निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु।
And just please wait, we will have a Tamil Thai world too as well.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ்வரத கண்டமிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறந்தியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you. Please be seated. We would like to start the meeting with the usual traditional lamping the light, and may I request Dr. Anand Moses and Dr. Asirvadam and our Lady Luck Bhavdharani. Come. Krishna and all my friends from the organizing committee. Please come. Thank you. We'll get started with the scientific program now. Um, Before going into the scientific program, I request all of you to rise and just observe 1 minute silence for the victims of the Falgam attack by the terrorists, which is a disastrous thing that has happened. I think we need to respect, let us respect all those victims that have happened.
So good morning to all. So it's time to move on to the first session for today. We have 3 interesting topics, and to chair the session, may I call upon Dr. C.R. Anand Moses sir as well as Dr. Ramanan.
Good morning, everyone. It's a privilege to chair the first session. I thank Dr. Vijay Kumar for this opportunity. And chairpersons have been given clear instructions. Do not introduce the speaker, do not introduce the subject. So we go straight away to the topic. I'm not even telling the name of the topic. I invite Dr. Hanish Gupta to the stage.
Good morning, everyone. First of all, very warm thanks to Dr. Vijay Kumar and the entire organizing committee of 3D Diabetes Discussion Dialogues for inviting me today for this session. Thank you, Dr. Moses and Dr. Ramanan, for introducing. And the topic that has been given to me is a topic which I believe that many of you have already heard, but I believe that I will try to give my own insights to this topic and bring some new flavor to your understanding as far as diabetes goes. The topic is hit hard, hit early, a proactive way to manage diabetes. I believe that all of us know that we have to start the treatment of diabetes for our patients in a very aggressive manner, and that's the way that we have been taught always. Since 2008, when the legacy effect and its every facet started to come out in the arena of medical science, we all started to do things in the way that science would have actually commanded us to do. So the idea here is that what exactly are we hitting at? When we talk about hitting at diabetes, what exactly a general person, a general doctor, a primary care physician, or any doctor at a senior level also, what exactly are they doing with diabetes? Primarily what they have been taught is that we have to hit down sugar. If we keep on hitting down sugar, we keep on achieving what we want to achieve in diabetes. But as we talk, the world has been changing dramatically, from biochemistry to molecular biology to genetic science, from population to ethnicity, and now we are talking about individual medicines for individual patients which are based on genomic sciences. From glucocentric to organ protection, and now we are talking about adding more life to years when patients are diabetics. From spot blood glucose sugar to HbA1c, now to glycemic variability and time in range. From drugs to therapies, now to precision medicine, for pharmacokinetics to pharmacogenomics, and from biomarkers to genetic makeup. This is a very interesting cartoon. I have never been able to ever overcome this cartoon. This is the story of You know, we all know the story of 4 blind men. And 4 blind men, they approached the elephant, and one touched the trunk, the other touched the tail, one touched the ears, and everybody had an interesting perspective to it. So one said that it's the muscle that is causing the diabetes. The other said it's the beta cell. The other one said it's the liver, it's the genes, it's the fat cell, it's the insulin receptor. And everybody had their own perspective on it. And we call them blind primarily because the real truth is that nobody ever has been able to come till now to know that what is the exact process by which diabetes is happening in the human body. If we talk about the therapeutic advantages in type 2 diabetes, in just last 5 years or so, more than 40 new treatments of diabetes have come out in the market. If you look at last 10 years, you would find that the progress which has been done in the last 10 years is actually equivalent to the progress that was done before in 50 years. So all these medicines, GLP-1 receptor RAs, SGLT2 inhibitors, DPP-4 inhibitors, their congeners, their way, how they function, and also the methodologies by which they are even functioning in non-diabetic patients. It's so exciting that we have actually changed the paradigm in which we were looking at diabetes in a very new wavelength. Despite the availability of numerous medicines, diabetes remains the 9th major cause of death globally. More than 50% still develop microvascular complications, 25% or more they develop macrovascular complication, and 1 in 4 people in diabetes, they develop CKD. So diabetes remains the challenge. Now, treating early with agents like GLP-1 receptor RNA, they have got benefits of multiple organ protections, and the legacy effect of the metabolic memory is maintained regardless of the later glycemic status. So like I said, whether it was the UK PDA study or the DCCT study, they all told us one thing, that if you are going to treat your patient suboptimally and not try to bring down the HbA1c, even for a loss of not bringing down HbA1c by a single %, which you could have actually managed, you are going to miss the chance to bring down myocardial infarctions and all-cause mortality by a high percentage. So you are actually increasing the risk for the patient throughout his life. So imagine that for the first 10 years, if the patient was not treated properly, not treated aggressively, was treated suboptimally, the type of risk that the patient is going to entail is going to remain for the life of the patient. It's not just going to be for those 10 years, but the entire life of the patient is going to get impacted. Despite modern evidence-based therapies, residual cardiovascular risk has still remained. So even if you are taking care of the best targets in the cholesterol of the patient, the blood pressure of the patient, the glycemia of the patient, there is a residual obesity risk, there is a residual inflammatory risk, there is a residual diabetes risk, or a lipid risk, or a thrombotic risk that is going to persist for the patient. And the funnel you can see on the left side, it is always going to filter out something which is going to create the complication. Now, if this was the only perspective that we have to treat the patient hard and we have to hit the diabetes hard and hit early, then I believe that I would have stopped my presentation of my slides here, because this is what sums it, this is what kills it, this is where we end. But the story is only half told, and I believe that Dr. Vijay Kumar has called me here because I want to give the whole perspective, the whole story to you as of today. So the story changes from here on, because we all know that diabetes is the leading cause of so many diseases, including kidney failure. Look at this picture, see that if the patient is having cystic disease or glomerulonephritis or hypertension, the risk is not as high as much as the patient is going to have the risk if he's going to have diabetes. Look at that black string at the top of everything, which is showing that more than 40% of the people with diabetes will finally develop CKD. And some of them require transplantation or dialysis. Now this other slide is even more interesting. This was done by a Korean guy by the name of Wen. And what did he say? He said that if somebody is having an early CKD, look at this. If somebody has an early CKD, his lifespan is reduced just by 6 years, only by 6 years. Somebody has diabetes, lifespan is decreased only by 10 years. But if somebody has diabetic kidney disease, that same lifespan, it gets reduced by 16 years. So even for a native kidney disease, the patient's lifespan is not getting as much affected as much it is getting effective if the patient is having diabetic kidney disease. And this is This is for both men and women, and the numbers do add up. What is pharmacogenomics? Now, this is a very interesting science that is coming up. Earlier, we had the same diagnosis, the same prescription. You come to me, you are a patient of diabetes, I look at you with the same vision, with the same prism, and there are going to be, the ideal situation would be the drugs which are not toxic, but the ones which are beneficial. Then there are drugs that are toxic, but they are not beneficial. Of course, they go out of the picture. We don't want such drugs, which are only toxic and not beneficial also. Then there are drugs not toxic and not beneficial. These are drugs which we all know that there are so many multivitamins which are prescribing. We don't know whether they are toxic, whether they are beneficial, but we keep on prescribing it. And drugs which are toxic but beneficial. Now, these drugs are the ones which will only affect some of the people. It's not going to be toxic for some people, only beneficial. And this is how the drug development is taking a new shape. We are not talking about ethnicities here, we are not talking communities here, we are not talking populations here. We are talking about a simple, single individual, and that is where the individualization of drug treatment is going to be the name of the game, because now we are going to have genetic analysis of each and every patient. And JIVA studies which are being done, that is genome-wide association studies, they are already underway, and they are going to give a genetic imprint for each and every individual that is going to come into your clinic, and they are going to have a genetic imprint, and there we are going to have the exact list of medicines. On what is going to enable this? Everything is going to be enabled by artificial intelligence. So looking ahead from 10 years from now, we see that type 1 diabetes and type 2 diabetes will redefine itself with endotype subtypes. There are going to be patients who are going to have genome sequence in their medical record. It's going to be polygenic risk scores with ancestry specific, endotype relevant, and a new generation of therapeutics is going to emerge with many new insights about the pathways which are going to be derived from genomics. But that is 10 years ahead of us. Right now, what are we doing? We are having the same considerations. We are having the consideration of glucose control, blood pressure control, lipid control, and one very important consideration with Western medical fraternity will not acknowledge, but it is acknowledged very much in our country, is infection control, especially UTI. Many of our patients, they get admitted in the hospitals. Many of our diabetic patients, they die because of infections. Somebody is having a community-acquired pneumonia which is not getting treated because he's having a sugar which was not under control, tuberculosis not under control because of diabetes, so many infections. Western populations, they don't have such problems, but Indian populations, subcontinental populations, they do have such problems, and that's why infection becomes a very important understanding in our paradigm. But still, even today, most of our fraternity is still glucocentric. They just want to talk about one thing, and that is glucose control. Let's talk about more and more glucose control. You bring down the glucose, this happens. You bring down glucose, that happens. Everything is explained by getting the sugars under control. But what is happening next is actually very different. Now we are having drugs, and this is a very important statement that I'm making. Two very important things have happened in the recent decade. We have drugs meant for diabetes which are not being given only to diabetics, and you know where I'm planning to go ahead with. There are SGLT2 inhibitors which are being given to diabetics and non-diabetics. And also in the recent market have been introduced medicines that do not control the blood sugar, and yet they are being given to diabetics. And we are talking about non-steroidal mineralocorticoid receptor analogs. They are not controlling blood sugar. They don't control blood sugar, and still they are meant for people with diabetes. This is something which is phenomenal. Drugs which were introduced in the market for diabetics, but not just given to diabetics, but also being given to non-diabetics, and drugs which are given to diabetics, but they are not meant for only for control of glucose. They are meant for something else. And that's why the new terminology that has come in is dual action. We want not just glucose control from the medicines. What we want is dual action of glucose control plus organ protection. If we do not offer organ protection to our patients, then we are just hitting hard, we are hitting early, but we are not hitting with the right weapon. That is very important. That is where the complete story comes. This is the paradigm shift in the approach. Earlier it was glycemic management, blood pressure and lipid control. What happened next? What was the fourth pillar that was introduced? The fourth pillar that was introduced was to give our patients agents which have got proven cardiovascular and kidney benefit. If this fourth pillar is not taken care of, is not paid attention by us in the present decade, then all the development, all the innovation that has happened in the past decade will just go to the dust. So we have to understand that this is a very important pillar in our understanding, that unless and until we are not giving our patients agents which have proven cardiovascular and kidney benefit, we are not going to help our patients with anything. Now this is evolution in science. To many people, what is creative disruption? We started with Edison's bulb. What was Edison's bulb giving us? It was giving us light. Then we came up with CFLs, that is tube lights. And tube lights were also giving us creative disruption because they stopped the use of Edison's bulb altogether. And finally, you see around yourself, your rooms are now lighted only with LEDs. Now, if somebody would come to me and ask that why are you giving this example in a forum which is meant for medical science, it is primarily been given because Thomas Edison's bulb, the CFL and the LED, they all provided light. They all provided luminescence. And same happens with other medicines also. Every medicine that is present in the arena of diabetes, it is bringing down sugar, just like Thomas Edison's bulb was also giving us light. Then why was it replaced by the LED? It was replaced by the LED because of certain advantages. And those advantages are what are creative disruption. So our job here today is not just to bring down the sugars of the patient. Our job is to give them a longer life, because now we have moved on even from organ protection to longevity. And most of the studies that you would find that are being present in the arena of diabetes, they talk about the number of years that are getting added to the patient's life. Another very important review article that came up was for the evolution of pillars of therapy to reduce heart failure risk and slow the diabetes disease progression. And this was by Dr. Bakris. And he clearly said that 3 pillars of therapy have slowed kidney disease progression by more than 50% to RAS blockers alone. And these finerenone and SGLT2 inhibitors, they are the ones that are the leading lights in this way. And these become the 3 pillars: RAS blockers, SGLT2 inhibitors, and non-steroidal MRAs, becoming 3 very important pillars that are maximally slowing down the diabetes kidney disease progression. Diabetes kidney disease is not going to happen in 10 days, 20 days. It's going to happen over years. And it's going to take number of years for the patient to realize, or even doctors to realize, that whether there is a benefit there or not. So if somebody comes to me and asks you that, doctor, have you seen any benefit? Then my answer would be, I have to see it for 20 years before I can tell you that I have seen benefits, because I have to give it continuously to the patient, and one day I will tell you that the patient did not land up in the dialysis unit or a transplantation unit or the cath lab. This is also very important thing, that you can see that the drugs that are getting introduced, they are being used for non-diabetic patients as well. A statement that I already made. This was not seen before the past decade. It didn't happen. The drugs that were introduced for diabetics were only meant for diabetics. They were never used for patients who were non-diabetics. But now that change is slowly and steadily happening. People are talking about weight management, weight regulation. I don't think so. It's a separate issue from management of diabetes. And because weight management is such a big cosmetic issue for many populations in this world, it becomes a very interesting proposition commercially. But my take would be that we should not discuss weight out of proportion of diabetes. We should discuss it together, and both these problems can be solved together as well. This is what personalized precision medicine is going to look like. Pay attention to this. Dexamethasone with GLP-1 receptor analogs. How it is going to happen? Why are you giving dexamethasone to the patient? Because there are certain subtypes of diabetes that are going to happen immediately because of autoimmune dysfunction. And in such kind of patients, dexamethasone is going to do a wonderful job, and we cannot deny that patient such an opportunity, because we have seen that some patients develop diabetes in a matter of 1 year or 2 years. Some autoimmune process is happening because of which their islets of Langerhans, the beta cells of islets of Langerhans, they're getting apoptosis immediately. And if at that point of time we know that there is going to be a genetic predisposition and dexamethasone is offered to these patients at the correct period of time, we may save them from actually developing diabetes later in their life. So before we conclude, we have to understand that future, as for the future, our task is not to foresee it, but to enable it. We, all of us, we are proponents of science. Whatever science tells us today, we have to embrace it. We have to go forward with it. We don't have to challenge it. We are not people who are going to foresee the future. We are the people who are going to enable that future for the many generations to come forward. This is the image that I want to leave with you forever. This is a doctor who's trying to save a patient's heart, kidney and brain and other organs also by giving water to the patient at the very early stage. This is a doctor who's trying to do the same thing, but he's got a burnt out disease. So many a times I come across people who say that, okay, I started this medicine, the patient came to me and I started SGLT2 inhibitor, the patient's creatinine was 4 and he did really well. I'm not that happy with that. There are doctors who also come said, okay, there was this patient who was nearing dialysis and I tried to start him on SGLT2 inhibitors and finerenone and he also did very well. Believe me, you cannot help a patient at this stage when the house is already burnt out. These drugs which we are talking about, which are adding years to the life of the patient, which are actually giving patients organ protection, they have to be started very early on. When the house is just getting the spark of fire, it's just starting to burn. When the house is already burnt out, medicines like SGLT2 inhibitors or finerenone, they are not going to have an impact on the patient. And this is my last slide, and thank you so much for your patient listening. I hope that I was able to change the perspectives.
Thank you. We have the discussion at the end of the...
No problem, sir. Thank you so much.
So next speakers, I request Dr. Krishna G. Seshadri sir and Samit Ghoshal sir.
I am Samit. I am Krishna and I am Samit also. Varda? Vandircha, sorry. Okay. Idarka hand mic ida. Hand mic illana ida. Those of you who want to join in, here is the integration. You can QR it and join in as we do, because originally Samit was supposed to join me and there's supposed to be a Jugalbanti. Then Vijay called me and told me you're only a Taniya Vartanam. So why not make it a Goshti, and therefore you can join and be part of it. If you just do this thing, it'll help you be part of it. Got it? Everyone got it? It'll be there even as we go on, but you can join here. The slide thing is not working? Okay. So I've sort of renamed this talk as Understanding the Patient Response to Your Care. A lot of time when we talk about patients being difficult, patients are not adhering, patients are not doing this, patients are not listening to what we tell them. It's a talk that we have talked about improving adherence, improving compliance, all of that. But a lot of times, we forget that there's another side to this whole story. So I thought in the next few minutes I will talk about that side of the story. So if you feel offended, please feel offended. That's the whole idea. Okay. Here's a 73-year-old man you're seeing for type 2 diabetes. He has diabetes for the past 15 years. He has seen 3 doctors in the past 5 years. He has come to you. Each of their notes says that he is non-compliant. Pleasant man, loving family, and multiple OHAs and insulin increased over time. So you see him, you talk to him, you simplify his regimen, write for tests. 2 months later, he comes back with his daughter who lives across the town. Sugars are still elevated, and then you ask him, are you taking your medicines regularly? Oh, how many of you have seen a patient like this? All of you, right? He gets very upset. No, doctor, இப்படிலாம் சொல்றீங்க. Right? Daughter starts crying that it's very difficult, sir. I come once a week. I live across a town. But he fights every day with me. If I ask him, I call him every night to see if he's taken his bedtime insulin. He gets very upset. நீ எதுக்கு எனக்குலாம் ஃபோன் பண்ணி இதெல்லாம் சொல்ற? Right? Okay? You can type, how will you improve the adherence of this patient? What will you do in your practice? Someone can speak, but the best thing is to use, it will come here. Anyone? What do you want to do for this patient? What do you think is happening? What do you want to do for this patient? He's got depression. No. How will you improve this patient's adherence? Reassurance, right? Anything else? So you reassure him, he goes home, comes back 2 months later, same. Follow up. You asked him to come back. You called him 2 weeks later. You asked him, are you taking his medications? He got angry with you again. Okay, you sent him to you talked to him about diet, you sent him to the dietitian. She gave him a diet chart, asked him to take 3 idlis in the morning, 1 cup of rice in the afternoon, 1 sundal in the evening, correct? Anything I missed in the boilerplate? Nothing happened. I put a CGM, okay. Explain the consequences, admission and treatment. You admitted him for 3 days, everything was fine. He went home, everything became this thing. Anonymous sent text message. He sent you back, but don't disturb me. Reassurance. Everybody is saying the same thing. Okay. I want to talk to you about this particular part. As you get older, everybody talks about age being a number. Don't believe it. These Instagrammers think age is a number. It's not. As you get older, your age is the surest way that nature says she is ready to recycle you. Right? As we get older, and diabetes has 4 parts here. Memory, learning, mental flexibility, and executive function. Executive function is one of the things that we really don't think about. That as people get older, their ability to problem solve, to understand complex instructions, to change old habits and start changing new habits, all differ. This is a person who has cognitive dysfunction, right? That is why she is being difficult. So the simplest thing is, a lot of times when we don't know what to look for it, we fail to look for it. So it is not a difficult patient, but a patient who is having difficulty. When you see patients who are suddenly going to 3 or 4 doctors, who have been model patients in the past, who have suddenly lost control, right? Lost a member of the family. Depression is one of it. But cognitive dysfunction is something that happens to all of us, a little more accelerated in a diabetic. So I just wanted to tell you that not every non-compliant patient is non-compliant. They have a problem. Fair enough? Good point? எல்லாருக்கும் coffee கொடுங்கப்பா. So my first lesson for care is, there is usually a cause if you care to look for it. I'm just turning everything around. A lot of times, we label people. We need to start thinking of different things. Okay, ready? Second patient. Here is, you're following a 64-year-old woman with type 2 diabetes for the past 10 years. Of late, her sugars are very erratic. HbA1c is around 9.5. She, however, complains of dizziness off and on. She denies any major problem. She takes her medications, including insulin, regularly. She has lost her husband 1 year ago. Her son now accompanies her regularly. He comes, he sits there, he is there with her. When you ask her, are you taking it, everybody, is there a problem home? She says, sir, my son and daughter-in-law take excellent care of me. I have no worries. What do you think is happening to her? What do you think? What is the next step for her? Please start putting into this. Okay, medications. She's not on a sulfonylurea, she's on a DPP-4 inhibitor, she's on some insulin, she is on an SGLT2 inhibitor, she's on metformin. Right? What else? Think. Think out of the box. Counseling. Sherry, you counseled her. The son says, "Naanga paathukurom, doctor. Why are you so worried? She's just lost her husband 6 months ago. That's why. Maybe she's not taking it." She's fine. What else? She's sleeping well during the night. Very good. So you asked her. She says, "Illa, doctor, Tukam is a big problem." Son says, "Will it be very addictive, doctor?" No. It's all right to give a hypnotic. Let her take it for some time. She's gone through depression. You gave her the medicine. But the same thing has happened. Counseling for her daughter-in-law. Okay. You wanted to die or what? The daughter-in-law is a very sweet girl. She comes with, once in a while she comes, she waits outside. The son comes and sits with her all the time. But nothing obviously seen. Evaluate for hypoglycemia. You put a CGM, I'll tell you what happened. Good question. You should evaluate. I'll talk about. Poor drug compliance. Well, that is a symptom. It's not the... See, remember, poor drug compliance is a symptom. It's not the diagnosis. Right? Let's think a little differently. You ask for a CGM to be placed. She comes back 15 days later and then the CGM came back when she said, "Sir, CGM போட்டேன் அது வெளில வந்துருச்சு அதனால வந்து இன்னொரு வாட்டி வாங்குறதுக்கு we weren't this thing. The CGM is not working, doctor." Have you heard this before? Yes. As you see her, you examine a small gash in her elbow. Exactly. Remember that I won't go what is happening to her. He gave me the right answer. She lost her family. Elderly have several problems, and people who are vulnerable have several problems. One is depression, right? Depression, severe depression cause it. People have, every year there is, you know what UAS is? When I first started coming from India to US, I would be the only person in the business class from India. From round about the 2000, you will find that lots of, the Lufthansa would become the Mami service. In India, it is called unpaid IR service. People will go, they are like summer birds going to US. Why? Because during the summer when their children are on leave, these guys have to provide daycare services. Okay, will your son, "Sir, give me 6 months medicine, sir." Anga poi test pannuveengla? No, sir. There everything is expensive, sir. I asked them, what will your son pay if he is paying for a babysitter? $16 per hour, sir. So ask him to pay $16 per hour to you and at least go to a Walmart or Walgreens and get your sugar checked. Illa, doctor. Adlan kootit po matanga. They go for 3 months, stay from morning to evening, and once a week with everybody they will be taken to a restaurant. Once a month they will go to a temple. This is all that will happen. But here it is even worse. Today the family system is broken. This woman has been beaten up by her, not by her daughter-in-law, but by her son itself. Elderly abuse is not unknown. People's life changes, they become vulnerable. Always find out. We only listen, we will understand it. What I'm trying to say is, before you label people as compliant, non-compliant, adherent, non-adherent, look for a pattern. Right? Second, many people, they have spent their entire money paying for their kids' education. Now, the moment they are retired, they don't have money to buy drugs. They'll say, we'll go to chief minister's or prime minister's thing. There also now local corruption has happened. They get substandard medications. Correct? Many do not take their medication, not because of that. They have lived well. Now they can't. And they have difficulty telling their family. Many times, they live alone. They are not able to cook a meal. They have to get food from outside. So life is tough. Life is not just diabetes. Diabetes is a part of life, but life is something else. So, my second point is, life can be cruel for the vulnerable. Before you label them, recognize it. This is an extreme example, but I promise you there are enough examples in our own lives. If you ask people in this hall, there will be 1 or 2 examples of these happening. How do I treated it? Well, I took her into our examination room and I asked her, is something going on? What is happening? Dara Daraya Kuttal. Then, does your daughter treat you well? Yes. Can you call her? She called her daughter. She now lives with the daughter. The daughter took her home. Here, eppadi doctor vandu ponnu veetla poi irukkuradhu. The son is undergoing counseling right now. Okay. A 40-year-old woman approaches you for inability to lose weight. She is a HR manager in a local company. She has irregular menses. She's single. BMI is 34. Her screen time is around 9 hours per day. She lives alone and has to eat out at least twice a week. HbA1c is 5.8. You discuss lifestyle with her and she rolls her eyes. You add metformin and say she can come back in a month and we can discuss other options. All of us do this, right? She retorts, this won't work, doctor. You don't understand. I've gone to 3 doctors already and they all think I'm lazy and don't try hard enough. I thought you would, and you belong to the same group. Have you done this? Every time the patient will say, "Illa doctor, I've tried. No, try some more lifestyle." Well, lifestyle has become, lifestyle. What is lifestyle? They live this life, right? Let me tell you something very interesting. What should you do for this patient? How do you respond to her? Let's get some answers. I have a few more minutes. Right. Let's put it here. Get a thyroid profile. In the weight thyroid profile, we should stop. Very rare. Hypothyroidism is so rarely a cause of obesity. Don't do it. Where are you? Anything else? Huh? Correct. Ask her to stop eating, then she'll go to another doctor. Vama, பக்கத்துல உட்காந்துக்கோ. நீ சொல்றதெல்லாம் எனக்கு புரியாது. I understand. When you can never put yourself in the patient's position, correct? What are you going to understand? You don't even understand your own wife. How will you understand her? Actually, you don't understand your own wife. That is. Don't waste time. Why would you not waste time? Okay, blame the hormones also. Next. What I really wanted to tell you is, a lot of times we think change of job, reduce carbs, increase proteins. Have you been in somebody's position? Why are they in the job? Not because they want to be in it. They have no other way. Again, we think those 10 minutes in our clinic is their life. It's not. There's life outside the clinic. Okay. Somebody's had a fracture. Okay. Will you tell them go do weight bearing without providing a crutch? Let us take this example. Somebody comes to you with a fracture. Will you tell them exercise? What will you do them? Give them a crutch and say, okay, let me help you heal a little and then. So my paradigm is, when do patients need medications? When they are suffering the most. I flip this paradigm. I give them medications first, help them lose some weight, and that motivates them to change their behavior. What we do, we shame them. இல்ல நீ சரியா சாப்பிடல, இல்ல நீ எக்ஸசைஸ் பண்ணல. That doesn't work, right? I'm being a little extreme, but understand that we need to stop this saying when they're coming to you because they've already paid 5 celebrity nutritionists their entire property. Today, the other day I saw a patient who was in Dubai. I was about obesity, and he said, "Sir, I have, you know what does a celebrity nutritionist in Bombay charge for these people? 3 lakhs. Turnkey, 3 lakhs." So, what I do, I put her on medications. Let her lose weight and she will notice that there is a change. And then, instead of saying, this is what, I'll just show you in a minute what I do in my practice, is maybe useful for you. We use instead of telling them what to do, we work with changing their behavior one step at a time. At the same time, making sure that they are not this thing. So the medication shows them the benefit, and then at the same time work on their lifestyle, right? Some reminders. There is evidence. When there's evidence, doctors don't trust the evidence. That's why we keep on going back to the old Panchangam. Panchangam is only for 1 year. After that, you have to change it, right? As new evidence comes, we must change the way we treat. Talk the evidence. Tell them what happens. Show them the evidence and walk the talk. Second, udane we talk about cost. Let me tell you something. Most patients who need it will spend for it. But you need to determine, do they need it? And I will tell you, if they come to you, it's usually because they need it. Because they don't come to you unless they need it, right? The most cost-effective way to practice medicine is to do the most appropriate thing first. Second, here is my favorite, this is my own quotation, you can please copy me. Life is not Instagram. Only a narcissist can have the perfect lifestyle. There are people who every day, Instagramல வந்து ஒவ்வொரு ஆங்கிள் அதே சொட்டையை தான் போடுறான், right? Instead of focusing on lifestyle, focus on behavior. What are some things you can change? Can you increase the number of days of cooking? Can you reduce the number of days that you're eating outside? Can you make sure you don't buy namkeens, it is made of palmolene? Can you reduce it slowly? You have medications to help you focus on behavior. Ultimately, it's easy to lose weight. It's easy to bring down your sugar. But to keep it on, you need to change behavior. So instead of focusing on lifestyle, focus on behavior. Then, lastly, I think, we should stop judging people. We, doctors who have sworn to help people, many times label our patients. I'm going to put 4 things that I'm going to say. One is, failure to cure is seldom viewed as failing on part of the physician. Failure to provide support is. Even if you can't cure, when you provide support, patients understand. Second, the secret of the care of the patient isn't caring for the patient. Francis Peabody. This is Albus Dumbledore. I like this. Words are, in my not so humble opinion, our most inexhaustible source of magic, capable of both inflicting injury and remedying it. A lot of times, we need to choose words what we use. But the most important word we need to use is, I understand. Or, I may not understand, but I'm willing to listen to you. Lastly, this is what? Did I listen to the patient well? Is a question that we need to always ask before we label patients. A lot of times, there may be a lot of faults on that side. They are human beings. But we fail because we don't understand our mission. So, lastly, the last lesson is our attitude determines the outcome. It is not anything else. The way we approach patients, our attitude determines the outcome. So, here is the last thing. What would you change about yourself after this? Share it with everybody so that please write down what you think you should change about yourself. And that is a good way to start this conference. Thank you. Please write. So, again, thank you so much for this opportunity. I really, really appreciate it. Thank you.
Thank you, Dr. Krishna, for your thought-provoking lecture. A lot of interesting points, lot of carry-home points for your practice. Thank you. Probably we'll have some more time during discussion. There is a small change in the topic now. Change in the topic and change in the speaker also. Dr. Sanjay Agarwal is not going to be here now. So instead of that, we have Dr. S.R. Arvind from Bangalore. Can we have his introductory slide, please? Is there any introductory slide for the speaker? He is going to talk to us on management of diabetes in primary care, challenges and solutions. Yes.
Yeah, thank you, Vijay, and thank you, Anand. Kannan, lovely to see you after a long time. And after two totally different types of lectures, the third lecture is going to be a little different. Okay. When this topic was given to me by Vijay, the first thing that I asked him was, what exactly you want me to speak? Then he told me there are a lot of issues. People are concentrating only on the medical management, even though it's not possible in primary care sometimes. I want you to put yourself in a position where you probably go to a village and you have nothing to treat. Okay. Happy to say that I'm a product of the Chennai medical education system. I was here, spent some time at CMC, spent 1.5 years at Chennai, learning under Professor Vishwanathan, and spent a lot of time with Dr. Moses, Anand's father, and then probably many of the seniors who are here. Well, we had only Dianyl, we had only glyciphage, we had plain insulin, we had lenti-insulin. So it was kind of easy for me to actually prepare this lecture. Okay, let's just remember one thing. This is something that we have to remember today. It's multifactorial, influenced by genetics, lifestyle, environment, socioeconomic factors. Each patient is going to be different, very difficult to generalize, and I was very happy, even though Krishna's talk was a little bit philosophical, each time you spend a little time, you try to pick up something new. Okay, let's also remember diabetes is not just blood sugar. Diabetes is going to be web of complications. And we know about these complications, so I think you need to be a Spider-Man to actually tackle, because you are doing a number of things. Comprehensive care is what we have been talking about. And this is the ICMR study which Dr. Mohan published, and we know the numbers. It's much higher than what the IDF Atlas of 2025 actually tells us. Yes, 101 million. The problem also is pre-diabetes, 137. A simple little statistics to many of you, most of you may know it. Every sixth person living in this world is an Indian, in the entire population of the world. Every sixth person is an Indian. And every 12th Indian living in India has diabetes. And this is the kind of a data that we are looking at. It's a huge burden. So when we talk of primary care, we must remember this is the kind of a burden that we are living in. And 67% of our people live in the rural areas. A very small number actually live in cities like Bangalore, Chennai, and things like that. So if you look at the data, if you look at the statistics, if you look at the burden, I think even the Spider-Man says, okay, I think I just would like to give up. Okay. So I think there's a huge task, right? Now, primary care and challenges, let's look at it from all the sides. Okay. Well, you can look at it from the infrastructure. Oh, I don't have the right infrastructure. There are issues with the doctors. There are issues with the patients. Oh, we love to complain about everything, except to accept we have failed to treat this patient. And I kind of like Krishna's talk basically because we need to recognize, as doctors, we have to become humble, we have to become human. There must be a cause, otherwise I don't think the patient would have not done well. So there are issues, nobody is saying there are no issues. You have to look at it probably from all the angles. So let's say we have a 3D look because it's a 3D conference. Well, these are the problems. Problems with doctors, problems with infrastructure, problems with numbers. And at some point of time, most of us, what's happening is we all have our own lives. You know, we will end up thinking, what am I doing here? Let me just make money. Or many of us feel, I wish I was an engineer, settled down in US and then not worried about all this. Okay. Now, just quickly let's go through, I mean, there are hundreds more reasons in the rural areas, right? We can talk about all these points. Oh, there is no education, I can't educate the patient, there are misconceptions. Yes, it exists. Non-adherence to treatment plans. Oh, they can't follow diet, they can't take medications. No, they have financial problems. No, my PSC is 50 kilometers away and they can't really come there because there are no bus stops. Yes, every one of them here. And I could have put another 20, 30, 40 more reasons. I'm sure all of you will add to this. Now, there are also problems with the doctors and the infrastructure. Let's accept this also. The shortage of trained professionals. CME is concentrating more on, okay, what was yesterday's lunch? Was it Andhra-based, Chennai-based, Bangalore-based? Inadequate CMEs, burnout, stress. In Bangalore, I don't know how it is today, endos are actually practicing in 3, 4 places. It's becoming tough because gone are the days when, you know, you stick to your dobi, you stick to your barber and things like that. I mean, there are clinics everywhere, there are malls everywhere. People go to the nearest place. And the problem we also face with the doctors and infrastructure is team-based care is not there. Limited resources, data management extremely poor with the patients and doctors. Well, power cuts, shortage of medication. I mean, you can go on and go on and go on. Okay. Now let's come back to 2022-23 onwards. And if you are seeing a person with diabetes, if you are serious about treating him with whatever resources you have, remember, diabetes is turning out to be cardiometabolic, renal, vascular in approach. And these are the 3 eras, and we are in the 3rd era. We are in the 3rd era. You cannot differentiate, most importantly, a rich person with diabetes and a very poor person with diabetes. We are in the 3rd era. Now, this is exactly what the IDF told me. 2025 IDF meeting at Bangkok had a lot of issues. You know, people were saying the talks were not good, this was not good, that was not good, people not there, etc., etc. But one of the important things that really came out of this IDF recommendations and guidelines is look at a poor person, look at a rich person equally, because both of them have diabetes. Okay, do not differentiate in the treatment. Okay, you can still control diabetes with the very, very inexpensive medication as long as you do this. And if you look at this one, just read only the right side of it. What they have said is, basic care is the birthright. So basic care itself has to be evidence-based. I mean, there were a lot of arguments. There were a lot of discussions. No, I cannot give the optimal care. What is basic care? You looks as if the basic care, optimal care is turning out to be the same. So much so, I completely agree with many of the people who discussed. They also said, okay, you can base it with your respective country, your respective region, take individual decisions at that. The only thing that also kind of shocked us was Try to do HbA1c where we know we can't even do blood sugars. But then again they said, look, there is nothing that tells us how the diabetes is going. So do not differentiate between optimal care and basic care, but try to see how you can do the basic care in your primary care setup. We don't have to follow these recommendations. I can tell you that also. You may not have ways to do a HbA1c, you may not have the best method. But what really surprised me was, including even a CGM, which we don't do, but we were told it's absolute practice now in UK and many of the European countries and also Australia, where the treatment is free. Okay, in certain things we differ, but can we give the best of primary care? Well, huge number of people not diagnosed. Okay. Now, if you think that you can actually have a good PHC, it's not going to happen. It's impossible to have a good PHC roadmap in India because health is a state matter. You cannot bring the central government and the state government together. It's very, very difficult. I mean, and there are a number of improvement roadmaps. Now, can we have diabetes clinics? Can we have Namma clinic? Can we have this? Can we have every 100 kilometers a diabetes clinic? I think it's going to be very, very difficult. Every 100 kilometers, India is changing. Language change, behavior change, religions change, everything change. And look at the population, 1.464 billion, and 69% of them live in rural India. Also, don't forget, they will not see a doctor, they will not take the medication, but they have the best TV at home. They have a lovely mobile phone at home because that's entertainment, without which they can't live. Taking medicine is not the priority for the rural India. Seeing a doctor is not the priority. Their mobile phone and a TV and a good two-wheeler and then cars. So how the mind behaves is something that we have to understand in the rural thing. I was actually running a clinic for the slum people in Bangalore for 10 years. And suddenly we realized that people have stopped coming. That's because between 10 and 1 in the morning of a Sunday, we would go only on a Sunday, we would go with a team of doctors, everything was being done. Genuinely poor people. The TV started showing 2 or 3 movies continuously in Kannada, Tamil, English, Hindi and other things. So these people said, can you people come and see us in the evenings? Because we don't want to miss the movie. I can't go to a theater. That's when I realized we also have to look at the priorities of the people, and that's how the mind works. And I'm sure Dr. Sanjay Reddy will be talking about the mind, the body, the diabetes. So I think all sides of it, we are going to realize that India is a great country, right? There's nothing wrong about the country. It's just that each one of us are different. So when it comes to treating, it's going to be difficult. This is what I was talking about. You will have all the slums, but you will have the mobile phones, Mera Bharat Mahan, and we are going to say. Now let's come back to the question. What do I do as a doctor? I'm not put anyone else in the position. I was just thinking, okay, what will I do? Small town, village setting. Well, I'm not that dark, but that was a beautiful AI-driven photograph that I got. But then it sends you the message. I have only a glucometer and a BP meter. That's it. What I'm going to do is check fasting, postprandial, both if possible. If it's not possible, I'm not bothered. I'm just going to check a random blood sugar because I don't know at what time the patient is going to come. I'm going to sit, educate, ask them to come before food, something, whatever it is. Most importantly, I will also check the BP. A good clinical examination for foot to diagnose neuropathy and PBD. You just don't need any fancy equipment. My biothesiometers, my everything from 1991 is collecting dust. All the PGs are told, just use your hands, you can pick up. Maximum you need is probably a hand Doppler in small cases. Everybody agrees? Neuropathy is basically through ruling out the other causes. I know somebody will say alcohol, B12 deficiency, spinal problems, thyroid. But then at least with a good clinical examination, neuropathy and PVD can be diagnosed. Okay. Most importantly in the rural area, probably primary care, I think I would talk about foot care. The genital hygiene is, the more I see patients today who are not circumcised, especially on the male side, the more problems we are seeing. Ridiculously high amount of people have balanitis and phimosis and they have no idea what we are talking about. If we are serious about the cardiometabolic shift, if we are going to be using a lot of SGLT2, I think it's worthwhile spending a little time on trying to teach patients what is genital hygiene. So foot care, genital hygiene, two important things in all our patients, men and women. Basics of the diet. I'm not going to give a questionnaire that Krishna showed you all, your likes, your dislikes, how much of carbs you take, what do you take, etc. I'm not even going to ask them. I will just tell them, please reduce your portion size. If you are having 3 idlis, try to make it 2. Anyway, whatever you're going to tell him, he is not going to follow it. Okay? Only you're happy at the end of the day that you have put in an effort. So the best thing is, please, reduce it. Reduce the quantity, and this is what your sugar is. I think the portion size reduction is one simple way of telling our people you are eating a little more. Now coming to the medication. Okay, I would definitely look for a fixed dose combination if available, only for one reason. If you increase the number of tablets, most of these people, they don't like it. They think that diabetes has become serious, something is wrong, or it will damage the kidney. I would probably look for an FDCF and SGLT2, DPP4, metformin. If it's not available, it's okay. We can always give them separately. All right? And trust me, a small dose of ARB is not going to reduce the blood pressure drastically in any of the patients. I would close my eye and then put them on a small dose of 20 milligrams or maybe telmisartan and statins. I would not even worry about checking their lipids because 96%, we have done Cindy, we have done many trials, 96% of people with diabetes in India required statins. Statins have taken over. Close your eyes, start statins. Don't even have to bother. That's the only drug which reduces cardiovascular risk. Well, I put the word CCB only if the blood pressure is high. And if you look for a combination, you are getting combination. Why? People suddenly ask the question, oh, this is not rational, this is irrational, why India is coming out with so many FDCs? I fully agree with all the things. Okay, if I'm talking in another conference, defending, not defending FDCs, I would probably have points. But then, in a country like India, if you're treating in primary care, if you're seeing it's better. I have seen this happening. A patient doing extremely well on an FDC combination gets the card from ESI and says, sir, can I go get the drugs in ESI? Yes, he goes. 3 drugs, unfortunately, become 3 different drugs. 1 pill becomes 6 pills, and the patient is very confused because ESI has only those supply. Even though they tell him, this fellow is my watchman, he doesn't understand it. So he stops taking the medications. So this is what I would probably do. We'll look at FDDs to reduce the pill burden and the cost, and after starting drugs which will not probably cause hypoglycemia or weight gain, if the sugars are still high, probably I will look for sulfonylureas, maybe basal insulin if the sugars are high, and spend time discussing all about hypo, self-injection technique. Try my best to tell them, okay, keep it in a cool place, insulin is okay for about 3 weeks. Well, if the infrastructure allows, what else do I need? I think the first thing I would pick is, if you want to evaluate for complications, there is one thing. If you don't know how to do a fundoscopic examination yourself, I would probably use for a fundus on phone to diagnose diabetic retinopathy, AMD and glaucoma, AI based. Still costs only 2.5 lakhs, no electricity, no Wi-Fi, nothing. Outbeats 90% of the best of the ophthalmologists. Tested at Shankar Nethralaya, Arvinda Nethralaya, Narayana Nethralaya, everywhere. And now, except FDA approval, this has already got an approval. Then, gastritis versus chest pain related to MI can always be a problem. If I am in a small place, I would then put in an ECG machine. At least it will tell us by taking an ECG whether it's an acidity or probably if I see some changes, I can probably refer them. Now, two areas where people are usually scared coming from floor spaces is death and blindness. I went for these two only for that. Now, because when you refer a case and say you're going to go blind, please go see an ophthalmologist, they will run. Now, when you take an ECG and then if there is a problem and if you say, look, you got a heart attack, you will die, then they will go. These are the only two cases where people are scared. And when you refer, they will go. Otherwise, casually tell them that, okay, diabetes affects the eye, you please go and see. At that point of time, his eye has no problem, so he will not go. Right. Lot of times it has been discussing with our minister, Jitendra Singh, who is part of RSSDI, still a friend, and he also says, PHCs are not going to be the solution. Diabetic clinics across India is not going to happen unless some entrepreneur comes forward and then says a PPP model and starts giving ideas to the central government. PPP will work, 50% from the public and 50% from the private. Somebody has to come out with it. Somebody has to say, okay, what is it that I need? How do I share a little bit of profits? PPP for free service, no, this is not going to work in India. PPP with a small philanthropic outlook, maybe a little margin to take care of the doctors. Because we did try diabetes clinics in Karnataka and a few PHCs. We impressed upon the government to actually fix a salary of 1.5 lakhs to the doctor, gave a nurse and an educator, gave a house to that particular doctor to stay, to run a diabetes clinic as a pilot project. What happened was the doctor did not stay because electricity and water was always a problem in that small little quarters that the government has allotted. So we have all kinds of problems happening. So PPP models are easy to talk about. We can talk about it for years. But somebody has to come out and say, okay, this is what I'm going to put up and let's see what's going to happen. So thank you so very much. It's been 35 long years working in diabetes and everything that all the previous speakers said is right. There are a lot of problems and then solutions are a little, but I think we should just move on. Treat every patient to our best ability. Okay. Never chase success, because success is for others to see in you, but most of us are trying to chase success and money. I think work to your conscience, work to your satisfaction. Everything else comes running behind you. Thank you so very much.
Thank you, Dr. Arvind. We have some time for discussion, so I call all the three speakers to the stage.
I think the first two speakers will have all the questions. I don't know how many questions I will have. But
We have about 15 minutes time. So Dr. Gupta, we had 3 exciting lectures, you know. The first one was a hit hard with all the available drugs. Probably in a setting with good resources. Then we had the other end of the spectrum. That is a basic model going right to the village. How we are going to. And Arvind, your model was almost like a diabetic clinic in the city with everything. Your village model.
Village model was
Yes,
okay. Thank
yes.
you. I can still remember one thing. One of the camps when Dr. Sheshaya took us out, JDM camps, and I remember your father also being there, and I can say it in front of this crowd, there were no glucometers. There was no way a pregnant woman could actually test her blood sugar. So we would start her on this one. I said, sir, now how do we monitor? We know the target. They don't have glucometer. Everybody would perplex, and then your father came out with an idea and said, just keep increasing the insulin by 2 units both the times. When the hypo occurs, ask them to stop it. And again, wait for 3-4 days. Keep increasing the insulin by 2 units. Let them not worry. Because as the pregnancy advances, the dosage of insulin advances. Then somebody asks, sir, low sugar, sir, the fetus can. You don't have any other way. Best outcome of pregnancy, ask them to keep increasing 2 units till they have a hypo, and stop. See, many of these things comes with kind of a practice, and then you keep doing it. But then you can't talk about these things in an open this one.
No, what I meant to say is there's a big divide, whatever it is, between
divide?
resourceful setting, patient gets the best of treatment. In a low resource treatment, still most of them are denied the best of treatment. And there should be some compromise in between, which has to be worked out, which you said the government is trying to do something.
See, the problem is health is both central and state government when it comes to individual states. See, Kerala government has now taken up with this one, that fundus examination and this FOP using AI is free in Kerala. Everywhere they can walk in. Now Tamil Nadu is trying to bring in that. But you can't ask all the states to follow the same thing, because this is the problem that we face in India. It's very unique. You can have solutions, but then it's difficult to implement the solutions.
The topics are open for discussion.
A lot of evidence about SGLT2. So can we start SGLT2 as a first-line therapy? And in primary care or PHCs, they're not giving SGLT2s. They're stopping with, in my state, with DPP-4 inhibitors. I think if we can convince them and give these, I know the contraindications and problems with this, but whether we can prevent in the future all the complications. And I'm also interested to know what will happen after 1 or 2 decades, because we are using SGLT2. So we can see very less number of CKDs.
Okay, I'll take the second part of your question first. Well, what will happen if we use SGLT2 after a few years? I don't know. Both of us can live that long to see what happens. But right now, the evidence says nothing happens. It helps the best. Okay. 2, you have to start an SGLT2, whether the government is giving it or the PHE has it or not, because that's the only proven drug to reduce your cardiovascular renal risk. Okay. So if you are a conscious doctor, you will ask the patient to buy it. Now, the generics have come. Okay. Empagliflozin, Lina is available for a ridiculously low price between 8 to 12 rupees. Okay. Now, if the patient is PHC is not giving it, you must ask him to give it. Well, DPP-4 works only if there's beta cells. Do they really work after 5 years, 6 years, 7 years, 8 years? We don't know. Okay, so I don't think we should just start with the DPP-4 and metformin. Start with 3 drugs, but others can join.
Can I just ask a question back? First is, every time I hear this thing about PHC, I understand all of this. But I think somewhere we doctors have forgotten that India has moved away from a country of extreme poverty. Extreme poverty, just the economic figures released yesterday, and this is multimodal economics, not just this thing, is 2.8%. It's just 2.8% from where it was in 1990, right? Poverty itself is less than 27%, meaning people who can't afford a basic house but live in rented, all of that. Second part is 94% of care in this country is given not in the primary healthcare setting but by private doctors in various parts of the country, right? So actually, I believe that government should get out of health. Please, you can disagree with me because they do a poor job. Instead, they should provide domiciliary insurance and give doctors the money and say, you provide the health care and we'll pay you. It's a much better model. It's worked with, in Andhra Pradesh, Arogyasri works exactly the same way. You go to any hospital, you get it done, you're uploaded, the money pays. It should happen for domiciliary because then these resources will get used much better, doctors will be accountable, and the care will be better. Third, the real truth is, unless there is a value for it, it will never be appreciated. When you give something free, it will be taken home and put in a bottle and never used. Its value is never known. And today in India, when you go outside and eat 3 idlis and 1 vada is what, 40 rupees? This is how it is. Sometimes we should stop. I think we are overplaying this poverty game. There is a courier service available in every village in this country except maybe in the extreme periphery. If you want to send a HbA1c, the actual cost of an HbA1c to do is what, 60 rupees or less?
The best method would cost about
100 rupees. Once in 3 months, you can courier an HbA1c. Somehow I feel, I'm sorry, I may be completely wrong. I feel that we are trying to sort of find excuses for non-performance. The truth is, we are no longer, I have great respect for all our stalwarts, but the time where they worked and the time that we work today are completely different. Their solutions cannot work today. Our patients should demand the best and get the best. My view is, the most cost-effective way to practice medicine is to do the most appropriate thing first. The patient has the right to say, look doctor, I can't afford, give me a cheaper alternative. But I think the doctor should tell the patient, according to what I know, this is the best drug for you, will you be able to take it? I'm sorry if I gave this other side of it, you can counter me on this, but I think our job as a doctor is to tell the patient, these are the options, these are the costs, what would you like to do?
So regarding your question about SGLT2 versus DPP4 inhibitor, DPP4 inhibitors always being more popular than SGLT2 inhibitors. So the crux of the matter is, sir, that it's the adaptability and the inertia of the doctors also that plays a great role. If we go on a basic scale, medicines which are being practiced right, center and left, there are in every field, sir, in every field there are people who are early adopters and then there are followers. So some people would be very fast to adopt new therapies. For example, now Mounjaro has come. Already in Delhi we have got 2,500 Mounjaro prescriptions which have already been generated just in the first 2 weeks of getting prescribed. So there are certain people who will be picking that lead very quickly. And there are certain doctors who would be following that lead regardless. In SGLT2 inhibitors, it's a no game, it's a game changer molecule because it's the only molecule that established the concept of cardioprotection. It's the only molecule that has given us more organ protection than any molecule that we have ever seen. It's a molecule which is on the prescription of the nephrologist, of the cardiologist. It's the molecule which has brought so many cardiologists, nephrologists and diabetologists on the same podium. So, and the number of studies that have been done, whether it is DAPA or whether it is empagliflozin, the number of studies that have been done by this molecule has been phenomenal. The problem is that what we are discussing right now, it's not just with the patients, it's also that we are not a homogeneous population even amongst doctors. So when programs like these are happening, what is happening is that the dissemination of knowledge is very crisp, it is very fast. And we are able to bring down the evidence to the last mile. We want to bring that evidence should be available to the last practicing model, to the last practicing doctor in the fringe of the village where the CME is not happening. And if they are coming over here and we are able to present that evidence to him, probably we'll be able to increase their confidence in prescribing the molecule. As far as SGLT2 inhibitors are concerned, excellent molecules. They are molecules, I believe, that they should be on the prescription from day one. That's my take on that.
Do you think guidelines will change metformin instead of metformin SGLT2?
Very difficult to answer, sir, but yeah, there are certain segments of the fraternity that are saying that metformin is not that great a option anymore.
Thanks.
Sir, my question is simple, sir. I ask Hanish Gupta, sir. Sir, you said you projected a cartoon, burning house and burnt out house, but most of these SGLT have been studied only for the burnt out patient, not the burning patient. I would like to comment on this, and Krishna sir can follow that, sir. Thank you, sir.
Excellent question, sir. Excellent. Because you are talking about EMPA-REG study. EMPA-REG study had all the patients. All the studies.
Kidney, heart
Yes.
failure, all the
Starting
studies.
with EMPA-REG study, yeah. So you're absolutely right. So the take on that was that it is able to bring down the mortality benefit because the patient was already very near to mortality. So we were able to bring down the mortality benefit as quickly as possible. But at the end of the day, sir, we do not have to forget the fact that the medicine was actually introduced in the market for diabetes. Now, if the medicine is able to bring organ protection in the late stages where the organ damage has already happened, think about it that if it is started earlier in the course of illness, the type of organ protection that the medicine is going to bring out is going to be phenomenal. And there are studies of projection,
But
which is...
my
yeah.
question is, can we extrapolate that to the burning patient, sir? Because that has not been studied. So we can't take what has been extrapolated to established CV even patient, cannot be extrapolated to the naive patient who is sitting to us, who is burning. That is my question.
So,
sir. Are we interpreting science in our own way?
We'll have an interactive thing. Do you believe that organ protection happens with SGLT2 inhibitor like empagliflozin?
Absolutely, it happens as per the science in an established case, but not before that, sir.
So, do you believe that there is a risk for the patient to develop organ damage in diabetes?
Yes, sir.
That's why risk mitigation is happening, sir. We have to go for risk mitigation now.
So, Gauri, I think we had this discussion many times. You're right, right? So, we'll go by the evidence. SGLT2 inhibitors do not have data to support superiority in somebody who does not have extreme high risk or established CVD. 150%, that's right. It has benefit in prevention of progression to DKD in somebody who's A2, G2 and above. Has evidence across the spectrum in prevention of heart failure. Fair enough. The only thing that has been shown to prevent progression of diabetic complications over a period of time in the Swedish obesity subjects in any of the trials is either loss of weight by 10 to 15 kgs or metabolic surgery. In primary prevention data, the Swedish obesity subjects, the others, we have some data. You're absolutely right. I have no problem with what you say. The GLP-1 on the other hand, in the AWARD trial, have data for both primary as well as secondary prevention. Is this a burning or the burnt out? I think the answer is there is data in burning also for some of these outcomes. So I would not take that extreme position, but your point is well taken. And you're never going to get a study looking at primary prevention. Let's also get this clear. Why would a company invest in primary prevention trials when it's going to take 8 years to show the benefit? It won't happen. Or much longer. So ultimately in medicine, you have to make the jump and extrapolate and say, okay, I need to take care of his diabetes, but I know that over a period of time this will help him. Therefore, the benefit. So just to go by RRs, the RR for someone whose baseline CV risk is less than 8%, right? In primary prevention will be only 7.8% total, 0.1 to 0.2% with a SGLT2 inhibitor. So the lower the risk, the lower the odds ratio of benefit, right? So there, but if would I choose an DPP4 and SGLT2 inhibitor? I would choose an SGLT2 inhibitor simply because there is the added weight loss which itself confers the benefit. That's all. Got it?
Sir, in continuation of this same SGLT2, sir, what is your take on this molecule when you give to a person with a pre-diabetics or early diabetics?
There's no data.
Because there may be no evidence, but still I feel that is a good molecule. You have shown the figures, 136 million for pre-diabetics and 100 million for diabetes. And you know for a well-known reason that this is a big mischief maker in the pre-diabetic stage itself. Then why not you give it, sir? You still want to wait for the ADA to endorse this?
As Dr. Krishna said, of course, there is no data, therefore the doctors are skeptical. But if you see a pre-diabetic who is a little overweight, and if you give it, I think there is absolutely nothing wrong. You can definitely give an SGLT2 with metformin or only SGLT2 in a pre-diabetic, and then talk to the patient and say, look, I'm giving it to you for this reason. Okay. If you ask for data, if you ask for evidence, we may not have it. But individually, you can definitely do it. And you have all the right to do it. And probably you'll be right in doing the right thing.
Sir, I've been giving this molecule for the past 5 years. I have yet to see a complication. People do talk about UTI. Yet to see, sir. Maybe the patient is already having upper urinary tract infection. You are not supposed to give. But you need to take a proper history, sit some more time and discuss with the patient. I think so you can do a good job. I'm not talking about the tertiary center. I'm talking about the primary center. I am in a private sector. I take my own time to see my patients. I give good governance, good advice to them. At least I take 45 minutes to see a patient. So I can find out everything, what is ups and downs. All you people said, I have put into a nutshell and I do to my patient.
So good morning, all of you. I am Dr. Kumaresan, former DMS, ESI. Sir was telling about two things. One about the PPP, main thing. See, in a country with 140 crores populations, to bring down the diabetes to a desirable level cannot be done by any private individuals or even a private hospital. So to achieve the maximum benefit, you will have to go in a PPP only, number one. Number two, PPP is not a profit sharing, because PPP is, the government has got a strength in certain ways, private have certain strengths. We have to combine both to get the synergy. Finance is not at all a problem. I tell you two examples of the PPP in Tamil Nadu. We did the CMONG centers, Comprehensive Emergency Obstetric and Neonatal Care. We engaged the ACAM Foundation for providing the staff nurses, trained staff nurses throughout the Tamil Nadu. Now the IMR is around 7.7 in Tamil Nadu. So, and IMMR is also around 39 or so. It's a very, very successful one. Second one is our 108 ambulance services. We have, government gives the fund. The operational part is taken care by the GVAK MRI. So similarly, to achieve the diabetic control, they will have to go into the PPP mode. Maybe a state-wise, somebody can take it up. For example, in Karnataka, Narayana Hridalaya has taken up a PPP mode with the government, and they have established center and tie up with the insurance. They are doing a better service at a lower cost, a broad base. More number of patients are treated. So similarly, this state-wise, some committee can be formed, expert committee, and with the support of some corporates, they can have a dialogue with that. Funding, that though it is a state, is under state government control, most of the funding comes from the central government only through National Health Mission. So that is not at all an issue. Only thing is, we need a good private as well as private partner, a corporate, to take up and do that, only for the operationalization. The main problem with the doctors in the rural setting is, they don't want to go there. At least in the initial 5 years of their service, they should be prepared to go there. Then only they will be able to understand the difficulties, what are all the problems, the requirements of the people. So that has to be taken care. So somewhere, a PPP mode can be worked out with a collaboration with the experts and with the local governments, state governments. Thank you.
So just to answer the last part of your question, I was testifying in front of the Planning Commission about 20 years ago. I had the IMA people, a whole bunch. And the same thing, doctors are not interested in going to rural areas. The reason is not anything else, sir. In those days, and in fact, I remember the IMA president saying something very simply, sir, the reason doctors don't want to go there is not because they don't want to go there, but because when they go there, they have to take a lota and go to the fields for toilets. The reason is not because doctors are not altruistic. The reason is the government there has failed to provide basic infrastructure, basic safety, no, I'm talking about 20 years.
Now, which state, sir?
Sir, this is 20 years ago in front of the family, in front of the thing. Even today.
No. 20 years back also, in my initial career of my service, I was staying in the most disadvantaged area.
Sir, today's young people want something else, sir.
No, that is what I am telling you. We stayed there round the clock. We did not do practice. That is the only 4 or 5 years I did my real work, which gave me a relaxation.
Sir, let me disagree with you.
Yeah.
It is if doctors still need motivation to go to a rural area rather than an opportunity to go to a rural area,
True.
then I think we have failed.
True. We have to inculcate in our undergraduate curriculum itself.
Exactly.
A portion of it, maybe in the SPM.
No. I'm saying the model needs to be urbanization of the rural area in terms of providing facility. If the roads are good, if there is piped water, if there is internet service, if the schools are good, then why would anybody not want to go? The failure, a lot of times doctors hurt themselves by saying we need to have a service motive. Why? A service motive is very important, but it is the job also of the government, of the people to provide the professionals the things that they deserve. Today,
I totally agree with you, sir. I have gone into the 4 states, Tamil Nadu, Karnataka, Kerala, Gujarat. I have gone into the rural areas and all. Nowhere these problems exist. That government satisfies. Maybe about the other states, other people have to tell.
Thank you, speakers, and I think we have last question from.
Good morning, sir. Kindly enlighten us more about the usage of Finerenone in diabetes, advantages.
I think there's a separate session on that, Vijay Kumar.
But now that you have asked the question, so two things I will say. Finerenone has been studied only in proteinuric kidney disease. It has not been studied in non-proteinuric kidney disease. So in proteinuric diabetic kidney disease, it has been studied extensively up to an eGFR even up till 18. So you can give it till that point of time. It is to be started very early. It is a medicine which is primarily meant for preventing the progression of proteinuric diabetic kidney disease. In non-proteinuric, it is not to be given. No study has been done, though the company still says that you can provide it, but logically it should not be given because there is no scientific evidence. Rest can be covered in the sessions to follow.
Thank you.
So thank you all the speakers and chairpersons. We had a wonderful session, wonderful discussion was there. So let's move on to the next session. We have 2 interesting topics, and to chair the session, may I call upon 3 chairpersons, Dr. K. Sai, Dr. A. Shanmugam, and Dr. Didipya Devaprasad. Over to the chairpersons.
Good morning, everybody. At the outset, let me thank GVK and his team for fabulous arrangements and topics and speakers. Let us not move on to first speaker, none other than SNN Narasimhan. He is talking on management of lipids. Should all diabetic get statin? Non-HDL, lipoprotein A, and newer agents. Sir.
Good morning, everyone. Thank you, chairpersons. the outset, I would like to thank Dr. Vijay Kumar for giving me this excellent opportunity to be here this morning, to be associated with all of you, to enjoy the scientific sessions under 3D Con. All of you know that the lipids and lipoproteins are associated with atherosclerosis in general and coronary atherosclerosis in particular. Out of all the lipids and the lipoproteins, it is the LDL cholesterol that plays a pivotal role, not only in the initiation of atherosclerosis, but also in the progression of atherosclerosis, ending in clinical cardiovascular events such as acute coronary syndrome or sudden cardiac death. There are molecular basis, biological informations, experimental data, Mendelian randomization studies, observational studies have gone to prove the role played by LDL cholesterol. The best role that played was only by the statins, HMG coenzyme reductase inhibitors, which had been used not only in primary prevention trials, but also in secondary prevention trials, have gone to prove that more the reduction that was witnessed in these trials, the reduction in LDL cholesterol, the more benefit that we had got, not only in morbidity, but also in mortality due to atherosclerotic cardiovascular disease. Dr. GVK had given me 4 important topics. Each one probably I can go on talking for 1 hour also, but I don't know how I am going to squeeze it for a period of 20 minutes. He has asked me to talk about should all diabetes get statin, non-HDL cholesterol, lipoprotein little a, and the newer agents. Let me try and see whether I can succeed in my attempt to cover everything within 20 minutes. The first topic is should all diabetes get statin? Many of you in this audience are aware about the ICMR INDIAP study, which had shown that about 81.2% of the population in our country are suffering from dyslipidemia. Apart from the huge number of people with the diabetes, people with the pre-diabetes, people with abdominal adiposity, people with the hypertension. I don't want to go into the details. Suffice to say that 81.2% of the people suffer from dyslipidemia in our country. The most recent data that was published last year has come out saying that the atherogenic dyslipidemia with a high triglyceride, low HDL is commonly encountered in our country. When you talk about the lipids and lipoproteins in type 1 diabetes, almost similar to the controls of your glycemic control is good. In type 2 diabetes, you have high triglycerides, the low HDL, the increased proportion of small dense LDL cholesterol, and increased ApoB are the 4 components of atherogenic dyslipidemia. Many of us tend to forget about it. The unique features of diabetes in our country, it is estimated that more than about half the patients with the diabetes in India are undiagnosed. Mortality in diabetes or due to atherosclerotic cardiovascular disease. Nearly about 75 to 80% of the people die due to ASCVD, complicated with diabetes. The burden of diabetes in our country can be probably be assessed by the younger age of onset. The ICMR INDIAP study started showing the onset of type 2 diabetes about 1 decade or 2 decades earlier in our country. In a multinational study involving about 24,000 people in 11 countries had come out with the data showing that it occurs at least 1 decade earlier when compared to Japanese or Chinese people. This is an excellent information that we have derived from the huge epidemiological data from United States and comparison between the people who have settled in the United States, South Asians, and compared to the Native Americans. The diabetes prevalence is higher in our population, that is particularly the people who have settled in the United States. The BMI is again high in our people when compared to Native Americans. The LDL cholesterol is again 130 and above is higher when compared to Native Americans. The HDL cholesterol less, and the atherogenic dyslipidemia characterized by hypertriglyceridemia is again a predominant feature in this particular study. We have concentrated only on South Asians, not on Native Americans. The Asian Indian phenotype, all of us know that is characterized by less of generalized obesity, more of abdominal adiposity, increased waist circumference, increased insulin levels, hyperinsulinemia, insulin resistance, increased levels of high sensitive CRP, and increased levels of leptin, and in the low adiponectin levels. These are the characteristic features of Asian Indian phenotype. It is also seen in this particular study, which was conducted in our country, which shows that the higher prevalence is seen in about 14 to 18% going into the problem of diabetes. When you catch them at the stage of pre-diabetes, nearly about 18% of them jump to pre-diabetes. It is suggestive of a more aggressive diabetes phenotype in our country. The CINDI trial, which was conducted in our country by our own people, had come out with excellent data that the ASCVD risk factors are seen in those people who are less than 40 years with the problem of diabetes. At the time of diagnosis, they were able to see nearly about 62% of them having dyslipidemia, apart from 83% who were very obese, 27% were hypertensive, 25% were smokers. I think all these risk factors are associated even at the time when the patients were diagnosed with the problem of diabetes, even at the age of less than 40 years. That is one important information that we derived from this CINDI trial. In addition, the CURVE study, which was actually initiated by Dr. Mohan and got published here, which had revealed that people with IGT has got a higher prevalence of coronary artery disease, nearly about 14.9% compared to even people with a normal glucose tolerance. So there are unique features of diabetes in our country. Number one, high prevalence of diabetes in Asian Indians. Number two, it occurs at younger age. Number three, Asian Indian phenotype characteristics as well as the features which attract our attention all the time. High prevalence of ASCVD risk factors, not only risk factors but also the coronary artery disease in people with diabetes, in people with the pre-diabetes, in people with metabolic syndrome. All these features, ladies and gentlemen, may be contributing to the premature coronary artery disease among Indians and provide a possible explanation for the increased CV mortality in our country. Having seen this, I think it is important, very, very important, to initiate the treatment for dyslipidemia and diabetics even without the clinical evidence of ASCVD on the day when it is diagnosed. That is the recommendation what Lipid Association of India has come out. And we differ from the association like AACE or ADA or ESCA because our guidelines are different. Probably it is indicated people with multiple problems in our country. So the management of diabetic dyslipidemia in the form of a consensus statement was published in Journal of Clinical Lipidology by Lipid Association of India in 2023. Before I go into the details of the recommendation, I thought I should tell you about the primary prevention trials. There was only one primary prevention trial which had gone to prove that if you are adding only 10 milligram of atorvastatin in people with diabetes with no baseline cardiovascular disease, it is going to give them the maximum benefit of nearly about 37% risk reduction when compared to the placebo. CART study was the first study to show that if you are giving only 10 milligram of atorvastatin for people with diabetes with no baseline cardiovascular disease, it is going to give them the extra benefit of reduction of cardiovascular events to the extent of 37%. No other study. We have studies like VASCOPS, ASCOPS, all those studies have included only 2 to 4% of the patients with diabetes. Whereas this study is exclusively for people with diabetes. In fact, the study was stopped at the end of 3.8 years because the investigators wanted to give the benefit to the placebo arm also because the huge benefit. So they were not hesitating to give the benefit to the patients who were receiving the placebo. So having seen these evidences, I think the Lipid Association of India is fully justified in coming out how to manage lipids in people with diabetes. This is very easy to classify. One on the other side, diabetes without ASCVD, the other one is the diabetes with ASCVD. Now you can just see diabetes without atherosclerotic cardiovascular disease, if they have no risk factors or only one risk factor is operating, there is no target organ damage, the person comes under high risk, you are expected to keep the levels of LDL cholesterol less than 70. So every patient needs to keep the levels of LDL cholesterol less than 70. That's the message, ladies and gentlemen, what I wanted to give it to you. If you want to concentrate on these levels, I think 100% of the patients who are diagnosed with diabetes need to receive statin therapy. The second one, when there is a target organ damage, at the same time, you are also seeing more than 2 risk factors. That means the patient comes under very high risk. You need to keep the levels less than 50 milligram. So that is about people with diabetes without ASCVD. On the other side, if you have established ASCVD complicating type 2 diabetes, now you look at this, no target organ damage, there are no other risk factors or only one risk factor is operating, you classify that particular individual under extreme risk category A, where the expected LDL goal should be around less than 50, but is optional for you to keep it less than 30. Whereas the person on the other side, already target organ damage, polyvascular disease, CAT, CAD, stroke, or peripheral vascular disease, all those complications are there in an individual with a diabetes. He comes under extreme risk category B, where you are expected to keep the levels of LDL cholesterol less than 30 milligram. That is the recommendation what Lipid Association of India has come out with a consensus statement. The justification for LI recommendation, we will concentrate only on two. One is A, B. The A category, at any level of LDL cholesterol, whether it is higher, normal, marginally elevated, or below normal, whatever is the level, but patients with established ASCVD are likely to get more number of events in the subsequent years. That means you need to probably be very careful in analyzing this data and bring down the LDL cholesterol less than 50 milligram. What about the category B? When you have the risk factors like cardiac failure, hypertension, age more than 75 years, diabetes, prior stroke, prior CABG, CAD, PAD, and the EGFR less than 60, current smoking. These are all considered the risk indicators. If you have the risk indicators associated with the ASCVD, that means the person needs to keep the levels of LDL cholesterol less than 30 milligram. So, are you clear? A, B. So, these two categories are coming under extreme category of Lipid Association of India's recommendation. The intensity of statin is high dose statin and moderate dose statin and low dose statin, which I will not dwell. The IMPROVE trial, which had used a high dose statin in those people with established atherosclerotic cardiovascular disease in the form of ACS, had come out with the data. People who received high dose statin, people with diabetes, were able to bring down the LDL cholesterol less than 40 milligram. And the benefit was seen in the form of reduction of MI by 24%, ischemic stroke by about 39%. If you look at all the data, people who received high dose statin, in people with diabetes, you can just see all these studies, HPS, CARE, Lipid, Prosper, ASCOT, LLA, or TNT, all the studies have shown that there is a definite residual risk. In spite of the fact that you put the patient on high dose statin, these trials have shown that they are at a very high risk. So the high risk, the residual risk can be many. Maybe a pro-inflammatory risk, cholesterol not being controlled properly, or the triglycerides are not concentrated properly, or you have a pro-thrombotic, pro-inflammatory risk, and then the refining the risk by including the drugs like SGLT2 inhibitors or GLP-1 receptor agonists in people with the diabetes probably will change the scenario of concentrating on residual risk. Should all diabetics get statin? I think I can request now to raise your hand. Those who hesitate, you raise your hands. Those who agree, need not raise your hands. I'm happy. Nobody had put their hands up. That shows all of you are agreeing with my statement that all people with the diabetes should receive statin. Only one person had raised the hand. Probably you can question me at the end. Non-HDL cholesterol, look at this information. All apolipoproteins, all atherogenic lipoproteins are IDL, VLDL, VLDL remnants, chylomicron remnants, LDL, and lipoprotein little. All these things are coming under a label called non-HDL cholesterol, leaving the HDL cholesterol. So if you leave the HDL cholesterol and you concentrate on any of the other parameters, all these things come under only one label, that is non-HDL cholesterol. Is there an evidence to say that the remnant cholesterol play an important role in atherosclerosis? Yes. The diagrammatic representation of this remnant cholesterol, which gets entry into the subendothelial space by initiation with the lipoprotein lipase and the enzymatic reaction, which causes sort of inflammation, macrophage, and finally the plaque formation. The chylomicron, which is rich only with the triglyceride, has got nothing to do. It will not enter into the subendothelial surface. The NCEP ATP3 guidelines 2003 started telling us way back 2003, if you have already reached the LDL cholesterol and if the triglyceride levels are more than 200 milligrams, you need to concentrate on non-HDL cholesterol. I think all of us had forgotten about this statement in spite of the fact that it was released in 2003. Look at this data. for LDL cholesterol as well as non-HDL. Non-HDL has got a progressive increase in the cardiovascular risk compared to the LDL cholesterol. And then another study, about 8 studies were included in this particular data, which had gone to prove that more reduction that was seen only with the non-HDL cholesterol has shown benefit when compared to LDL cholesterol or the other parameters like ApoB. This study also had given us important information. People who reach the LDL cholesterol, but still the non-HDL cholesterol is high, 130. LDL cholesterol has come down below 100. That was the time when these goals were maintained. So if you see such patients, they are at a very high risk of developing cardiovascular disease. What is the risk? 32%. If somebody had reached the levels less than 130 non-HDL, but LDL still high, what is the incidence? Only 2%. So what does it mean? So you need to concentrate on non-HDL cholesterol in those patients who had already reached the LDL cholesterol goal. That is the message what we have already obtained. There is again another study which had gone to prove that the various parameters like the non-HDL and the HDL, non-HDL and the LDL values which are depicted here, the hazard ratio at every level of reduction of LDL, every level of reduction of non-HDL, the hazard ratio for recurrence of events in statin-treated patients is higher for non-HDL than the LDL cholesterol. The recent data, both in men and women, those people who have more than 220 milligrams of non-HDL, they have higher vascular events compared to people who are having a lower levels. It starts at the 10th year and it goes on even after 30 years of follow-up also, they were having a higher risk of developing a cardiovascular risk. What about people with the diabetes? Non-HDL is significant. There are a number of studies which have gone to prove that the non-HDL has got a good role to play in atherosclerosis, particularly in people with diabetes. This is a recommendation by the Lipid Association of India. It is a non-HDL is a co-primary target, as important as a lipid lowering. Monitoring the non-HDL is simple because it does not require a fasting blood sample, takes care of both LDL and TG targets. Non-HDL should be 30 milligram more than that of the LDL values. Statin remains the first agent. Adding an ezetimibe may be considered. Adding an icosapent ester probably will help this patient to reduce the cardiovascular risk. If you have any doubt with regard to LDL, non-HDL, ApoB, this is a simple one-slide information. One, LDL measures the cholesterol content of not only LDL, but also lipoprotein little a. Non-HDL measures the cholesterol content of all atherogenic lipoprotein particles, whereas ApoB concentration measures the number of all atherogenic particles. This is the message. Lipoprotein little a, not little anymore. It is seen that those people who have atherosclerotic cardiovascular risk in heterozygous familial hypercholesterolemia, the same amount of risk is faced by those people in whom we have elevated levels of LPA. So LPA levels should not be neglected. It is not an emerging risk factor, but we need to realize that this is also one of the important risk factors for pushing patients for atherosclerotic cardiovascular disease because of its pro-atherogenic effects, pro-thrombotic effects, and pro-inflammatory effects. There is good number of studies by Copenhagen City Heart Study, Copenhagen General Population Study, where they had evaluated 11,000 patients on the top and 100,000 patients at the second study with a long years of follow-up, nearly 10 years and 26 years of follow-up, clearly has shown those people who had 90th percentile and 95th percentile had higher incidence of cardiovascular events, including myocardial infarction. Even recurrence of events, major adverse cardiovascular events were also high in those people in whom you had higher levels of the problems of LPA. The most recent data, which shows anything that is going beyond 150 milligram, that is equal to 350 nanomoles, you are not supposed to say milligrams when you talk about the LPA. It is nanomoles. We cannot equate. This is equal to this one. Approximately 150 milligrams is about 350 nanomoles. Please remember that. And those people who have more than 150 had got a higher incidence of cardiovascular disease, even though the people have been followed up for a period of 80 years or so, their observation seems to be correct. Because up to the age of 80 years, people have followed up, and then this is the message that we get it from this particular study. LPA is also responsible for aortic valvular stenosis. aortic valvular stenosis. Why should we get worried about LPA? One, it can increase 2 to 3-fold increase in one, myocardial infarction. Two, atherosclerotic cardiovascular disease, particularly the AS, that is aortic stenosis, peripheral arterial disease, ischemic stroke, heart failure, including heart attacks. So strong, independent, and likely causal risk factor for cardiovascular disease is a message that we derive it from all these studies. How to manage LPA? There are two ways. One is antisense oligonucleotide. Next one is a small interfering RNA. The antisense oligonucleotide, there is the pelacarsen. Probably we'll expect the results by the end of this year. The other one is the olpasiran. Again, a small interfering RNA, which is probably useful for managing patients with the LPA. The LPA in patients with diabetes. There were controversies which was going on. If you have low levels of LPA, it pushes patients for diabetes. That's the message what we have learned from the various observational studies in the past. But contrary to some previous studies, the new research has shown that the low levels of LPA do not cause type 2 diabetes. This is by the Mendelian randomization study, and then the recent study published in this particular journal, in addition to the information that we obtained from the European Society of Hypertension, European Society of Cardiology. Management of lipids, newer agents. This is a last slide which gives you an information about the newer agents. One is a smaller molecule, bempedoic acid. I think some of you are using it. I think many of you are not using it, I know. Only few, like Dr. Prabhakar is using it, I am also using it. So bempedoic is a wonderful drug. And I can say that probably it can replace your PCSK9 inhibitor if you are going to add it with statin and ezetimibe. 3-drug combination following myocardial infarction, that is acceptable now. The other drug is the antibodies, evinacumab, alirocumab. All these are PCSK9 inhibitor. Evinacumab is an ANGPTL3 inhibitor, the drug that is being used specifically for people with homozygous familial hypercholesterolemia. And then the ASO, antisense oligonucleotide, pelacarsen. The small interfering RNA, inclisiran, and SLN360 for LPA, olpasiran for LPA. And the other one is the CSL112 for increasing the HDL cholesterol. So I think I had given you enough of information within the stipulated time. I don't know whether I exceeded the time, because the 4 major topics were allotted to me. I was wondering how I should cover it. I hope I did the justice. Thank you very much, ladies and gentlemen, for patient listening.
Thank you, sir, for this wonderful talk. So should all diabetics get statins? You said yes. About non-LDL, after LDL targets are met, people used to talk about non-LDL, but you are saying take non-LDL as a co-primary target and keep it 30 more than the established LDL target. Lipoprotein A is important both for atherosclerotic coronary artery disease as well as calcific aortic stenosis. And you did elaborate about a lot of these newer agents which we'll be looking forward. Thank you for this wonderful talk in short, crisp talk, sir. Thank you.
Thank you very much.
You can introduce.
So next, we have the pleasure of introducing 2 speakers. We are going to talk about Jugalbandi on diabetes and heart failure. We are talking about heart failure with preserved ejection fraction as well as heart failure versus reduced ejection fraction, NT-proBNP, management and preventive strategies. To have this Jugalbandi, may I invite Dr. D. Prabhakar and Dr. R. S. Sundar, and may I request their introductory slides to be... Yes.
Just skip the slides. I think we'll just skip the slides. When you said Jugalbandi, Sundar had only one doubt. Should we dance and come on stage? I think we'll let you all dance and have fun. Right, what we'll try to do over the next about 20 to 30 minutes is, instead of a regular talk, this is going to be more of a discussion on heart failure. We'll try to keep a discussion, and Sundar's suggestion was, as and when you want, you can break us. It's not going to be a continuous dialogue discussion by us. All of you are welcome to join into the discussion. Yep.
Yeah, good morning, everyone. At the outset, thanks for this forum. And a small remembrance about the great man, Professor Sam G.P. Moses, because he was the one who initially sowed the seeds for cardiodiabetology 40 years ago. And he was the one who started the union between cardiology and diabetology, and in fact coined the term cardiodiabetology as well as so-called cardiomyopathy in diabetes. So I would like to remember him on this special occasion. And always, forum in a diabetic conference on cardiology and vis-a-vis cardiology conference wherein diabetes talk comes, it's always met with a lot of interest. So without much ado, we will just start on a case. That's how we discuss this. So see, this is a routine case which we see. This is obviously a case. When we suggest a case, it is never a pure case, because we are not talking about theory. Obviously, the patients are managed in the real world situation. We may not start a diabetes patient with a SGLT. We may not start the patients with a metformin. We may not start patients with a GLP analog. Whatever you see in a podium, in a theoretical meeting, will never happen in the real world. So this is what happens in most of the time. It's a 60-year-old garden variety patient, 10 years diabetes and hypertension, 5 years. Fine, asymptomatic for almost till 2 months ago. Progressive dyspnea since 2 months, no angina, PND since 10 days, dyspnea at rest for 5 days. All these things were treated as lower respiratory infection. I'm sure almost everyone, every cardiologist and most of the physicians who deal with emergencies would see this. That no, 2 months, sir, I have been having cough and cold. Nobody thinks of heart failure. Because above the age of say 50, especially in a diabetic, any new onset dyspnea should never be, poo-pooed as respiratory problem. You should invoke cardiac failure also into most of these patients. Otherwise, most of them get diagnosed so late. It's almost 2 months since he started having the symptoms, and the patient comes to anybody's clinic. It could be yours, it could be mine, it could be sirs. Heart rate of 120. So that is the first important indication that your heart is under strain. Tachycardia, blood pressure borderline 110/80, afebrile, mild dyspnea at rest, JVP, of course. I mean, these are all undergraduate teaching. Of course, you can see if you want. And most importantly, look for a gallop sound. So if you have a gallop sound with a tachycardia, you are invariably treating a heart failure. And bilateral basal crackles. So this is how uniformly the patient comes. Nobody comes to the textbook. Nobody comes with a heart failure suddenly in the middle of the night. All those things may be 20% of heart failure. Most of the heart failure patients, I would request Dr. Prabhakar also to confirm on this, that most of them, they just walk in, ambulant heart failure, progressively deteriorating with PNDs in the night. And if you leave them without treatment, they may sink the next day. So this is how our patient comes. The drug list, as I told you, no fancy drugs, no evidence-based medicine. This is what happens in real world. I'm not talking about podium talk. This is sulfonylurea, metformin, calcium channel blocker, vitamins. This is how all our patients, most of our patients in real life are managed. There's no SGLT, no GLP and all. So this is how it's a garden variety. So investigations, what will you do? Investigations.
So basically first I will wear the cap of a physician or a diabetologist here. So when a patient like this walks into my clinic, as a physician, what will you do? The first thought, diabetic, probably mild fever, breathlessness. You do suspect a respiratory tract infection, which is much more common. That's what you do. But you don't wait for so long. The moment you realize that he is not all right, and one important thing is it's progressive. 2 months ago, he was walking 5 kilometers. That's a warning sign. I think that is what all of you should remember. When to start suspecting a cardiac cause. I think that is very important as a physician. So at this stage, so far you have come here, apparently diagnosis is already there. He's given all the symptoms, everything is there. Now, if you're going to do as a physician, what else can you do? That's the question. The most important thing that a physician can do, not depending on a cardiologist, one of the biggest fears any physician has is losing a patient, which is true. Come on, let's all accept it. All of us believe that if I send it to some fellow, he's not going to come back to me. So what will you do? You can do a simple NT-proBNP for these patients. As an outpatient, NT-proBNP is available as point-of-care kits. 10 to 15 minutes you can get a report. Even if you do the test, you will get the report within about a day. You don't have to wait for 2 months for this. I think should be the care. So how do you interpret NT-proBNP in a patient in a chronic outpatient setting? Very simple. 125 is the cutoff. If it is less than 125, don't bother. Your patient does not have a cardiac cause. Beyond 125, the importance is looking at the age. Age less than 50 years, 125 plus is abnormal. 50 to 75, 250, double the value. If the age is more than 75, it's going to be 500. 125, 250, 500 in the outpatient setting in a patient presenting with breathlessness. If you had done it, you would have seen about 1,000 or 2,000 NT-proBNP. Straight away, you need not have wasted the patient's time. That would have been an excellent test for this. Rest of the investigations, I think, are all routine.
I think point of care NT-proBNPs are also available, and see, at least it will give you a rough idea. So it is like a quantitative troponin and a card test. At least something is better than nothing. So you should do a NT-proBNP on all patients who present with dyspnea. New onset dyspnea, NT-proBNP is the way to go. And I would not go into detail about others. Of course, echo is very important. Of course, always have a cardiologist as your friend. We are all there to help you. You can refer
Dr.
to us.
Parnavan sir wants to say something. Yeah, go ahead, sir.
Yeah.
If the patient has bilateral extensive rhonchi instead of rolls, the same scenario
with rhonchi.
Patient admitted in ICU with acute breathless. Now, on examination, only bilateral extensive expiratory rhonchi, no rolls. So, what is your? That's the same thing we have right now. We have one case with us. That's why I'm asking.
So this is where in your outpatient setting you look at an NT-proBNP that helps you considerably. You have your total count, you're suggesting infection. You have only an NT-proBNP being elevated, then you ask for an echo. It's always, you need not even ask for an echo. Start treating. You just nebulize your patient, you have your answer.
And rhonchi in heart failure is not unusual. You can have rhonchi in heart failures also. I mean, after all, it is a reactive phenomenon of the bronchi. So if you have some amount of pulmonary congestion, you can have rhonchi in. See, all these so-called, within inverted commas, undergraduate teachings, I mean, it is good to have a unexplained tachycardia, no fever, with a third heart sound. I think clinically, you are diagnosing heart failure.
Actually, what happened was, this patient did not improve with furosemide. It was managed by the doctors. And subsequently, we took a history. He's been having this on and off cold cough every year, seasonal. Then there was a overlapping bronchial asthma was there in addition to S3 cardiac failure.
Yeah,
so that was scenario commonly without that's right.
You are talking about a patient already having cardiac failure with asthma. Is that what you're talking about?
No. New onset.
New onset.
New
okay,
onset
that's
asthma,
fine.
new onset breathless actually.
So I think
not
basically
asthma.
it's the clinician. The clinician is at fault.
Yes.
All you could have done is just tried a nebulizer, which is not going to harm the patient in heart failure. If you had shown total disappearance of the bronchi, you have your diagnosis there. Seasonal asthma, yes, fine. I think it's basically as a professor of medicine, I think he's going into clinical medicine. I think it's perfectly fine. There's no substitute to that, sir.
So the echo is very important apart from proBNP. And of course, we did all these things. And these are the results. ECG shows a left bundle branch block as it is expected. Sometimes you get a left ventricular with strain, X-ray pulmonary congestion. The important thing is the echo. Echo shows a dilated left ventricle, ejection fraction of 35% with pulmonary artery pressure of 50 millimeters of mercury, bilateral effusion. And a proBNP which is very, very high, 3,500. Renal functions normal, HbA1c, uncontrolled diabetes. So this is a standard garden variety heart failure with reduced ejection fraction. So how would you go about treating the patient?
So basically now your diagnosis is clear. We have everything in place. Your NT-proBNP is high, you have a cardiac failure, left bundle branch block with cardiac failure. Very simple. So when you have a cardiac failure, how do you start treating the patient? The first thing you always do is, what do you give? First thing? Diuretics. Excellent. I think all of you have heard enough.
Would you admit the patient?
This is an outpatient. It is not mandatory to admit all patients with heart failure. You can start a diuretic, and if the patient responds, that will be the initial response. That symptomatic relief is going to be given by the diuretic. In fact, what I do, I give them a shot of diuretic. In fact, you have those mouth-dissolving diuretic tablets available now with excellent bioavailability. So if you start using that, within 24 hours, he will tell you, sir, you have done something, what I had for 2 months, I've tremendously improved. By the time you get all your other investigations in place, and then you can start introducing the other drugs. I keep telling practically, there are 3 clinical phenotypes in heart failure. One is the congested phenotype, which is what we are saying. Every fellow is going to be congested when he presents to you. Yeah, you can go to the algorithm.
Acute heart failure, I always equate it to hypoglycemia. The amount of satisfaction a patient gets when you treat.
I think much cheaper than most of the diabetic drugs. I think sir should agree with me. So I think it should be fairly cheap to start these drugs. MRA, depending on the potassium, I keep starting. But the important point is, within 4 weeks, all drugs should be on board. Within 4 weeks. Because these drugs start showing their effects very early. Try to adjust individually to your patients. The next practical point which I'd like Sundar to highlight would probably, what do you do if the patient has got a brittle blood pressure of about 90 or 100 systolic?
Yeah. See, again,
in the outpatient setting.
In the outpatient setting, see, the problem with most of the patients is they will come to you with a borderline blood pressure, 90, 100. This patient is different, 110, but it's okay. But the moment you give some diuretics, their pressures may drop around 90, 100. So those are the patients where you need to be very careful. Obviously, the first drug of choice in the big four will always be SGLT. SGLT should go in first, and then probably I would slightly differ in this, because MRA, I feel, when you have a loop diuretic in, you need to have some amount of MRA so that you combat the potassium. So that is also okay.
I'll also add one more thing to MRA. MRA is the drug that reduces the blood pressure the least among these drugs. Though we keep talking about resistant hypertension, give MRA. In this scenario, MRA reduces the blood pressure the least.
So you can give a MRA on top of SGLT, and parallelly, if you feel that at the time of discharge, it's okay to get a very minuscule dose of a beta blocker, because beta blockers have shown to have the greatest mortality benefit in heart failure. No other drug has shown that amount of mortality benefit like that of a beta blocker. So obviously, a very minuscule dose. Which beta blocker? I wouldn't go for a carvedilol with the lowest blood pressure. I would probably go for a bisoprolol with a very, very minimal dose, 1.25, and then follow up the patient, potassium, renal function, diet, lifestyle, call him back after 2 weeks, and then probably think about ARNI in that case. So that would be my approach in a lowish blood pressure, say 90, 100. But what happens in them is, once you do this, once your cardiac output improves, you get a good blood pressure. So sometimes you have to add these drugs in spite of a lowish blood pressure to get a better blood pressure. Don't worry about the BP falling. In fact, you are giving these drugs so that the cardiac output improves, and subsequently his BP improves. So that is what happens. So
the hypotension in heart failure is defined a little differently. You call it as symptomatic hypotension. Asymptomatic 90-60, please don't worry, they're all fine. They will do well, nothing will happen. I have patients walking around with 85 systolic without any problem, taking 100 milligram twice a day of sacubitril valsartan, 10 milligrams of bisoprolol, MRA and SGLT2 inhibitors. I have not changed the dose. I've kept them on the same. They are absolutely stable. Don't worry about the blood pressure. It's not the numeric value, it is symptomatic hypotension that's important. Another important thing in this particular is the BP drops dramatically. The next thing you have to look at, as a cardiologist, I have the privilege of having an echo machine. I will look at the IVC size, scale down the diuretics and stop the diuretics. Patients do not require long-term diuretics. One of the biggest causes for hypotension is overuse of diuretics. And if you're giving these useless drugs like nitrates and other things for these patients, please stop. None of them are required. Any doubts? Anything you want to talk about this?
Wonderful.
Yeah, go ahead. Aditya.
Wonderful here. I think most of them will be hesitant to start diuretics with hypotension, and that is well addressed here. Now, the other issue is some of these patients who have, because it's been long standing for 2 months, they may present with some degree of AKI at presentation, so cardiorenal syndrome at presentation itself. And therefore, there's always this inertia of, well, should I use ARNI when you have renal failure, a creatinine of 1.4, a potassium that is hovering to 5.1, with the risk of worsening AKI and hyperkalemia with ARNI. So in this situation, just like hypotension, what would be your thought process?
It's a tough area. Obviously, it is going to be tough when somebody presents to you with, say, a GFR of 40 with a cardiorenal syndrome. Obviously, the go-to drug obviously is going to be SGLT to start with. Because above 20, you can boldly start them on SGLT, maybe minuscule dose of beta blocker again, because beta blockers are not very much contraindicated. You can use a beta blocker, and then follow them up, and then get the other drugs on board subsequently.
Practical advice to DD's question. DDPA is sitting in a hospital which is which is a tertiary hospital. You get all these complicated, please don't treat in the outpatient, send it to the hospital. Don't do outpatient management of all these sick patients. Yeah. This needs a lot of monitoring. Be a little careful. Everything is going to be brittle. Be careful. Because if you try doing something as an outpatient, don't try to be too heroic also. Be sensible.
I think many of the patients, you don't miss anything by admitting them. So you can hospitalize them a couple of days, monitor them, see how they behave with the drugs. Because it's like ATT. How they behave with the drugs. Maybe a couple of days, give them counseling, and then discharge them.
Yes, Aditya, you wanted to say something?
Sir, my question is very basic and this thing. Regarding in that history, like every time my chief used to say, whenever any heart failure case comes, we should even ask about the erectile dysfunction. I want to know this thing, because any patient who has erectile dysfunction, there is one lesion will be there in the heart, is what my chief used to say. And whenever we used to give the beta blocker also before initiation, that could be better, because always my chief, if I don't write, he used to scold me. That's why I remember. It is a layman doubt. I just want to know the expertise of you, sir.
I'm not sure about
Okay, the answer to your question is erectile dysfunction. Basically, you call it as atherosclerosis. Probably when you have atherosclerosis there, you have atherosclerotic disease somewhere else. So possibly that's the simplest explanation I can give you for that.
Beta blocker causing erectile dysfunction.
Beta blocker causing erectile dysfunction. Here, it's going to be very simple. You have a patient who's going to take a beta blocker and survive, or you want a patient who's not having erectile dysfunction and die.
No, you need to see.
The choice is yours.
Aditya, patient will die of heart, not with erectile dysfunction. That can be taken later.
Most of the patients above the age of 60 with respiratory infection coming to you with resting tachycardia, seeing in the OP. After 3 or 4 days, they come with unusual chest pain. You diagnose atrial fibrillation. So what for these patients with failure you will give?
So atrial fibrillation is a separate disease. If you start looking at atrial fibrillation, first try to find out structurally the heart is normal. If the heart is structurally abnormal, start treating that accordingly. Then you take a fair decision on whether you want a rate control or rhythm control. Depending on the Church-Wasc score, you have to go ahead, anticoagulate the patient and start treating them. That's a separate topic, I think. It's a good question. It happens practically, but I think we should probably have a separate Jugalpati for that. Sorry, sir. Go ahead.
So this patient, so obviously 4 drugs into the pipeline within 4 weeks. That's the rule. Then diurese, remove the diuretic, loop diuretic as soon as possible once the patient is dry. Then statin, Dr. Narasimhan had already spoken, so we are not going into it. Any role for coronary angiogram? We have 11 minutes. Any role for coronary angiogram? Of course, a patient has severe heart failure. There is a role for coronary angiogram. What about revascularization? PCI, no, but maybe CABG in a limited set of patients.
See, point is, this is what he's trying to say. I'll simplify what he tries to say. The role of a coronary angiogram in a heart failure with reduced ejection fraction has become a little controversial. There's a lot of issues on that, so even if you don't do, because most of the patients with the current medical management, the 4 pillars that we said, see, when you give the 4 pillars, when you treat a patient for 2 years, you save 1 life out of 4. If you just treat 4 patients, you save 1 life. So the mortality reduction is 25%. This is absolute risk reduction.
I think this is the
so when
lowest
this
NNT.
is there, yeah, this is the lowest
lowest
NNT.
NNT.
So when you have such treatment, you don't need revascularization. That's the justification for this. It's a little controversial. Beyond that, I don't think we'll fight on that.
Ivabradine, yes, there is a role for ivabradine when your heart rate is above 70 in spite of all the medications. The newer drugs are there, like vericiguat, which is there, which can be added as the 5th pillar if you want to add in refractory cases. I think that is pure cardiology.
One
area.
word of caution at vericiguat. Please remember, it is not an outpatient drug like digoxin. Vericiguat is reserved for patients who, despite guideline-directed medical therapy, are still symptomatic. So please remember that. It's not a regular drug to be used. Probably leave it to the specialist of heart failure.
I think the older drugs, I mean, very limited benefit, digoxin, hydralazine. I mean, once the big 5 have come, big 4 plus 1 have come, I think we are getting away with the older drug. Device therapies in a limited set of patients does help, like ICD, CRTs and other things. Role of anemia, sir, your favorite topic?
See, I think most of the patients, whenever you have a hemoglobin, even at 11 or 12, if they continue to be symptomatic, you have given a good guideline-directed medical therapy, he continues to have a breathlessness. Look at serum ferritin levels and TSAT. If the ferritin level is less than 100 in these patients, you give them 1 gram of ferric carboxymaltose. 1 gram IV can be given. Or if your ferritin is 100 to 300, again TSAT is less than 20. Look at both. Again, you give them iron. You will find tremendous improvement in symptoms. This iron and the capacity of iron to carry oxygen, that's very, very important. I use it extensively. Please do it. And once you give it, it lasts for about 3 to 6 months. The reason why you have to give parenteral iron is oral iron is not absorbed in these patients. So you have to go for a parenteral iron. That's very important and very practical. The other point, now that he said anemia, always vaccinate all your patients with heart failure. Annual dose of flu and pneumococcal vaccine, depending on the age. I will not go too much into that.
So this is the first case. I think we'll go to the next one. So one word is what HbA1c is. These are drugs which he is getting. bisoprolol, DAPA, Arni, eplerenone, and torsemide at the end of 1 month.
Will you be satisfied with that? Aditya, I'll ask you this question. Are you happy with this? No.
You are not happy.
What are you not happy?
So why I don't satisfied, because I don't know the eplerenone, how it could be there, and the cost effectiveness. It depends on the cost effectiveness of the patient, and I wanted to know about the anemic status of the patient, because even it says clearly in the guidelines.
All are fine.
All are fine, sir.
Metabolic parameters are fine.
And no, sir, because I want to see the torsemide daily for how many days you want to. For 1 month torsemide, I'm never okay, sir. I want
Right,
to.
let's forget it. I'll tell you what I wanted. Okay, your answer is correct, partly correct. Few things. Bisoprolol, you go for a heart rate control. The most important thing is get the heart rate less than 70. Try to get the heart rate as low as 55 to 60 in heart failure. That's the best heart rate. If you're going to use dapagliflozin or empagliflozin, it's pretty much the same dose is fine. Arni, maximum tolerated dose. Try to go up to 200. Don't bother about the hypotension. If you remove the torsemide, you can definitely go up on the dose of Arni. That is fine. Eplerenone, 25 milligram, 50 milligram. What do you do? Okay, now there is a very recent article which has clearly said 25 milligram of spironolactone or 25 milligrams of eplerenone is what has actually been studied. The guidelines have written it wrong and say go up to 50. It is wrong. This is written by Michael Baum. It's a very beautiful article, came about 1 month ago. So you don't have to push the eplerenone. One of the bigger problems of that is the hyperkalemia, which is not going to happen. So this particular patient, get your heart rate down, manage your blood pressure, make sure all 4 drugs are on board. Heart rate is very, very important. That's the only problem with this. We'll go to the next case.
See, what is most important is get all the 4 drugs as early as possible. That is the teaching. That's it. Nothing else. And use NT-proBNP just like your HbA1c in diabetes. That's all.
So we'll make this case short. Basically, what we are looking at is a 60-year-old obese lady, and who has presented to you with an occasional nocturnal breathlessness and breathlessness, which is about class 3. I'm not able to do anything. The obese lady, BMI of 38, not able to walk. Classically, most of us see these patients in the outpatient. Old lady coming with breathlessness, you do everything, you do a routine ECG, echo, everything, nothing is showing abnormality. Look at the blood pressure, 180 by 90. So what do you think this patient has? How do you screen these patients? That's the primary question. I'll not go time because we don't have much time.
Obviously, the standard thing what we discussed previously, NT-proBNP is important. Obviously, uncontrolled hypertension with suggestion of heart failure. Obviously, you get a renal values, you get your echo done, X-ray, ECG, and all those stuff. So these are the basic things which we have already done. So we'll not go back into that. So these are the investigative results. So patient has a very high BNP again. So that defines heart failure. Then you go to the echo. The only difference between this echo and the previous echo is your ejection fraction is above 50. The previous echo, the ejection fraction was 35. So you obviously know that this is a heart failure with reserved ejection fraction. Obviously, here there is something important which Dr. Prabhakar will understand, agree with me, that it is not just the ejection fraction. You need to do more. You need to do more about this so-called diastolic function of the heart. So you always look into E by E prime in the mitral Doppler. You always look into the pulmonary vein reversal. We look into the LA strain. All these indices can be looked into in a dedicated echo lab if you have one. Otherwise, I think this gives you the diagnosis, and then you can refer them to either me or Dr. Prabhakar.
He's promoting cardiology, right? I'll just add one more issue in this. So in a clinic, when you sit and have a patient with breathlessness and the blood pressure is high, you look at the ECG, which is available in most of the places. Left ventricular hypertrophy is a very important thing. So if you have left ventricular hypertrophy, it means that the heart muscle is thick. There is going to be less compliance. It's like a rubber band. It's not going to stretch. That is what diastolic dysfunction is all about. So left ventricular hypertrophy with the parameters. If any lab is giving you a report of grade 1, grade 2, grade 3 diastolic dysfunction, please change the lab. That's all an outdated, very old formula. It has to be American College of Echocardiography's ACE criteria for a diastolic dysfunction. That is quite different. It is normal, abnormal, intermediate. So that is different. LA strain, he said, is available in very few labs, but if it's there, it's going to be useful because it's the most specific one. Practically speaking, the NT-proBNP values I gave you, the 125, 250, 500 for you, for the age, is going to be the best one. But in an acute breathlessness, for the question that DDPA was there, sitting in an ICU, the values are different. Acute breathlessness, patient seen in the emergency department, the rule out is 300. Rule out is 300. But for diagnosis, it is 450, 900, and 1800, same age criteria, 50, 50 to 75, and 75. Now I have a question for the diabetologist. How many of you routinely do NT-proBNP to find out a new factor called stress of the heart? Does anybody do? Krishna unfortunately disappeared. Krishna sits here. Normally does that. Krishna is the only fellow who I know who is doing it as a diabetologist. There is a value of NT-proBNP of 50. If the value goes more than 50, you think of heart stress in diabetes. It's specifically meant for diabetes. Very few diabetologists, diabetologists don't talk about it. But to make a diagnosis, it is 75, 150, and 300 for the same 3 age criteria. So, and those patients, please get an echocardiography done. This is an outpatient method of doing it. Probably you can go into the management, we can close. We have just 2 minutes.
We'll go. See, what is important in the management of preserved ejection fraction is the controversy, because it's highly controversial. Obviously, you need to, in preserved ejection fraction, it's different from reduced ejection fraction. Here, you need to target the villains which you see. Number one, blood pressure control is going to be the key in this lady. Number two, you need to give diuretics, otherwise the patient is going to go to the next doctor. So you need to symptomatically improve the patient. You need to give some amount of loop diuretics in these patients. These two are standard, getting the risk factors down, getting blood pressure control, diabetes control, everything. But what does evidence say? Do we have any evidence in this area? Obviously, SGLT.
There are only 2 drugs that have good evidence at this point of time. The SGLT2 inhibitors, yes. ARNI to some extent. If the EF is less than 60%, 50 to 60 probably, ARNI is going to be there in that group of patients. Spironolactone selectively, but finerenone off late of the fine arts is there. I think with that, we will not go too much into the controversy. But I think in an outpatient clinic, NT-proBNP is your marker. And if you want to treat, I think all diabetics should be on SGLT2 inhibitors unless they can't tolerate it or some other contraindication. You're going to reduce our practice if you start doing that regularly, which is what is the ultimate goal of 3D-Con. Try to destroy the practice of cardiologists.
That is why there are so many stalls outside, because all diabetics should be on statin, should be on SGLT. So these two are going to be standard. So apart from that, obviously, controversy again, coronary angiogram. So the drugs which are recommended today, which are going to have some amount of mortality benefit, heart failure benefit, are only 2. One is SGLT, definitely yes, backed up by evidence, both EMPA and DAPA. And the second one is obviously ARNI, controversial, but to a certain extent, at least it reduces blood pressure in this patient, which is important. And of course, finerenone.
Heart failure with preserved ejection fraction, it actually normalizes. So if you have an elevated NT-proBNP, you treat them adequately with all these drugs, you'll actually notice the NT-proBNP will be normal. Then don't say your original diagnosis was wrong. No, you have treated the patient well. That's all it means. I think we should call it quits.
Being very democratic, the previous patient got DAPA, this patient got EMPA. So torsemide, finerenone.
Both are off patent.
Yeah. And avoid beta blockers. Because in heart failure with preserved ejection fraction, you need to be careful about beta blockers, because here the cardiac output is maintained by the heart rate. So you need to have an uppish heart rate, because otherwise if you're going to push the heart rate down, the patient is going to become more symptomatic. So try to avoid beta. That is the most important difference between preserved and the reduced ejection fraction. Avoid a beta blocker in this group of patients.
That's a little tricky there. So basically, patient with coronary artery disease, some other indication, please don't withhold the beta blockers. But as an antihypertensive drug and during the treatment, beta blockers are not indicated, because actually when the heart rate is more, the diastolic filling becomes more, the diastolic pressure becomes higher, they become more symptomatic. It's been proven that withdrawal has actually been beneficial. There's a trial called Preserve Heart Failure. Yes, sir.
Excellent, sir. Thank you. I thought I will remember 125 as the cutoff value, because 126 is for diagnosing diabetes.
Beautiful.
Okay. So, but you're saying 50, 75, which one I should?
So, basically it depends on the age of the patient, 50 to 75. So, you remember this 125, double it each time.
But what about this 50 and 75?
That is strain.
50 is, which one?
Strain.
The
Strain. He's talking about the strain.
Diabetic strain.
Diabetic
stress in the diabetes. Oh, that's fine, sir. That's a very new terminology. It is very difficult for you to pick. It's a very new terminology that has come in called heart stress in diabetes. And that is 50 milligrams. Less than 50 is normal. So if you're going to have more than 175, 150, and 300. So for an outpatient practice, for a diabetologist, if you want to do it routinely, you can still do NT-proBNP. It has some value. And if your value is high, please get an echo done. Not the routine echo, get a proper echo done. That's very important.
Thank you.
I think most of these patients benefit with SGLT with a loop diuretic, most of them. SGLT, minimal loop diuretic, most of these patients do well.
Yeah, go ahead, sir.
I really enjoyed this discussion. So when you, regarding this evaporadine,
when you are using the all pillars for heart failure in sequence, a patient is all right, but persistent tachycardia is there. So, the tachycardia indicates is a neuronormal activation heart failure. That indicates a decreased ejection fraction, whatever so. If that is the condition, if you give ivabradine to control the heart rate, but it is a reflection of heart failure, we are bringing down the heart rate. Is it okay, or still you go use ivabradine?
That's a typical question from Dr. Paranam. I think all of you will agree with this. This is how he normally thinks. So it's not like that. See, a heart rate is a manifestation. It is a You are not treating the heart failure. You are only treating it. But over a period of time, you give ivabradine only when you can't give the beta blockers. So try to push up the beta blockers. In fact, the other question I would have been happy if you had asked me. I have got the patient on 10 milligram twice a day of ivabradine, or 10 milligrams or 15 milligrams of ivabradine. But the BP is now all right. What should I do? Please change over to beta blocker. You have to come back to beta blockers. That's a better way of looking at it. It's only symptomatic relief. And in fact, in an acute heart failure, when you give ivabradine, you can start beta blocker early actually. Initially bring down the heart rate. It is beneficial. The hemodynamics improve.
Wonderful. Thank you, sir.
Actually, ivabradine, it only acts on the funny current
yes,
and
yeah,
only
yes,
in
I
the
know.
sinus node.
Yes.
So it is not going to tamper with your sympathetic overactivity, etc., etc. So it is going to only act on the sinus node and reduce the pulse. So giving your diastolic time much improved diastolic time for coronary filling. So that is going to bring down your diastolic pressure, LV-EDP, and that is going to improve your heart failure. So that is how it works. It reduces heart rate, improves diastolic time, improves diastolic filling, and your LV-EDP comes down.
That's more appropriate. Yes, sir. Yes.
Thank you,
Thank you.
Dr. Shankar and Dr. Prabhakar sir, for the wonderful discussion. Many more take-home messages for us. Thank you for...
Thank you.
Use NT-proBNP more in your clinic. If you want to take one message from the whole thing, use NT-proBNP more in your clinic.
Yeah, that's a great message for all of us. Yeah. And we have a question session for our first talk by Professor Dr. N. Narasimhan. Any questions to Professor Narasimhan, sir? Please be in the microphone.
Sir, I got a question to you, sir. Sir, regarding the newer siRNA molecule, lipodesiran is a molecule, I think so, a single shot of it can bring down the LPA to nearly to 90%. It's a SI, as you mentioned about the 3 or 4 siRNA molecules. The lipodesiran is one of the latest which is added to the armamentarium.
The small interfering RNA are actually in the experimental stage. Some of them had completed the phase 1, some of them have completed phase 2 trials. We need to get the information only after phase 3 trials. Till that time, we are totally ignorant.
Sir, regarding
the future, I'll just tell you something about this. This is something that's coming up, sir. The gene mapping and the genetic changes, there is this double-stranded DNA that can be altered, and once in a lifetime you give this through a carrier vector. It goes, changes the DNA, and there is a permanent treatment for LDLs. This is the future. Small interfering RNA, classical example is inclisiran.
That is available, sir. Inclisiran is available in the market.
Inclisiran is there.
And one thing I would like to appreciate at this forum is, I'm happy you brought up that pneumococcal vaccine as well as the flu vaccine, sir, because heart failure is an immunocompromised state. So people don't think about that. I'm very happy you thought about it, because in many forums I raised up this issue only after saying that, then they take it in a half-hearted manner. But you have brought it through you, sir.
I think with regard to the heart failure, you people were discussing about it. And there is a passing mention by Dr. Sundar saying that statin was covered by Dr. Narasimhan. I did not talk anything about the statin role in heart failure. What is your preference of statin? What are the controversies actually behind statin therapy in patients with heart failure?
See, I wouldn't take the controversy. See, obviously, most of the patients who come with a garden variety of heart failure, whatever we discussed, if you want to put it as, I mean, what is the risk category they fall under? They fall under a very high risk category. In fact, most of the patients have some form of atherosclerotic cardiovascular disease underlying. Forget heart failure. And heart failure as a mortality issue, it has higher mortality than the worst of cancers. And most of these patients are going to get hospitalized, at least 50% of them get hospitalized in the first 6 months again. And at least 50% of them are not going to live more than 5 years. So we are talking about the most highest risk category of diabetic patients who develop cardiovascular complications. So I think I would straight away go in for a high intensity statin in most of these patients and try to get the LDL down to less than 50.
So it's two points here. One is heart failure with atherosclerotic cardiovascular disease, without atherosclerotic cardiovascular disease. Without atherosclerotic cardiovascular disease, there is no role for this. Clearly, there is no role. If you want to give for a diabetic, for the diabetes you give, that's fine. But for heart failure per se, there is nothing much. But if you have atherosclerotic cardiovascular disease, go for those. Having said that, you will also notice that heart failure patients have a low level of cholesterol. The reason is because of the cachexia, they have low levels of LDL. That is also known. Per se, statins, heart failure, there's nothing direct. Per se, there's nothing direct. So I don't think there's anything much to talk about. Yeah, so correct. So depending on diabetes, atherosclerotic cardiovascular disease, treat that. But for heart failure itself, there's nothing. Not even antiplatelet agents.
If the patient is a diabetic and if it had already been started on statin therapy, he jumps into failure, what will he do at that stage?
Diabetic going into cardiac failure. You're treating the diabetes, I am treating the heart failure.
Thank you, sir. Thank you for the wonderful session. We'll conclude this session for want of time. We'll have a discussion after some time. We have oration to follow it up almost. Thank you, sir. Thank you, everyone.
Thank you. I think the whole meaning of 3D conference is that dialogues and discussions in diabetes. I think that has been achieved during this last 45 minutes or so. Thank you, Dr. Narasimhan and Dr. Prabhakar and Dr. Sundar. Thank you very much for instigating everybody to discuss. Now we are going to embark into one more important aspect of our conference, giving Dr. C.V. Krishnaswamy oration. Okay. Dr. C.V. Krishnaswamy, who is affectionately called as CVK. So I have been, after my initial education under Dr. M. Vishwanathan, Dr. V. Mohan and Dr. Ramchandran, and then after that I joined Dr. C.V. Krishnaswamy. And then he has told me not just medicine and diabetes, but he's told me the philosophy of life, how do we lead, and also the aspect of taking care of the downtrodden. Also, he has taught us. And then he took us to VHS Medical Center. We were associated with him. And it's a great experience for almost 15, 16 years. And prior to that, I still remember when he took me as his assistant, he spoke to Dr. Mohan and Dr. and Dr. M. Vishwanathan and said, this boy has come to me, can I take him? And both of them said, yes, you should take him. I still remember that. So that was it actually. So I'm really honored to be been associated with him. He has been with VHS Medical Center. He has done a yeoman service towards the more than 700 type 1 diabetes children, where he has provided free treatment and also giving insulin and travel grants to come from their villages to come here, and soft loans for self-employment, and so many things that he has done it from VHS Medical Center. We produced a few papers as well, more practical papers along with him. So, Dr. Prema Krishnaswamy, his better half, was also a very, very popular obstetrician and gynecologist, and taking care of both together, took care of both the downtrodden and the elite of the society as well. Both he has taken care of them. And they were blessed with 2 daughters. One is Sundari and the other one is, so 2 daughters. And then today we have his son-in-law also, Rajaram is here. And then his son-in-law, one more son-in-law, Chandrasekhar, Dr. Chandrasekhar. He's taking care of his clinic now. So basically we instituted this award, basically that oration, is basically for those people who have done original research work, which he also believed in. And then we need to recognize them. And most important thing is why I named this as Dr. C.V. Krishnaswamy oration is that though he is not here in this world today, I would like to keep remembering him year after year. And that is one reason. It was an emotional aspect. That's the reason it has been instituted. And we have an excellent orator today, and we'll be introducing him. Before that, may I call upon Dr. Professor Sundaram and Professor R.S. Hariharan to chair the session, and also Dr. Chandrasekhar. He will be the chairpersons of the meeting. And can I ask Ramesh Chandrasekhar? And before that, sir, would you like to have some few words about Dr. Mohan?
Good morning to all of you. I have to share one important CVK, to CVK, sir. I was a student and a professor at MBX Stanley Medical College. I have become a professor, and now Dr. Mohan was my student, and he is going to deliver the lecture. This is a great occasion for me to be happy. So I have come for this. Welcome.
May I invite Professor V. Mohan, sir? Please come, sir. So, Dr. Mohan, sir, thank you for accepting immediately, and then it is an honor for me as your student. And I know Dr. Mohan, apart from taking away, going to read the citation, I would like to have some experiences what I had with Dr. Mohan as well. As a young guy, student, I was working at MB Hospital for Diabetes. Believe me, I would like to say very emotionally, sir, he's one of the biggest supporters I had during that time. I can't imagine, I cannot forget his support that he has given, not only in teaching and various other aspects as well. Sir, thank you, sir. I've been honored to be your student, and then also I'm really grateful to you, sir, throughout my life. Thank you. And I would like to call upon R.P. Rajesh to read the citation of Dr. Mohan.
The organizing committee of 3DCon 2025 have immense pleasure in awarding Dr. C.V. Krishnaswamy Oration Award 2025 to Dr. V. Mohan. Dr. V. Mohan is the chairman of Dr. Mohan's Diabetes Specialty Center at Chennai in South India, which is an IDF Center of Excellence in Diabetes Care. He is also the chairman, Madras Diabetes Research Foundation, which is an ICMR collaborating center of excellence and Asia's largest standalone diabetes research center. His main research interests are epidemiology of diabetes and its complications, genomics of diabetes, including monogenic diabetes, precision diabetes, and nutrition in diabetes. Deeply interested in research from his undergraduate medical student day, he has published a record of over 1,765 papers in peer-reviewed journals, which include 1,140 original articles. So his research has attracted over 216,000 citations and has a H index of 155 with I-10 index of 959. Dr. Mohan is ranked among top 2% of the scientists in the world by Stanford University, and also among the top 0.01% of researchers in type 2 diabetes by the Expertscape. He has received over 220 awards, including the Dr. Harold Rifkin Award and Dr. Kelly West Award by the American Diabetes Association, and the FRS from the Royal Society of Edinburgh, And for his extensive contribution in the field of diabetes, in 2012, Dr. Mohan was awarded Padma Shri, the 4th highest civilian award by the Government of India. He has also been confirmed Lakshmipad Shingania Award in the category of Leader in Science and Technology given by the IIM Lucknow from Her Excellency the President of India, Srimati Draupadi Murmu. He also provides lifelong free treatment to thousands of poor patients from the free diabetes clinics established by him and conducted over 3,000 free diabetes camps, including several along with the Sri Satya Sai organization. He has published nearly 40 books on various subjects ranging from diabetes, wellness, motivation, and spirituality. Dr. Mohan's autobiography, Making Excellence a Habit, The Secret to Building a World-Class Healthcare System in India, and his book titled Banting, Bose and Beyond are the best sellers on Amazon. So it is indeed a great pleasure and honor for the organizing team of 3DCon 2025 to present the Dr. C.V. Krishnaswamy Oration Award to Dr. V. Mohan on April 26, 2025.
And one more thing is that he is also the maximum viewed on YouTube also. The lakhs of people are following him in the YouTube. I think he is the #1 in the country and #1. And the other thing is that he is the only Indian who has taken the 2 awards from American Diabetic Association, which is no mean is small. Rajaram, would you please come on to the dais? Come. His family member, Dr. CVK's family member. Rajaram, please come.
Dr. Vijay Kumar, Dr. Hariharan, Dr. Sundaram, Dr. Ramesh, all the other organizers who are here. It's a very, I would say, emotional moment. Already when the introductions were being made and when Dr. Sundaram was talking and Dr. Vijay Kumar was talking, memories keep flooding in. As you grow older, what we live on is memories. And here we are seeing several generations of memories. We saw the picture of Professor Moses, Professor Sheshaya, Professor CVK. Dr. CVK, I knew when I was in school, not when I was in medical college, because his association with my father, Professor Vishwanathan, whom he considered as his guru, was a very close one. My father had some people who were extremely close to him. One was Professor Dr. M. Krishnamurthy, and the other is Dr. CVK. They were not only working with him in the hospital, doing teaching, research, publication, but they had a very close personal touch with him. And therefore, I have heard Dr. CVK, I have heard of his writings, even when I was in school, because I didn't know at that time I'm going to do medicine. I thought I'm going to do English literature, which was again one of Dr. CVK's strengths, because his English was par excellence. He was an orator par excellence. His English was something which we looked up to as students, and then when we became medical students, sheer pleasure of listening to him talk. He would quote poetry, he would quote so many things from English literature. He had a very deep passion for English literature, which is something which I also shared. So that was another aspect of Dr. CVK that I knew. He not only was working in diabetes, but also in chest diseases. Some of you may not know that he ran the chest clinic in Stanley. So he had multiple talents, obviously. He had finished his MRCP in England, then came back, and then he was doing diabetes and he was doing chest diseases. And then I think the big move for him was when he not just started his private practice, but then started his work as VHS. And at VHS, his empathy to poor children with type 1 diabetes came through very strongly, because he believed that these unfortunate children, he was one of the first actually to start free treatment of poor children with type 1 diabetes at a time when very few people were doing that. The government institutions used to do that, but then outside of the government sector, through an NGO, through a charitable kind of an organization, he was the first in India to do. Today, we see all over India many people taking the lead, but many may not know that he was the first. And then through his late wife's interest, Dr. Prema Krishnaswamy, another very lovable, very loving, very efficient and very popular obstetrician and gynecologist, who had as big a practice as him, came his interest in diabetes in pregnancy, gestational diabetes, type 1 going through pregnancy. And he also made it a point not just to treat the children with diabetes, but to find a vocation for them, to see that they are gainfully employed, which today we take for granted. But imagine 30, 40 or more years ago, that was absolutely new. People came, gave insulin, and then sent them. But he went far beyond that. And of course, in his later years, he also started experimenting with other systems of medicine, and had strong beliefs that alternative systems can also play a role. And he has done some seminal work on that also. These are areas which we would hesitate to enter because we know nothing about it. But he made a mark there also by studying various other non-traditional methods. He always believed that it's very important to avoid side effects of drugs, and he would never give any drug to anybody if he thought that there was even a 1% chance of that patient developing a side effect due to the drug. So these are all, including metformin. So these are all very, very strong traits of a compassionate human being who went beyond the call of duty. And for somebody who was trained in England, who's developed the Western way of thinking, to have all these kind of traits is very admirable. And therefore, you know, my connection with my father and then Dr. CVK, and to deliver an oration in his name, arranged by his colleague and student, Dr. Vijay Kumar, who is also my student. All and so many generations come in. It's not often that in an oration you're able to bring in so many, and then to see Dr. Hariharan, Dr. Sundaram and others and the family members of Dr. CVK also here is a very unique occasion. So I salute Dr. CVK. I thank Dr. Vijay Kumar for all the kind words. We have many students who pass through our hands, but generations, one generation later, decades later, to have the same close connection that we had when they were students, with no jealousy, no competitive spirit coming, but only love and affection coming, is a very rare thing. In professions, it's very rare. Not only in our profession, in any profession. After some time, people start considering even their own progeny and their own students, their own proteges as being their competitors. So that has never been the case in Dr. Vijay Kumar's, and that again is a sign of his humility and his love and affection. So I'm totally bowled over today and very humbled to present this oration. Thank you, Vijay Kumar, once again. I know you're not the only one. There are many people who help you. I've been in that WhatsApp group, and right from yesterday I've been seeing all the pictures and the emotions of different people. That shows the love and affection that people have for you. I wish, this is I think the 9th edition, if I'm not mistaken, 9th. So very soon I think you'll be finishing your 10th and then going on to the Silver Jubilee of 3D Con. So my blessings to you to continue this great work. The kind of discussion that we just listened to in cardiology a few minutes ago was truly outstanding, something which is very much needed in this day and age. I cannot but show the picture of my father because this is Professor Dr. CVK's oration, and my father would have been very pleased that I'm delivering an oration in his student's name, and Professor CVK would have been very happy that I'm showing my father's picture here. And of course, he knew Rema very well because she had actually consulted Dr. Prema Krishnasamy on different occasions, and we had quite a close relationship. It's always customary that when you've finished an oration, you thank the people at the end. But I changed the order, and I said, let me thank all my colleagues who have worked with me, because I always keep telling them, mention was made of the number of awards I got and all that. I keep telling my staff that the reason they are giving me these awards is because I'm a very good courier boy. So I go to Delhi or I go somewhere, I pick up the award and come and give it to you. And courier, no problem with the courier service, and it's done free of cost. And that's why they give me the award. The award is for you. I'm only the postman or the courier boy who goes and picks it up. So this award also I take back to my center because these are the people who do the work, although I do get the credit. Vijay Kumar told me to talk on epidemiology of diabetes because he said the Kelly West Award, which I received at the American Diabetic Association, that's considered the highest award in epidemiology in the world. So, and I was the first Indian to deliver the Kelly West Award. So he said, many people may not have heard the Kelly West Award, so can you model yourself on that? That again was interesting because that also took me down kind of memory lane when I presented the Kelly West Award, because I had to kind of go through 50 years of what happened in not just India but in South Asia. And so very briefly I'll try to do that today. I have no conflict of interest to declare. Most of these studies are from Indian government agencies, but we also have support of NIH, which hopefully will still continue. We have had some fear whether it will stop. But the good news is that just yesterday I heard that 2 grants which were awarded before the latest president came to his seat has now been approved. And so we are going to get it. We thought it's gone. All the grants are gone. But it looks like some of them will continue. So we're very grateful to that. Of course, UK funding has also been there. For those of you who are not at US, when I received this award, there's something very special about the 2 awards I received from the American Diabetic Association. The last time I received the award, the Harold Rifkin Award, that was for International Service in Diabetes, that was exactly 6 years before this award. And what was very interesting and what is a coincidence was that it was in the same city. So as you know, the ADA rotates, and it goes, this year it's in Chicago, next year it's New Orleans. So it keeps rotating to different cities. And the last time when it came to Orlando was in 2018, when I got the Harold Rifkin Award. And after that, the next time it came to Orlando was 2024, when I got the Kelly West Award. So when I started my lecture at the ADA, I said, bring it more often to Orlando. I may be getting more awards. So I was jokingly telling them. This also has a historic importance to me, because the person standing to my left is Dr. Mandeep Bajaj, who is the son of Professor J.S. Bajaj, one of the very well-known diabetologists of India, who was also the president of the IDF. And the only time IDF has ever come to India was in 1976, when Mandeep's father, Mandeep was in, I think, college or something at that time, or school at that time. And that is when his father brought the IDF to India in 1976, and that's the year when Professor Sheshaya actually attended his first IDF Congress in Delhi. And then years later, I get this award from his son, who later rose to become, because Professor Bajaj had said that his son will become the president of the Diabetic Association of India. But fate had it otherwise, that he actually became the president of the American Diabetes Association, not the Diabetes Association of India. So that was another coincidence. So one of all the awards which are presented at the ADA, there are about 8 or 10 awards. Only 2 are published, the Banting Lecture and the Kelly West Award. Only these 2 are published. They are invited talks, and the editor always attends the lecture to make sure that it's publishable. And there's no guarantee it will get published because it gets peer reviewed, but they cannot normally refuse because they've given you an award, they usually have to, but it goes through very tough peer review. In this case, 4 people actually had reviewed it and gave me very tough comments also. But in the February issue of this year, this lecture was published, and it's received quite a bit of acclaim since it has published. The story actually starts in 1972, and that's very significant for me because that's the year when I joined my father in doing my research on diabetes. I joined MMC in 1971, but 71 to 72 we didn't do anatomy physiology. Those days we did pre-medical, so we had English, physics, chemistry, biology, and statistics, which was later discarded. So but when we joined the first year, so my passion was English literature. So my entire 1 year I did only English. I didn't even study the other subjects. I said 1 whole year I would have to study English. But then in 72, when I joined anatomy physiology, I joined my father and said, okay, now I have to start working with you. And the same year, from All India Institute and Professor O.P. Gupta from Ahmedabad published the first multi-center study of diabetes in India. Until then, there were studies published. CVK and my father had published, Professor Moses has published. They were all based on urine tests. And the way they would do it is they'll go to an exhibition and collect all the people who come there and then do urine sugar. There was no glucometers at that time. Lab was very difficult to do. So they'll do urine tests for people and report some tests. But for the first time, blood tests were done in this study. And when they call it multi-center, there were 6 cities which were selected. Chennai was not one of them. So there were 6 cities selected in India and 1 village near those 6 cities. That means 1 urban, 1 rural, only 1 village, just randomly selected 1 village. So that became a multi-center study. And in that study, which was published in 1972, Professor Ahuja and Professor Gupta, actually there were 2 slightly different studies, but they were published together the same year. In those above 20 years of age, the prevalence of diabetes in adults in these major cities, Delhi, Trivandrum, Ahmedabad, and a couple of other cities which were studied, it was 2%. That means if you study 100 people, 2 of them will have diabetes. And in rural areas, it was less than 1. The figure went up because in Ahmedabad, in rural area, they got a slightly higher figure. So it became about 1.5. So to remember, you can say 2%, 1%. So 2% of all adults, remember these figures when I go on, because 2% of all adults in 1972, that is 53 years ago, when that study was published, had diabetes. My father, why I put his photo here, when this study was published, one of the first things he taught me was, and he made a statement, is that Mohan, diabetes in Indians is a migrant Indian phenomenon. Indians have the gene, but we don't have the environment to get it. But when Indians go abroad, they will get diabetes. So a series of studies were published. They are all of different criteria were used, different time frame, but these are all the available studies at that time. So what is very interesting is that wherever the Indians, remember 72% Indian data from those countries where Indians have migrated either to Canada, US, UK, Tanzania, South Africa mostly Tamils, and then of course Malaysia, Singapore, again Tamils, and then Fiji and Mauritius, North Indians. So wherever they went, the diabetes prevalence are very high, mostly about 10%, 11%, 11%, 7%, 13%, 11%. So my father was right that the same Indians, same Tamils, they have gone somewhere else and their diabetes rates have gone up 5 times. Okay? Of course, one of the 1989, but more prone to diabetes, more prone to hypertriglyceridemia and so on, which I'll show you in a minute, and also more prone to heart disease at a very young age. In 1984, I worked in the UK for 1 year as a Wellcome Trust Fellow. So at the Hammersmith Hospital where I work, which is the premier, now it's called Imperial College, it's the premier most hospital in the whole of UK, Hammersmith Hospital. When we looked at the myocardial infarction rates below 40 years of age, this is in London, heart of London, in Hammersmith Hospital. When we looked at all the myocardial infarction rates below 40 years of age, there was not one single white man, not even one, who's admitted in the ICU with a heart attack, was a white man. They were either South Asians or black people. So below 40, no heart attacks in white people. So striking, 100%, that not even one white man had got. So we started thinking there's something which is making us get heart attacks at a young age, and of course diabetes was one of the prime thing. Same thing in Singapore, same thing in Canada, same thing in Malaysia. Wherever you study, the Indians standing out. Now, repeated studies were done in Singapore, 1990, 2000, 1980, 90, 2000, 2010. In everyone, the rates went up. Okay? So if the Indians are there, Malays are there, and Chinese are there, 10 years later, all the 3 went up. But the gap is still maintained. Indians are still the highest. 10 years later, all went up. Again, Indians are highest. Till today, if you ask me why is that so, we don't have an answer. Even today, I'll show you some theories and some things, but we really don't know the exact reason why we are so prone. And that's why when Dr. Narsingan says about statins and taking statins and all that, I entirely agree. Because anything you can do to reduce that risk, you should do. We should not dilly-dally thinking, oh, we won't get it. We will get it. The rates are so high. So that is lesson number 2, that South Asians and Indians, I use the word South Asians there because in the audience you'll have Pakistanis, Bangladeshis, Sri Lankans all sitting there. And for US, they don't know South Asians, Indians and all. Their geography is only New York, New York. New York to California is like a different country for them. So at least Asia, they can understand better than India. That's why you use South Asians there. So have higher prevalence of type 2 diabetes compared to other ethnicities, including other Asians. If it is all Asians, then why are you having more than Chinese? Why are you having more than Malays? So even within Asia, we are the highest. South Asians, people who belong to 8 countries, Pakistan, India, Bhutan, Nepal, Sri Lanka, Maldives, Afghanistan. These are the places from where we have very high prevalence. If you go a little more to the east, Thailand is different. Korea is different. China is different. The South Asians seem to behave in a very peculiar way. Meanwhile, so what did my father say? It's a South Asians, Indians, migrant Indians who get diabetes. But then India is changing. India also a lot of changes taking place. 1991, something very important happened. India became completely bankrupt. Complete bankrupt. Until then, until 1960s, we didn't have food to eat. The ships had to come from US carrying wheat. It will come to Chennai only. Chennai harbor, ships will come. Almost every 3rd day, 4th day, one ship will come carrying a lot of wheat. That wheat will get distributed through the public system and the headline will come in the paper. Don't worry, 2 more weeks we have food for India. We are living from ship to ship. Only the ship comes, India has food. Then they changed it. M.S. Swaminathan, C. Subramaniam, they said this is not good. And because they were getting the food through the PL 480 scheme, and they started tightening us for giving us the food. You know how they are. They give you, they start bullying you. Then they said, no, we will make our own food. So the Green Revolution came. Green Revolution came, but people didn't have money to buy food. And India had a policy where foreign investment is not allowed at all. 1991, when they realized that the whole country is totally bankrupt, it's now or never. If they don't open up the country, India is finished. So Manmohan Singh, as the finance minister under Narasimha Rao, opened up the economy and said, bring in all the investments. The moment that gate was opened, like a flood, things started coming in, economy started booming, liberalization, globalization, all that is from 1991, okay? Socioeconomic status improved. People are now able to get more food. They're able to eat. They're able to get scooter, something else. Those going by cycle are now going by scooter. Those are scooter going by car. All changing. The whole lifestyle is changing. But then, as the economy grew, diabetes also increased, and type 2 and obesity also increased. And that, if you draw a line there, 1991, from the studies that are available in India, I've drawn a line at 1998. Economy opened up in 1991. Up to 1988, diabetes prevalence was in single digits. You can see 3%, 4%, 5%. It's not come to double digits. 91, we open up. The next study which has come is Ramchandran study in Chennai, 11%. It's already crossed 10%, okay? 11, 12, 14, 15, 16. The last study we did, apart from INDAB, which I'll come to in a minute, was the two-center study which was funded by NIH, CAR study, Nikhil Tandon in Delhi, and we in Chennai, that was published about 10 years ago. 22% in Chennai of people above 20 years of age have diabetes, and in Delhi it's 25%, 1 in 4. Remember the figure 2%, 1%, 1972? Now we're talking about 2015, 23% and 25%, 10 times it has increased, okay? In the same cities where it was studied earlier. Look at rural, same thing, 1%, 2%, 6%, 14%, 16%. In the INDAB study, which I'll briefly mention about, in rural Kerala, the prevalence rates of diabetes are higher than in urban Kerala. It's actually going the other way. Just like in the West. In the West today, the poorest people have maximum obesity and diabetes, and the rural people have more diabetes, and exact opposite of what we see here. In India, it's changing. The same thing is happening. We're about 10 years behind, same thing is happening now. So at this point, when this study came, 2015, the study came, I said, it's time to visit my father's hypothesis. He said it's a migrant Indian phenomenon. That time it was 2%. Now it is 25%. What is happening abroad? Is it 40%, 80%? What has happened? So let's do a study. So we collaborated with the Masala study in US. That's the only place in the US where they have two cohorts, one in northern Chicago and the other in the Bay Area in California. So Dr. Alka Kanaya in the Bay Area and Dr. Kondala Namrata Kondala in northern Chicago. So we collaborated with them, did the same age group. They study only above 40, because below 40 they don't even get diabetes in the white people. So they studied above 40. We studied above 20. So I said, okay, we'll also study above 40. We'll match it, same method, same diagnostic criteria, same everything. Age group, everything, right? Here are the results. This is published in Diabetes Care. Red is Indians in Chennai. This is not done in Delhi, it was done in Chennai only. This is diabetes in Chennai, cure study, representative population of whole of Chennai, okay, 26,000 people. Now, if you look at 40 to 44, 45 to 54, 55 to 64, 65 plus, whichever age group you study, yellow is Indians, this is not white people. This is Indians in US, the migrants who had such high rates when my father was there. They are actually having lower now. We have beaten them. Why? Why is that so? It's a different socioeconomic class. They are not poor laborers who are there. They are the richest people who are there. They are among the richest people in the whole of US. They are the ones who funded the president. Okay? So they are very, very rich people. So they take care of their diet, they take care of their weight, they are exercising regularly, they have cut down on the rice and they are eating the right food, they are eating a lot of salads and they are very health conscious. So their diabetes rates have started going down or stabilizing. We are still growing. We are a growing economy. We have not reached that stage at all. Therefore, we are now having higher rates than in the US. And therefore, the third lesson I learned is that in 40 years from my father's time, the clock has come a full circle and diabetes rates in native urban Indians here, this is urban, I'm not talking about rural, rural is much lower. In urban Indians, but that's also urban, that's also not rural, okay, is higher than in migrant urban Indians. So the whole clock has gone. So it's no longer a migrant Indian phenomenon. My father died long before this, so I don't think he would have even imagined that one day this will all completely change, that we'll have more in India than in the US. Now comes the ICMR in-depth study. So as there's a lot of history and a lot of emotional things now, I talked about my father, then I talked about my generation. Now enters the next generation, my daughter. So she was in school and she started seeing all my studies. And when she joined medical college, she said, I want to talk to you. So I went to her. So she said, what? She said, can I be frank about all your studies, all your cure studies, whole Chennai and all your studies, something Delhi you did. Can I be very frank with you? I said, yeah, you have to be frank, no? They are totally useless. Only a daughter can say that, you know? They are totally useless. I said, I produced 160 papers, all useless. I said, why? Can you tell me why they're useless? Because you're using the word India. Chennai is not India, Papa. So I said, what do you mean Chennai? Chennai is also India. Chennai is also India, but Chennai is not India. So I said, then what is India? India is India. We have to study the whole country. I said, we are clinicians. How can we study the whole country? Is it our job to go and study Manipur? And she said, yes. Leave it to me. I'll do it. So I went to ICMR and said, this daughter of mine, you know, please tell her no, and please tell her not to do such a study. Because they said in Nagaland, if you go and do a study, they'll cut your head. Okay? All kinds of fears like this were there. So I said, I want my head. I don't want to be chopped off. So please discourage her and tell her that such study cannot be done. We had Dr. Ganguly, who was the Director General. So he said, brilliant idea. Ask her to do it. We will fund it. Gone. So now we are stuck. So I said, you're going to do this now. You're going to go to all over India. She said, please. This is my dream. Allow me to do it. So that is how the world's largest, it's not 113,000 now, we have crossed 124,000 because when this was written, we had not done Jammu and Kashmir, we had not done Andaman, Nicobar, Diu, Daman, Lakshadweep, all that is not done, all done now. So it's 124,000 people. It became the world's largest, most ambitious epidemiological study on diabetes ever done. Nobody has done this. Because when you do a study in China or US or Germany, you pick one here, one there, one. You don't go to every state and study every state, and that too not a country of 1.4 billion people. It's almost impossible. In fact, not only Lancet published this main paper, which became now one of the most talked about papers. In fact, earlier this year, she got in January this year, ICMR looked at all its papers published in the last 5 years in the country. All fields, every specialty, they wanted to select the best paper ever published in India with ICMR funding. She won it hands down. There was no competition at all because this size of a study had never been done in hypertension or heart disease or in any other TB, nothing else. So she won it hands down. And this is one of the most quoted papers. Any conference, anywhere you go in the world, this paper is shown. Okay? So this became, and the numbers for India, which she wanted, she said there'll be huge variation within India, Papa. You mark my words, I'll show. The prevalence rate of diabetes varied from 4% in Bihar and Uttar Pradesh to 26% in Goa, Puducherry and Kerala. I would never have imagined that it will be so low to so high, all done in the same way. In fact, what I'm not showing here is, after the study was published, Lancet wrote to us and said, I don't think such a study has ever been done in the world. So can you write an article on how you did the study? We want to publish that also. So we wrote another article in the same journal on how we did the INDIAB study. That itself became an article by itself. What are all the challenges? For example, we were kidnapped in one place. Bow and arrow was shot at us. In Mumbai, we got arrested because they said, you have got only permission from Maharashtra, but not from Mumbai. We said, Mumbai is the capital of Maharashtra. They said, no, you must get from Mumbai. And since you got only Maharashtra, you're going to jail. So they took our people to jail. Then we had to get facts from ICMR to release those people. In Nagaland, we were kidnapped. In Manipur, they shot arrows at us. All kinds of things happened. Nagaland, luckily, they didn't cut our head. So it's a study which is almost impossible for anyone to do. But that gave us the numbers for India. That's what she wanted, not only for diabetes, but also for pre-diabetes, hypertension, obesity, abdominal obesity, and hypercholesterolemia. Is the Asian-Indian phenotype of diabetes different? There are at least 13 differences. We talked about Indians not only having more diabetes when they go abroad, but also more than Chinese, Malaysians, and all the others, Fiji and Melanesians and all these people. Why is that so? Over the years, many colleagues, Dr. Yajnik, Dr. Ramchandran, many people have worked on this, both in India and abroad, Dr. Anup Mishra, and at least 13 differences between type 2 diabetes in India and the West have been shown. I'm not going to go through all of them, but I'll show you one or two of them. The first one is the lower age at onset. We get diabetes 10, 20 years younger. Why we're getting it 10, 20 years younger without obesity still remains a question. There are some genetic factors. I'll come back to that. But the second point, high insulin level. You remember I told you I went to Hammersmith Hospital, and there we were studying all the people below 40 years and looking at heart attacks, and there was nothing in the white man and only in Indians. We started looking at what can be the possible factors. That time UKpedia study was just started and it was going on. So I went to the lab and said, let me see all the biochemical parameters, because UKpedia had recruited both Indians as well as Europeans. I was just eyeballing the whole thing. Suddenly something struck me. The Indians seemed to be having higher insulin level. Now, I showed it to my boss, and she said, why should Indians have higher insulin level? I said, I'm sure it's correct, because here's the statistics, age matched, gender matched, everything matched. She said, present it in the, so British Diabetes Association meeting was coming. So I presented it in the UK British Diabetes meeting, and Bob Turner, who was doing the UKpedia study, came for my poster. So he stopped at my poster, and he said, Mohan, either you're terribly right or you're terribly wrong. Both are very important. If you're terribly wrong, get rid of it immediately. Some goof up somewhere, now's the time to correct it, you correct it immediately. If you're terribly right, you're discovering something. I have never heard one race having higher insulin than another. This will be the first time in the world that somebody is showing this. So either way, you have to do it. So I said, how do I do it? I've got the values. He said, you have to do clamp studies. You have to do clamp studies and prove that if you have higher insulin level, they're more insulin resistant. So you have to do clamp studies and then prove it. I said, okay, let's do that. So the first thing was the paper. So that got published in Diabetologia. Shown in red is the insulin level. This is non-diabetic people, and this is diabetic people, just diagnosed. In UKpedia, GTT was done, just diagnosed that day, okay? And you can see that both in normal, these are people who have normal GTT. GTT is normal. To maintain the GTT normal, Indians had to put out so much insulin. Only then the GTT is becoming normal. And then when they're just diagnosed, of course, already it started coming down, but still it is slightly higher on the day when they are diagnosed. So this is clear proof that, and they're all age matched, gender matched, everything matched. So Indians are having higher insulin levels. Then listening to Bob Turner, we did the clamp studies. So when you do the clamp studies, we calculate what's called as the M value, so glucose uptake. How much insulin is needed to keep the glucose levels normal. So the Indians were more insulin resistant. So when you presented this and published this, for the first time in the world, a racial difference in insulin level and insulin resistance was established. Very soon, 12 other groups confirmed this. So it became known that South Asians are more insulin resistant. So if they're more insulin resistant, why should they develop diabetes. And where is this resistance coming from? I'm just cutting short 30 years of work. Is it the subcutaneous fat? Is it visceral fat? Is it the liver fat? These are places where insulin resistance comes. This is a 2024 publication, I think, which looked at, no, 2022 publication, which looked at all the published studies in South Asians as well as white Europeans, and looked at all the studies which have been done. Moral of the story is, there is fat everywhere in the Indians, but it's a liver fat which seems to be the most prominent. That is why we have MS, LD so much. That's why we're having so much of fatty liver and whole thing, insulin resistance. That is why we are having so much of heart disease. All that came in there. So this lesson number 4 is that we have greater insulin resistance in the early stages of the natural history of diabetes. When I presented in June last year at the ADA, there was not one paper had not been published. Soon after I published this, and it came up in the ADA, why are Indians having higher insulin resistance? Why are they having more ectopic fat? All these questions came up. I didn't have the answers. The answer came just a month or two after my Kelly West lecture. So I told the editor, sir, I have to include this because this is very important. I didn't talk about it in my lecture, but there's a continuation of my story. He said, yes, include it. So what they did in Glasgow was, it's called as the Las Vegas study. And what they did was, they took South Asians, they took white Europeans, and said, we are going to feed you more. We're going to feed you more. It's an experimental study. Those who volunteer can come. Of course, they matched them and all that, and gave them excess calories. And they said, we are going to study, do biopsy for you, do CT scan for you, do MRI for you, do everything for you, and see how the fat is moving in the Indians and in the Europeans. To cut a long story short, this is a breakthrough paper, so by Jason Gill and Navid Sattar. So what they actually showed was, if you overfeed the Indian and you overfeed the white European, the white Europeans have a lot of small adipose tissue in the abdominal wall. So when you eat more, those start getting expanded, their abdominal wall increases, the fat doesn't go inside, it stays there. The Indians, due to some genetic defect, have less of those. So very quickly it saturates. And once it saturates, the fat cannot stay there. So it has to go inside. So visceral fat goes up. The visceral fat cannot circulate for too long, go into the liver. Okay? So that is a breakthrough paper which came. And that is explained here, that when you take too much of calories, particularly carbohydrate, you get the subcutaneous stores get overwhelmed, partly due to genetics, and then there is fat spillover, which goes into the liver, muscle, pancreatic beta cells, so beta cell function also goes down, insulin resistance comes, and even in the heart. And that's why you have epicardial fat being more, which is why you need higher dose of statins and lower, our LAI publication shows that we need lower LDL cholesterol than what the others have. Now, insulin resistance is one thing, but to get diabetes, you need insulin deficiency. So where is this insulin deficiency coming from? This is a very large study, again 26,000 people in Chennai. We went to their homes and we did GTT in their homes. We did fasting, 30-minute and 2-hour value. Why we did 30-minute? Because we can measure insulin level at fasting and 30-minute and calculate what's called as a disposition index. So disposition index is in yellow, that's the insulin secretion, and red is insulin resistance. Now, these are people who did not have diabetes. We asked them, do you have diabetes? No. Do you have pre-diabetes? No. Are you on treatment? No. Okay. Then we'll do the GTT for you. Those who are normal glucose tolerance have the highest insulin secretion. By the time they come to IFG and IGT, the pre-diabetic part, especially if they have combined IFG and IGT, the beta cell function is dropping very rapidly. So we are not able to sustain that. We produce a lot of this insulin, but the fat is producing the resistance. The fat is also in the beta cell, and therefore we are failing. So we become diabetic. These are newly diagnosed diabetic, just detected. See how much beta cell they have lost. So the message is, you have to hit hard and you have to hit early if you want to prevent diabetes. If you're going to wait for everybody to come, so much of beta cell is gone. The cardiologists are not scared of talking about time is muscle. They time to, the needle. How much time? 30 minutes, 40 minutes, 60 minutes. They talk about it. But we don't even talk about pre-diabetes, we don't talk about anything. We wait for people to, oh, a little pre-diabetes, okay, okay. You're losing beta cell function. This is a time when we should be preserving beta cell function. And unless you do that, the conversion rates will keep going up all the time. So that is the next lesson, that Indians with type 2 diabetes have severe insulin deficiency. This insulin deficiency is much more than the Pima Indians and all the other Indians and the Chinese and so on. That is why we get it. Now the next question, is this Asian Indian phenotype due to genetic factors or environmental factors? In fact, my guru, Satya Sai Baba, answered this. When he asked me, why is diabetes increasing in India? In an interview with him, I said, genetic factors. Then he said, 1970 and now your genes completely changed, no? He asked me. Then I knew I'd made a foolish mistake. Because same people there, 2%, now 26%. He kind of glint in his eye. He said, all your genes changed in 50 years, he said. Then he said, your diet is not okay. Go and look at your carbohydrate intake. Look at your rice intake. Look at physical activity. Those are the points. It's environmental factors which is driving your epidemic. He explained it to me. So while genetic factors are important, and obviously there are a lot of new genes, we keep studying Jivas. We did 3 Jiva studies published in Nature Genetics and other journals. You do find some odd gene here is only in Indians and so on. They are not explaining the epidemic of diabetes. They're of academic interest. You can publish a paper and say, oh yeah, we found one new gene. It's not going to help you at all. But this is more important. This is a more recent study in England where we collaborated. Now if you look at beta cell function, there are genes for beta cell function, okay? And this is in the white Europeans in blue, and in pink is in the South Asians. The genes for defective beta cell function are different in the South Asians and in the white Europeans. That's coming out very clearly. So there is a genetic component, but most likely it is epigenetic, okay? What about environmental factors? That is very clear from what I showed you earlier. 1960s, we were living like this, okay? The only thing you carried on your head, you carried a lot of weight on your head, and you're agriculturist working in the field, people played, frugal meals, all that changed since 1991 and since 2000 and 2010. We're eating more calories, our boys are sitting, working to American timings, night, their sleep is gone, chronobiology is gone, they're putting on weight, they're eating junk food, calories are going up, everything is changing. The whole thing is completely changed. That leads to 4 things. One is increased calories, especially carbs. Second is less physical activity. And third is some new things like pollution. The data, this study I took up after Baba told me. He said, go and look at your diet data. You've got data that rice and carbohydrate. I know your data, he told me. I have not even looked at my data. He says he knows my data. And he says, go and look at it. You will see that diabetes will go up with increased carbohydrate intake. So we went and we published this in British Journal of Nutrition. You can see that as the carbohydrate goes up, this is all Chennai. Everybody is eating a lot of carbohydrate, but divided into 4 quartiles. This is 200 grams of carbohydrate, that is 400 grams of carbohydrate. 4 times the diabetes is going up, 4 times. Okay? So it goes up with glycemic load, with glycemic index, with carbohydrate. You eat more fiber, it goes down. So it is simply a matter of too much of carbohydrate and less of protein. But this is a cross-section study, although we have adjusted for family history and physical activity, we have adjusted for everything, but still it's a cross-sectional study. So you have to do a longitudinal study. In longitudinal study, what you have to do is, you have to take a large number of people, look at all their diet, don't have diabetes now. Now you follow them for 10, 15 years, how many develop diabetes, and then you go back and see what were they eating. That's the best kind of evidence you can get. That we did in the PURE study. The PURE study now has 250,000 people in 27 countries. It started in India, in Bangalore first, then Chennai, 5 cities in India. Now it's there in 27 countries. It's the world's largest epidemiological study. It's much bigger than INDIAB, because INDIAB is only the largest diabetes study is INDIAB. This is the world's largest epidemiological study. So what we did here was we looked at rice intake and incident diabetes. So does taking too much of rice actually produce diabetes? That's what Baba had told me. So here is the rice intake. South Asia, you can see how much rice is taken. Look at Europe, 0, okay? And other countries. China has also come down. It's now come to 200 grams. So when you looked at the incident diabetes, calculated the hazards ratio, 61% higher risk of getting new onset diabetes. They didn't have diabetes earlier. If you take more carbohydrate, 61% higher risk. Okay, and in China, it's come down because their rice intake has gone down. They're eating more meat and more salad. The rest of the world, it's still significant. Overall, it's also significant. China losing significance. Now the next question will come, what do you do physical activity? You're eating. And some people ask me, oh, in your father's time, then why you had 2%? Because they're not eating that much, number one. Number two, they were eating different type of rice. They were eating more of hand-milled rice and hand-pounded rice, not the highly polished rice. Third, they were doing a lot of physical activity, which we're not doing now. So we looked at physical activity. If you do physical activity, the ratio comes down, the hazards ratio comes down from 50% to 16%. So 34% reduced. It has now lost significance. You see, it's touched the 1. Once it touches that 1 unity, significance is gone. So it is still there, but so much reduced, it is no longer statistically significant. So we published in this paper saying that, yes, white rice is definitely increased to incident diabetes. Later, last year's paper in the Lancet, again we published a paper where we looked at just glycemic index and glycemic load. And you can see that if you're overweight, clearly glycemic index and glycemic load is also, this is in the whole world, not just India. If you take, and it can be any glycemic index and any glycemic, it need not be rice alone. So if you take too much of carbohydrate, too much of glycemic load, you are producing diabetes. We have another paper where we have shown mortality. That is a New England Journal paper where we have shown that increased mortality also occurs if you take too much of glycemic load and glycemic. Of course, I'm not going to go into it. Why, when you take too much of rice, there are so many mechanisms by which we explained it in this paper, why you get more of diabetes. Before I conclude, I must give you some solutions also. It's not enough if you just give the problem. So using INDIAB, we wanted to, you can't do a study for next 25 years, putting people on high carbohydrate diet, low carbohydrate diet, this one. Next 20 years, we'll be doing a study, and nobody will follow a study like that. Okay? Difficult to do diet studies for 3 months. So we had to use mathematical modeling. In science, you can always use mathematical modeling. So we had a very top scientist, mathematician, Sheshadri Srinivasan. So my daughter took up this project, and we started looking at how much of carbohydrate you have to reduce and replace it with what. And one more paper is now coming out in Nature Medicine as a follow-up of this, but this is the Diabetes Care paper, where we showed that from the 60-70% carbohydrate, just 10%, 10 to 15% you reduce. You don't have to cut off all the rice. Cut it by 25%, 30%, replace it with protein. So if you have a thali, just include more proteins, more vegetables, cut the rice. That's enough. That's a solution from India, just increasing protein. Fat you keep the same, but you take healthy fat. Take MUFA or PUFA. New factors are coming in. So we have pollution coming in now. And this we studied because Delhi has a lot of pollution. So we wanted to look in the CARS study, Delhi and Chennai, NIH funded study, where we looked at does PM 2.5 exposure lead to new onset diabetes, apart from diet, apart from body weight, apart from everything else. And we found that yes, not only diabetes, but a big study on hypertension and on dyslipidemia. 3 separate papers showing that all the metabolic pathways can be affected because this is pollution. It is going into your body, it's going into your blood, and it is affecting the pancreas, affecting the heart, affecting the lung, affecting everything. And we wrote an editorial on that as well. So these are my lessons that we have learned for 50 years from the epidemiology of type 2 diabetes. There is a genetic susceptibility, and Dr. Yajanik believes it is due to B12. I'm not entirely convinced about it, but there's probably something to do with B12. This makes you more susceptible to type 2 diabetes from the time you're born. Then from young age itself, this fat starts accumulating because you're eating too much of carbs, excess adiposity, small adipocytes, fat overflow, ectopic fat goes into the liver, initially produces hyperinsulinemia, then the beta cell fails, then you get diabetes, and all the while other things like pollution and so on are adding on. And this is what causes the South Asian phenotype. We call it the thin, fat, severe insulin deficient type of diabetes. Solution is improve the nutrition of the mother, cut down carbohydrate, increase protein, increase fiber, start exercising, and decrease air pollution. And by this you can prevent diabetes in South Asia. So I'd like to end by giving you my contact details. Mention was made of my social media. The reason I'm showing this is every day we try to give one new information to the large number of followers. So if you join any one of these, you can get information. This is my more recent WhatsApp channel. Again, close to 7,000 people are on my WhatsApp channel. So every single day, 365 days, you will get one message from me. It could be a motivational message or it could be an academic message. If you find anything new in the world which is kind of very important, we will put it there so that the public also comes to know. I'd like to thank Dr. Vijay Kumar. I'd like to thank and pay my homage, my pranams to the memory of Dr. CVK, and thank all of you in the audience. I see so many faces, my seniors, colleagues, juniors. It's a very emotional moment for me, and I hope I've done justice, and I hope I would have made both Dr. CVK and my father proud. Thank you very much.
I must congratulate Dr. Mohan. He really walked down the memory lane, and he has given statistical data to all our feelings over the years. What the diabetology world has been seeing over the past 50 years, from the lower prevalence of diabetes to the current prevalence of diabetes. Not only you showed the prevalence rates of various places in the world, but also within the country itself, how it is different from different states, and also the reason for them, sufficient data to support the impressions, and also an Indian solution to Indian problems at the end. You have certainly done proud to your father, Professor CVK, and to this podium. Yes, particular day, we have all benefited from your lecture. Being an oration usually doesn't ask questions, but I'm sure you wouldn't mind. But I think I should congratulate you once again for the excellent talk. Thank you.
நீங்க பேசினா வந்தது. Excellent work, and thank you for bringing back the memories and the kind words for CVK, and I hope a lot of us emulate, take these things forward, and God bless you for all the work. Thank you.
We'll just take about 2 minutes. Apart from giving an oration, it is also that we wanted to recognize some wonderful people who have done human service towards improving the quality of life of diabetic people. So in that, I think we are giving every year. In that way, we have recognized, the organizing committee has recognized 3 people who are close to me as well, and good friends of mine. First, I would like to call upon Dr. S.R. Aravind.
So the organizing committee of 3DCon 2025 have immense pleasure in awarding Dr. C.V. Krishnaswamy Award 2025 to Dr. S.R. Aravind. So Dr. S.R. Aravind obtained his MBBS from Bangalore University in 1983 and proceeded to certify in DNB Internal Medicine. He also secured additional training in diabetes under Professor M. Vishwanathan at DRC Chennai. He is the founder director of Diacon Hospital, which is the first university recognized center for study of diabetology in Karnataka. He is currently the course director of the postgraduate program in diabetology at the Rajiv Gandhi University of Health Sciences and Jaipur National University, and he has over 30 years of teaching experience. He is currently the president of Diabetes India and served in the executive committee of RSSDA for 15 long years before becoming the president of RSSDA in 2015 to 2016. He is a principal investigator in several multinational clinical trials and has also conducted investigator-initiated trials. He has a keen interest in biomarkers and food complications in diabetes. He has over 150 publications in national and international journals. He holds the certificate from Guinness Book of World Records for the largest diabetic health screening done on 14th November 2013. He was conferred the Lifetime Achievement Award in the field of diabetology from the Karnataka chapter RSSDA in 2013 and by Diabetes India during the 9th World Congress held at Jaipur. He is also conferred the Fellow of RSSDA during the 42nd annual conference held at Lucknow. So it is indeed a great pleasure and honor to present the Dr. C.V. Krishnaswamy Award of 2025 to Dr. S.R. Aravind during 3DCon 2025.
Next, I would like to call upon my good friend, Dr. Sanjay Reddy, onto the dais.
So, Dr. Sanjay Reddy is a consultant diabetologist and medical director of Diabetes and Endocrine Care, Bangalore, and also the consultant diabetologist at Fortis Hospital, Bangalore. He is the CEO of Primer and the honorary treasurer of Diabetes India. He is the former National Executive Committee member of RSSDA, and he was the organizing chair of Diabetes India 2020, Bangalore. He was the scientific chairman of Diabetes India 2023, Bhubaneswar. He has participated as a principal investigator in more than 60 clinical trials and has more than 20 scientific publications in indexed and in peer-reviewed journals. It is indeed a great pleasure and honor for the organizing team of 3DCon 2025 to present the Dr. C.V. Krishnaswamy Award 2025 to Dr. Sanjay Reddy.
Now I call upon Chennai boy, my good friend, Dr. Krishna Seshadri.
Professor G. Krishna Seshadri graduated from Madras Medical College. He pursued his post-graduation in the United States as resident in internal medicine at Chicago and proceeded to complete his fellowship in endocrinology at the Cook County Hospital, Chicago. He has obtained his American Board certification in internal medicine, endocrinology, diabetes, and metabolism. In 1996, he was appointed as lecturer in the University of Illinois College of Medicine and later joined Sri Ramachandra University in 1997 as the professor of internal medicine and professor of endocrinology and diabetes. He was also the professor of endocrinology and medical education and consultant at Sri Balaji Vidyapith and its constituent colleges. He is currently senior consultant endocrinology and diabetes in Apollo Hospitals, Greaves Road, Chennai, and senior clinical and research lead, Apollo Sugar. He is the editor-in-chief of Thyroid Research in Practice, the official journal of the Indian Thyroid Society, editor-in-chief of International Journal of Clinical Metabolism and Diabetes, the official journal of RSSDI. He has been conferred with several orations and awards. He is recipient of several orations, notably the P.N. Shah Oration Award by the Endocrine Society for the year 2009, the Sam GP Oration by the Research Society of Study of Diabetes in India for the year 2014, the Shaukat Shadikot Memorial Oration by Diabetes India, and Dr. Sindhu Pandit Oration. He has research interests that extend across the spectrum of diabetes. His translational research work predominantly on the effect of gut microbiota, vitamin D, and circadian rhythms on diabetes and inflammation. His clinical work focuses on thyroid nodules, obesity, MASLD, and diabetes. It is indeed a great honor and pleasure for the organizing team of 3DCon 2025 to present the Dr. Shivi Krishnasamy Award 2025 to Dr. Krishnaji Seshadri.
Sir, I'll pack it on with you. Namaskaram, sir. Sir, அது கொடுங்க பேக்ல வேணா வச்சுறேன். பேக்ல வச்சுறேன்.
So thank you all. It's time to go on to the next session. The next session will be on novel therapies. And to chair the session, may I call upon Dr. Hanish Gupta and Dr. S.R. Aravind.
Before going into the next talk, we'll announce also the lucky tip winners. We'll be getting a very good educative hampers, gift hampers, and stay back. And before the lunch, we are going to give these awards to you.
Dr. Hanish Gupta and Dr. S.R. Aravind. Yeah. Yes, sir. So over to the chairpersons.
Thank you so much. For the session for novel therapies, I'd like to call upon Dr. Ashwin Karuppan for improving glycemic outcomes with new generation insulin.
A very good afternoon to one and all present here. It's been a great honor and pleasure to be here among the Doyens, and we have had a fantastic lecture by Dr. Padmashri Mohan sir. and then we also had a lot of other insights. And I'm going to take it quick because I know it's lunch time, so I just want to make it as short as possible. So we are going to talk about the improving glycemic outcomes and new generation insulins, because we know that recently there have been various circulations saying that the old generation of insulin is slowly coming down, has been withdrawn. These are my financial disclosures. This talk is for Novo Nordisk. Looking at the typical case scenario in our day-to-day clinic, we see one 49-year-old gentleman engineer which has 9.5 as HbA1c, fasting is 196, postprandial is 244. Already he is in diabetic for the last 7 years, and now he is on metformin, glimepiride and empagliflozin, which are on maximum doses. So what do we all do in these case scenarios? Especially in an Indian scenario, we all know what we usually do. So what happens is, like, we keep adding OHAs until we get the control because of inertia to start insulin, or most of the time the physician itself is having an inertia. But you know what the literature says is very clear. As you keep adding more than 2 OHAs, you only get a decremental effect. Even if you have an incremental effect, it might not sustain for longer period, and the patient continues to experience hypoglycemia. And when you add insulin to these patients, when you have more than 3 OADs, you always see a good reduction of HbA1c. So successive oral anti-hypoglycemic drugs has a lessening effect in most of these patients, and substantial benefit could be obtained only by initiating insulin, which we are all well known, is already in the guideline, but we have a little bit of inertia to start those. When you come to insulin, so then if you convince the patient to take insulin or you start them on insulin, so what next? If you can see that the unmet needs, most of the guidelines says that you start on a basal insulin. So previously, back in those days, we had this insulin of NPH. Still we continue to use NPH in government setups, still we continue to use, and even in government setups off lately I see that people have changed into the newer insulin, first generation. So when you see the first generation, it was really not once a day, it always has to be given 2 times a day or sometimes 3 times a day. Higher glycemic variability, it keeps peaking up and down. Fixed timing dosage is the key in most of these generation of insulins which were not there, especially in the current generation where we do not have time to take care of ourselves, but we have time for everything else. So not truly a peakless insulin. So this is what the inherited risk we had. So coming to the current basal insulin, if you see there are in 2003, you have the euglargine, which is still continuing to be used by most of us, and then we have the detimer, which is still be used in pregnancy, and now we have heard that detimer is going to be withdrawn. And then in 2013 we have degludec, and then in 2018 we had U300. The previous insulin was always at half-life was around 5.5 days or half a day, but the newer generation proceeds, it's a truly peakless insulin which proceeds more than a day. So when we come to the degludec and when you compare U300 glargine, both are a single dose. They say that there is no glycemic variability, but the study otherwise says that the euglycemic clamp study in type 1 diabetes which was done, it clearly shows that the effect of degludec, when it is given at 0.4 units per kg, you don't see an intraday variation. The time interval between these are flatter. That means it's a truly basal insulin which mimics the physiological concept of our regular body. Whereas when you come to glargine U300, you can always see a dip. First, it starts acting only after 6 hours, and then you can see that it goes low, and then there is a much intraglycemic variability in most of these cases. Again, coming to degludec, higher HbA1c reduction. Here I can see that it is 1.5 and 1.2. But if you see it is statistically significant, you have better reduction because there is intraglycemic variability is less in these patients. So again, coming to degludec has a lower risk of hypoglycemia in most of these patients, And you can see that when it's compared to both of this, you can see the rates of hypoglycemia demonstrates nearly 30% lower reduction of hypoglycemia compared to a euglargine 300. And then the change of preposition of patients experiencing more than one episode of hypoglycemia was also significantly lowered. Because when you come to insulin, one thing that the patient doesn't want to experience or fear the most is an hypoglycemic episode. If you have a hypoglycemia, probably the patient will never come back to you with the insulin, or they fear for it, where we have to spend some extra time to make them understand, and in our busy practice it is nearly impossible to spend more time with these patients. So it not only that, it also says that when you shift to U300 glargine, there is always a 20% extra dose which is need to be injected. Though the volume might be less, but the doses are always high. This I have experienced myself in my clinical practice, and I am sure that many of you who are using euglargine 300 will also experience this. And when you come to dose flexibility, which we talk about most of the time in our regular patients, why dose flexibility? Today if you see, the patient says, sir, we don't have time, we have night shifts, we have morning shifts, we forget it. See, they will be on time for a movie, they will be on time for everything else, except for the course that they have to take the medicine timely. So most of the times, even in households, you can see people, our mothers who cooks the whole morning, they continue to cook, they forget their medicines, the time is up, and then you keep adjusting it. So this is how it is. But when you have degludec, you have at least 8 to 40 hours of dose flexibility is allowed. When it comes to euglargine 300, then it can be up to 3 hours. In this case, we revisited. We started the patient on degludec, 14 units, and then we saw after a 3 months period, we saw a subsequent reduction in these patients. The patient is happy. We reduced the number of OHAs, and patient went home well, and now he continues to be still under control. So let's look at the next case scenario where you have a 53-year-old gentleman, 10.2 HbA1c, fasting is 150, postprandial is 280. And in this case, again, the patient is on 3 OADs of a maximum dose. So when you come, Dr. Mohan has clearly stated in the last few lectures that we were once a poor country where we had 1 meal a day. Now we have been having multiple meals a day. We are compulsory snackers, food is available everywhere, and we have a huge carbohydrate load. That's what Dr. Mohan finally finished his slides with, saying that at least 15% of your carbohydrate level should come down, which we try to tell these patients most of the time. It might be practically not possible for us to tell these patients, because we've been advocating this quite some time, for a long time, saying that you have to add more proteins. But we don't tell them what more proteins are. We tell them cut down on carbohydrates. Instead of 3 idlis, take 2 idlis. But somehow, if you see the total calculation throughout the day, the average patient consumes around 300 grams of carbohydrate every day, which is quite high. So in this case, a basal insulin alone might not be a popular one in among our cases, because we have a high carbohydrate load, so that we need to hit the postprandial high. So most of the time, if you see that though increase in postprandial and fasting plays an important role in HbA1c, if you see, the postprandial is the one which plays the maximum contributions towards that of HbA1c, and this is what we are going to talk about next. So if we have in this case premix, or a premix or 2 combinations of an analog is only available as degludec and aspartate. In the whole world, there are only one product which has 2 components together, that is 2 analogs together. All others are either protominated insulin or probably has a different component. So in this, when you start insulin naive patients from basal insulin and compare that with the premix, you can see that the HbA1c reduction was superior from baseline, which is 1.4%. You had a significant reduction of postprandial component, which is very, very relevant to our case scenarios, where we see on day-to-day activities, we see our postprandials are high. In my practice, sometimes patient comes and tells me that the lab reports are wrong because the postprandial is lower than the fasting. So this is how we see most of these patients. And you can see that there is superior reduction, and up to 72% of these patients are able to achieve targeted HbA1c. Similarly, when you have multiple OADs, the chances of hypoglycemia and hyperglycemia are quite high. If you see people who are taking 4 or 5 drugs, they continue to spike. It goes slower, it goes higher. They start eating more when it goes low. When it goes high, they are worried, they take more number of medicines. So when you started these patients, the confirmed hypoglycemia initially at baseline was 176, but over a period of 3 to 12 months, it was nearly negligible for most of these patients. And then severe glycemia almost nil. So not only did the sugar comes down, but the quality index, that means the patient satisfactory quality index, was significantly higher because they have better controls, they have less number of tablets to take. If you see the overall cost, it is still lower than how many medicines you take every time and the hospitalization cost. So there was a better index of all these patients. So from Basel, where we started, the euglycine 100 said, any time of the day, but same time every day. Then the U300 came, it said within 3 hours before or after injection, and now you have this injection which you should give at the major meal of the day, which says administer any major meal of the day. And in our country, most of the major meal of the day, though we say that you eat like a king at breakfast, eat like a peasant at lunch, and then you eat like a poor beggar and in the night, we always follow the opposite. If you can see, it is always the king's dinner that we eat. So most of our patients have the high carbohydrate load, so this is more flexible to us. And then the recommendations are very simple. How do you titrate it? In my experience, though the slide says that it's one major meal a day, in my experience, I have always used it twice. There is no doubt it's a premix insulin. There is no doubt it's a 2 combination insulin, and it works best when you give it twice. So either you can base it on a major meal, yes. If your fasting is higher, how do you titrate it? That's the next question. So the titration is very simple. When you give it in the night, you titrate according to the fasting blood glucose. When you give it in the morning, you titrate according to pre-dinner. So pre-dinner if you give twice, then you can titrate accordingly, and it's very easy. And we have been using this premix, and the number of pricks comes down, and patient doesn't have any hypoglycemia. And this is the whole idea behind this particular molecule. So when it comes to intensification, when do you intensify? When do you need to try it 2 times a day? When you have a dose, higher dose, 30 to 40 units you reach, you are still unable to achieve the target, and there are spikes at dinner or at breakfast, and you are not able to give it once a day, then you split it. So it's as simple as that. So when the total dose, you can always split between 2 meals, and the ratio of the carbohydrate content and the amount of carbohydrate, if you can sit and calculate by a simple monitor, you will be able to do that. And finally, coming to my last slide, the simple concept is, we have been, Dr. Arvind has clearly stated, people want to buy cars, people want to build houses, people want to do a lot of things. They want a fancy mobile. And Dr. Krishna Seshadri has also pointed out very clearly, less than 2.3% were among the priority. So today, affordability for health is there among patients. All that you need to do is to convince them that it is your topmost priority. As physicians, it is our responsibilities to tell these population, tell these people that you have to varumun kappom, illa vandadukapram pappom. So this is what is the slogan. So the better option is varumun kappom. We will prevent diabetes. We will try to make sure that we can try to give these insulins or convert more. It's not a promotion to convert more number of people into insulin, but to do the right thing at the right time. Thank you so much.
So we will take up the question answer session in the end together with all the speakers. The next talk, which was by Dr. Tom Babu, has been cancelled, and now I'd like to call upon Dr. Adeline Reena for providing a talk on stepping up obesity care with semaglutide 2.4 mg.
At the outset, I would like to thank Dr. GVK sir and the organizing team for having me here today, and thank Novo Nordisk for having to be in this session. Yeah, anyway, just to save time, let me start off. So what I will be talking in the next 10 to 12 minutes or so is to mainly look at how somebody develops obesity and what are the interventions that we currently have to help these patients tide over obesity and probably cut down their metabolic risk. Now, as with any chronic metabolic or lifestyle disease like type 2 diabetes, hypertension, or CVD, obesity is no more just a phenotype, but we consider it as a specific disease entity because we know from the fact that weight gain or a dysfunctional or an excess of adipose tissue is the root cause for all metabolic perturbations that we actually come across with all the cardiovascular, renal, and metabolic diseases. So when we talk about obesity, it is generally said that any energy balance is maintained with a simple equation of calorie in is equal to calorie out. But it is not as easy as it sounds because we know for the fact that the energy balance cannot be just so simple. So when we talk about calorie in and calorie out, we would have seen people who eat such high amount of calories, yet they do not gain weight. At the same time, we will have people who count their calories before consuming and would still not be able to lose weight. So it's not just about the calorie in and calorie out, but many other factors contribute to weight gain and obesity, and that is what makes it as a disease entity and not just mere phenotype. So when we talk about the factors that contribute to obesity, we need to understand that genetic predisposition is the most strong component that somebody would actually gain weight. So 60 to 70% of weight, of our body weight, is contributed by genetic predisposition. Now, besides the monogenic forms of obesity, which we all know, which is quite rare, we have the polygenic forms of obesity, where you have a lot of MCR4 mutations, the fat mass and obesity associated gene mutations that contribute significantly to the weight. So without a genetic predisposition, we will never get somebody obese. So genetics still plays a major role in terms of obesity. Now, beyond obesity, you have other factors like biological factors, wherein you have the appetite system which becomes dysregulated. We have the psychological factors, stress factors, because we know that when somebody is sad, they eat. They are happy, they eat. They are stressed, they eat. Just like smoking, no? In movies, they say when somebody is stressed or they want to really think more, immediately they start smoking. So similarly, eating has become a stress reward, and therefore whenever people get stressed, they start eating and eat more. Especially they have a potentially increasing appetite for high fat and high carbohydrate diet. So then you have the environmental factors. We have easy access to calorie-dense food. We have unhealthy eating patterns, erratic meal schedules. Medications, again, the steroids, the anti-epileptics, antipsychotics, and even sulfonylureas can potentially make somebody gain weight, and the social components, which we all know. So what I'm trying to say is that there is a core genetic component for all obesity, with so many other factors confluencing the epidemic of obesity in a given individual. Now, when we talk about the appetite regulation system, there are three things that come into play. The one is called as the homeostatic regulation or the homeostatic eating. What we mean by homeostasis is once the energy reserve or the energy balance goes low, the body gives a peripheral cue, and that gives signals to the hypothalamus. Hypothalamus produces signals to increase hunger with a lot of peptides coming into play, and the moment we are motivated to eat, the hunger settles down. So this is basically a neurohormonal activation of the appetite regulating system, and that is mainly driven only when the energy reserve goes low. On the other hand, you have the hedonic eating system, where the eating is mainly done for pleasure. It's not mere hunger, not mere energy deficit, but somebody wants to eat. As I said, somebody gets stressed, they eat. They're happy, they eat. They want to enjoy. Say they've scored well, they give a treat. So something like more of pleasure-driven eating. Now, having said that, they don't exist as two separate entities. They are quite interconnected. One influences the other. And most importantly, what we need to understand is the hedonic eating most of the times overrides the homeostatic eating. By that I mean to say that the pleasure eating overrides the energy deficit eating. And that is the reason why obesity sets in. Now, then you have the executive function where once you become hungry, just like how we are all now before the lunch session, the decision of eating, how much to eat, what to eat, it all depends on your environmental factors and your behavior. So that is the reason why behavioral therapy becomes most important and relevant when we manage patients with diabetes, because we don't want to just target the homeostatic eating and hedonic eating, but also this executing function without which none of the weight loss programs are going to be successful. Now, what are the peptides that are involved? The homeostatic eating, as I told you, revolves around a lot of peptides. So you have the orexigenic pathway, which stimulates the appetite, and the anorexigenic pathway, which suppresses the appetite. So the orexigenic pathway is mainly driven by our GLP-1, the polypeptide YY, oxyntomodulin. Oxyntomodulin is a physiological dual agonist. Just like tirzepatide, you have a physiological dual agonist of GLP-1 and glucagon. Then we have pancreatic polypeptide, amylin, insulin, and leptin. So all these hormones are anorexigenic and they suppress the appetite. On the other hand, you have the orexigenic pathway where you have ghrelin, you have agouti-related peptide, neuropeptide Y, all these hormones stimulate hunger. So unless there is a balance between the orexigenic and anorexigenic pathway, patients do remain hungry for a longer period of time and they end up consuming more. So this hedonic eating pathway is mainly driven by dopamine and the cannabinoids. So this is basically as a reward system. You do good, you eat well. You score well, you eat well. And that is how this reward system works. And the behavioral therapy, as I told you, depends on what you think that you would eat and what would give you that happiness, what is accessible for you and all that. So all these three domains of appetite regulating system has to be considered when we are dealing with a patient who primarily has obesity and complications where you want to help them out with some weight loss. Now, lifestyle intervention is the most important and the first and foremost pillar of any weight management. We all know about the calorie deficit that we need to create by increasing the calorie expenditure and decreasing the calorie intake. Now, weight loss is due to lifestyle intervention can go up to the tune of 3 to 5%. So that gives you the metabolic benefit, though may not help in diabetes remission or something, where from the direct trial, we know that unless there is a very low calorie diet, the diabetes remission doesn't happen. So lifestyle intervention is important. And what they have shown is the 3 to 5% weight loss, but unfortunately, the weight gain happens much higher than the pharmacological intervention. So at around 2 years following the weight loss, 50% of the weight is regained. And at 5 years of following the lifestyle mediated weight loss, 80% of weight is regained. So what I'm trying to say here is lifestyle interventions do work and will have to be incorporated into the weight loss regime, but the rebound weight gain is much higher, making ourselves and patients helpless when we are just sticking on to lifestyle intervention, especially with a morbid obesity. So there has been a constant struggle between weight loss and weight gain. We have so many factors acting towards weight gain, so many factors acting towards weight loss, but it's a constant struggle. I'm sure we have all encountered patients who lose weight and quickly gain weight, making it no different from what they were before. So pharmacological interventions, especially the GLP-1 based therapies, have helped us to modify the brain-regulated appetite control system. So that way, we are able to potentially correct the pathological abnormality, just like what we do so in the management of type 2 diabetes. We are able to regulate the appetite control system with GLP-1 based therapies like semaglutide. So semaglutide, the subcutaneous version of 2.4 milligram, which comes in the brand name of Wegovy, helps modulate the appetite control system in the brain. So basically what it does is it acts primarily at the hypothalamus, at the arcuate nucleus, at the appetite regulating control. So you can see here that it acts at the amygdala, which potentially gives you that feeling of eating. Basically, it gives you the feeling of having some food, having something to munch and all that. So that is completely inhibited with semaglutide. On the other hand, the peripheral cues that tell you that you will become hungry, your tummy is empty, you need to fill in some calories, that has also been inactivated. So that way you have a peripheral action as well as you have a central action that helps you to modify both the hedonic as well as the homeostatic regulation of the appetite control system. So that way, it's a centrally acting drug predominantly, which makes it even more efficacious with regards to weight loss, unlike our peripheral drugs like metformin and alpha-glucosidase inhibitors, which have a peripheral action, especially in the gut, which slows down, gives you that satiety, but does not have an effect on the brain or on the appetite control system, and therefore doesn't translate into a good weight loss. Looking at the efficacy of this molecule, we have the STEP series of trials comparing with placebo, with diabetes, without diabetes, with metabolic complications, with mechanical complications like OSA and arthritis. And it has also been studied in adolescent population, which many times we do not have the other GLP-1 analogs. They have also looked at it in patients who had high cardiovascular risk like HFpEF, and also the patients who had MASH. And overall, all these trials, including the STEP 1 and 2, SELECT and STEP HFpEF, which is mainly done with Wegovy 2.4 milligrams, the SUSTAIN group of trials done with 1 milligram of subcutaneous semaglutide, and the PIONEER trials, which we are all familiar, which takes care of oral semaglutide. So there is a good amount of Indian representation in all of these trials, so we are able to extrapolate the benefit that this molecule can offer to our patients as well. So the STEP 1 trial primarily compared Wegovy 2.4 milligrams versus placebo for a period of 68 weeks. And this included patients who had obesity with or without comorbidity. Now, what they actually did is they started with 0.25 milligram, up titrated to 0.5, 1.7 mg, and stabilized at 2.4 mg for a period of about 52 weeks. And what they actually showed is that compared to the placebo arm, which showed a 2.4% weight loss at the end of 68 weeks, the patients who were put on semaglutide 2.4 milligram subcutaneous did have a greater weight loss, and this comes as no surprise. So a 16.9% body weight reduction was observed at the end of 68 weeks. Now, when they looked at how many people were successful in achieving this weight loss, they saw that 5% of body weight loss was achieved in close to 92.4% of patients. More than 10% of weight loss in 74.8%. Now 15% weight loss, which is actually required for diabetes remission, happened in half of this population, and 20% of weight loss in more than 1/3 of population. So that gives us an idea as to the response that this molecule can offer to the patients who are put on this molecule. Now, when they looked at the other benefits, again, the numerical reduction with waist circumference, systolic blood pressure, diastolic blood pressure reduction, CRP reduction, A1C reduction, and more importantly, the functional score. Patients who had osteoarthritis did show a better functional score because the weight came down and their mobility improved. Now, the STEP 4 primarily looked at Wegovy, when what really happened when treatment was withdrawn. Because whenever we are worried about rebound weight gain, we want to know whether patients will be able to manage without the drug. So what they primarily did is they did patients put on Wegovy and Wegovy for a period of 20 weeks, and then one group continued Wegovy, the other group stopped Wegovy. So what they showed was when patients stopped Wegovy, they had a 6.9% increase in the weight after the initial weight loss, and whereas patients who continued on semaglutide 2.4 mg did show an 18% weight loss at the end of 68 weeks. So that tells us that just like how we tell patients for diabetes and hypertension and CAD, most of these weight modification regimes and drugs probably need to be continued given the fact they are expensive. But more than that, this is how chronic disease has to be taken care of. Now, this is the long-term data. What they actually showed was even until the end of 2 years or 104 weeks, the weight loss that was initially achieved at the end of 68 weeks did sustain for up to 2 years. So that gives you the amount of less of rebound weight gain or the increase in the calorie intake did take care, and there was no much weight difference when patients were continued on Wegovy. So the adverse events were very much comparable. Of course, the GI effects were much more in patients who were on semaglutide, but as we know, when we gradually titrate it, we don't have a problem of withdrawal or discontinuation of this molecule. So to summarize, the semaglutide subcutaneous injection does really help with regards to weight loss, with regards to metabolic benefits, but the most important thing is patients need a good counseling, lifestyle modification, and then pharmacological intervention, which is very much worthwhile to not just treat obesity, but also to prevent the obesity-related complications like CVD, type 2 diabetes, and CKD. Now, the efficacy of the drug has been clearly studied. We have close to 20% weight loss at the end of 68 weeks. And this weight loss is sustained even at the end of 104 weeks, which is about 2 years. And not just the weight loss, but also metabolic benefits, cardiovascular benefits, renal benefits, and the physical ability score did improve in patients who were put on semaglutide. So thank you very much, and I'll close my presentation here. Thank you.
Are there any questions from the audience first before I ask the questions? Okay, you have a question.
Madam, it is an excellent question. Madam, it was an excellent presentation. Regarding semaglutide, I just wanted to know your real-world experience, and in patients with comorbidities, like if they have any CKD. And one thing I want to know is whether diabetic retinopathy, how it is there, regarding your real-world experience.
First question, I don't have personal experience with 2.4 because it's still not launched in India. But your second question, the oral semaglutide, I have a pretty good experience. And the weight loss is very heterogeneous. You have super responders who lose like 10, 15, and 20 kgs. On the other hand, you have average responders who lose about 5 to 10 kgs. So the weight loss, as I said, it's a multidisciplinary approach. So you need to have lifestyle in place. You need to motivate the patient, address the behavioral patterns, and give a pharmacological intervention. But overall, the semaglutide does really help.
This diabetic retinopathy.
The retinopathy, I think you're asking about the anterior ischemic optic neuritis.
Yes,
so the concern of anterior ischemic optic neuritis has always been there whenever there was an intensive glucose control during a shorter period. Even with glargine in the ORIGIN trial, you would see that the risk of worsening of retinopathy. So that way, the molecule doesn't have a direct impact on the retina per se, but what they actually have shown is the vascular endothelial growth factor and platelet-derived growth factors do go up during the intensive glucose control, and that is probably associated not just with SEMA, but also with LIRA. So you can see that with LIRA as well. So that is the reason, and that is why sometimes practically what we do is when the A1C is too high, we allow the A1Cs to come down a little and then probably initiate. We don't want an A1C to drop right from 12 to 6 or 6.5. And it's better to get a fundus examination, especially when you have long-standing diabetes, because the risk factor is male gender, obese, and long-standing diabetes. So when you have these risk factors, it would be better to screen the fundus, make sure that there is no severe NPDR or PDR, and also to look at the cup disc ratio. If the cup disc ratio is low, if you have a smaller cup, then probably these are the patients who are at risk of AIOL.
It's a nice presentation, Adeline. In fact, in tirzepatide study, patients presenting with a severe retinopathy, they were virtually eliminated from the study. Regarding the BMI cutoff, you have clearly made a mention, 27 kg plus comorbid, one of the factors associated with obesity, or 30 kg.
Yeah.
Because most of the Indians have also participated, you said. What were the BMI cutoff for the Indian patients and the international cohort?
The BMI cutoffs was the same, sir. So that is why there will be an exclusion of patients with BMI between 25 to 27, because we take 25 as a cutoff.
But regarding this product, what is the loss of muscle mass when compared with the other molecules?
It's a very good question, sir. So usually whenever there is weight loss, especially when there is more than 5% of total body weight loss, we expect the fat mass as well as the skeletal muscle mass to come down. And that's what is happening when we put patients on intensive lifestyle modification. And that is the reason when we are looking at just lifestyle interventions, we tell patients to increase protein intake and also do resistance training to reduce the skeletal muscle mass loss. But when it comes to semaglutide, the the fat mass comes down, but the skeletal mass is preserved. So I have not shown it in this slide, but the skeletal muscle mass or the lean muscle mass is preserved with just an expenditure of fat mass. Now, having said that, there would be a skeletal muscle mass, especially when there is a calorie deficit created, but the lean muscle mass loss was less when patients were put on semaglutide along with lifestyle intervention.
Thank you. Thank you so very much, Reena, because organizers have requested me that, it's already late for lunch and the next session starts at 2. So I request the audience who have not had lunch to complete their lunch, come back so that we can start the next session at 2 o'clock. Those who have a lot of doubts about semaglutide, I'm sure Dr. Reena should be around. The Novo people will be around here. You can clear all the doubts. Thank you so very much.
Thank you, Arvind, Dr. Anish and Dr. Arvind. Is Dr. Ram Prakash is here? Dr. Ram Prakash? Dr. Mumtaz? Come. Dr. Sudarsh? Dr. Meenakshi Sundaram? Yeah. Okay, good.
active intra-abdominal fat that can be assessed clinically by waist circumference. And then there is an increased visceral intra-abdominal fat, which is particularly notable in people with type 2. And this is associated with decrease in both beta cell function and insulin sensitivity. So we have typically thin fat Indian where metabolically fat, there is a high central adiposity and there is a high amount of visceral adiposity, which sort of, makes them more prone for development of type 2 diabetes. This is a nice paper which looked at that why might South Asians be susceptible to central obesity and its atherogenic consequences. And we do talk about the adipose tissue overflow hypothesis. So we are now seeing increasingly a lot of ectopic fat deposition. And this usually happens when there's a saturation of adipose tissue compartment, and that leads to overflow of the fat into other sort of visceral fat compartments. And this, to a certain extent, is responsible for the insulin resistant state that the patient tends to develop. Initially, there is a compensatory mechanism that happens, and then there is a failure of compensation, and you know that leads to the hyperglycemia. So we're now looking at a lot of high liver fat, we're looking at a high pancreatic fat, and ectopic fats and other, and this happens usually when there is a saturation of the adipose tissue. And this has also been mentioned in our own clinical practice recommendation. And the significance that it has is that all these ectopic fats that we tend to get, there is a sort of a very resistance, to the lifestyle intervention in reducing this adiposity. So although we do recommend lifestyle modifications, exercise, diet, but a lot of these people actually do not respond as much as they would if it was other situations. Also, this fat makes more prone for other non-communicable diseases. So this is the Kerala Diabetes Prevention Program, and they showed that even in patients with normal weight obesity, there is a high amount of cardiometabolic risk factor. And they looked at diabetes, hypertension, and dyslipidemia. And they've looked at in non-obese, normal weight obese, and obese population. Clearly, you can see that normal weight obese actually behave more like obese when it comes to occurrences of diabetes, hypertension, and dyslipidemia. Which also brings us that if you look at this forest plot and a meta-analysis of number of studies, clearly you can identify that in patients with normal weight obesity, there is almost a 60% increased risk for cardiometabolic events. And you can identify that because of high amount of adiposity, inflammatory pathway, increased amount of adipocytokines that is there, and a proatherogenic profiles, these patients tend to get a high cardiovascular risk. I just now want to come to the crux of my talk, which is lean versus obese patients, how they are different, and do we have differentiators that sets them apart. And I'm going to put this in a tabular form, which makes it easy to understand. So let's look at the comparative analysis in terms of clinical and pathophysiological characteristics of lean versus obese patients. What is the typical BMI and body fat? And I've made two columns out here. Lean type 2 diabetes, where the BMI is normal and or underweight range. And the other column is obese type 2, where the BMI is in the overweight or obese range. So in typical BMI and body fat, the BMI is often normal or low, less than 23, and they have a high body fat percentage and central adiposity despite the normal weight in lean patients. Whereas in obese type 2, the BMI is more than or equal to 25, and there is a generalized adiposity with excess subcutaneous and visceral fat. What about age of onset? In lean type 2s, it's often younger onset, where the age may be less than 40 years in most cases. In obese type 2, classically midlife or older onset, though obesity-driven type 2 is increasingly seen in the youth, and often associated with calorie excess and sedentary lifestyle over the years. The primary defect in lean type 2 is beta cell dysfunction, and many lean patients show early beta cell failure, which brings us to the fact that because they sort of have beta cell failure and a low insulin values, these patients go on to insulin as a treatment much earlier. Whereas in obese type 2, The predominant pathophysiological defect is insulin resistant and reduced insulin action due to the adipose driven inflammation and lipotoxicity. And these patients respond exceedingly well with weight reduction. What about the association with metabolic syndrome? In lean type 2, it's less prevalent and they have a lower incidence of hypertension, dyslipidemia, and coronary artery disease. I don't want you to go back with the feeling that they don't have it, because all adipose tissue that they have is central, and that does give them a high amount of cardiovascular risk. But we are talking in relative terms. And in patients with obese type 2, it's highly prevalent. And obese type 2 typically represents with features of metabolic syndrome. That's high TG, low HDL, hypertension, fatty liver, elevated cardiovascular risk factors. Okay. What about the glycemic profile in between the two groups? In lean type 2, they are markedly hyperglycemic, and this occurs despite being lean. And often they present with severe hyperglycemia diagnosis, which can be very difficult to treat, but ketoacidosis is rare. So you need to start insulin early if patients do not respond to oral agents. Whereas in obese type 2, hyperglycemia gradually develops on a background of years of insulin resistance, and again ketoacidosis is uncommon. What about autoimmune markers? They're generally negative in both the situations because it's not an autoimmune condition. And need for insulin, often high insulin requirements are seen early in the course of the disease with lean type 2. Whereas in obese type 2, they can be managed with oral agents over the years, and insulin becomes necessary when OHA failure tends to happen with the longer duration of diabetes. Microvascular complications. The lean type 2 have high rates of microvascular complications, and this may reflect the severe hyperglycemia or delayed in diagnosis. Whereas in obese, they are also prone for microvascular, but it is tied up with, the risk is tied up with the duration of hyperglycemia and control. So if you have a good control and the patient tends to be normoglycemic, it sort of delays the onset of complications. Whereas in lean type 2, you see much earlier onset of microvascular complications. And lastly, what about the macrovascular risk or outcomes? So in lean type 2, lean diabetics initially have lower rates of atherosclerotic cardiovascular disease, but over a period of time, as there is more adiposity, they tend to sort of lean over and get a higher risk. But there is a higher mortality that lean diabetics have as compared to obese diabetics. And in obese diabetes, you have a high cardiovascular risk. Obese diabetics tend to have a high rate of coronary artery disease, stroke, heart failure, and we generally tend to have a lower all-cause mortality than lean diabetics. So in summary, lean versus obese diabetes on, then we need to initiate insulin. But here the goals are clearly weight loss, and here GLP-1s and SGLT2 come much higher in terms of treatment protocols for the patient. And bariatric surgery, there's no clear indication for bariatric surgery for lean diabetic patients, because here the focus is not weight reduction. So it's not going to help these patients in any kind of a way. Whereas if you are giving it for obese diabetic metabolic surgery, then there is a hope that the patient will get remission of diabetes. Particularly bariatric surgery can induce more than 20% of the body weight loss. So it is a recommended option for patients who have the indication for bariatric surgery, or else with the current anti-obesity medication that we've got with, tirzepatide, injectable semaglutide and others, which can give you about 18 to 20% of weight loss, then these medications go up on the list in terms of effectiveness for therapy and addressing the hyperglycemia as well as the weight increase and reducing the cardiovascular risk for the patient. So I'd just like to conclude my talk by saying that diabetes management is most effective when it addresses the individual's underlying pathophysiology and risk profile, which often correlates with body composition. In lean type 2 patients, typically they have less insulin reserve and require early pharmacological intensification, sometimes insulin therapy, and the focus is on adequate nutrition. Whereas in obese type 2 patients, they benefit greatly from weight-centric interventions like diet, exercise, possibly bariatric surgery, and medications that promote weight loss or reduce insulin resistance. And lean patients might have fewer tools like weight loss at their disposal, so reliance on medications like metformin, secretagogues, insulin is higher, and care must be taken to avoid undernutrition. And obese patients have the opportunity and challenge to significantly improve their diabetes through lifestyle change when successful, and this can reduce their need for medications and improve outcomes. But it requires a sustained effort and often multimodal support, and counseling is most important. Avoid weight regain because that is rather detrimental and it sets back the patient's efforts. So thank you very much for your patient listening. It's been a pleasure to talk on this lovely topic.
Thank you, sir, for your crisp communication of the lean diabetic and the obese diabetic clinical situations, management also. We will have a question and answer for at least 5 minutes. You can be with us. Yes.
Sure.
Open to the audience for the interaction. Please come to the mic and then.
Sir, my question is regarding the lean diabetes. What about the gut hypothesis, sir? Recently in Lancet study, they were telling that gut hypothesis has also a role. And when we give probiotics for this lean diabetes patient, they were having the better glycemic control. In your practical experience, sir?
So honestly, I have never used it in my own clinical practice to give probiotics for control. I have read the reports that are there, but as of now, this is not a guideline recommendation that we can use probiotics for control. So, I mean, there are odd reports. You can use it. It's not going to cause any harm. But whether it will benefit or not, I don't know that.
Thank you, sir.
Good evening, sir. Thank you very much for your clarified speech. And I just have one small clarification, sir. Recently, WHO has introduced a new type 5 diabetes with malnutrition. How this type 2 lean mass different from that?
Yeah, okay. So I was there at the IDF meeting when Dr. Nihal Thomas and the group we have been talking about it, and Dr. Mohan and Dr. Nihal and Dr. Yagnik and all these people, we used to, if you remember the older classification of diabetes, then MRDM was a separate classified entity in the older classifications of diabetes. And then somehow it went out of the classification because MRDM was not really, visible in the Western world as much. We'd seen odd reports out there, but I think a lot of reports came from our part of the world. Now we're revisiting it to say that this is a separate entity, and Dr. Peter Schwartz and others have said, let's call it type 5 diabetes. But this is essentially the same what we're talking about malnutrition related diabetes, where you get pancreatic calcification, low insulin values, insulin very early in the phase of life. So it's, I mean, these behave like lean type 2. So, you know, they're phenotypically very similar to lean type 2 that we are really talking about.
Thank you, sir.
Good evening, sir. This is Dr. Amala. That was a very candid presentation about lean and obese diabetics. So, in lieu to the previous question asked by our delegate, so what would be like a key takeaway or an algorithm sort of thing that you would suggest when a lean diabetic comes to our OP? Because the lean diabetic overlaps between type 1, type 2, and type 5 now. So, like, how
Correct.
would we approach the patient?
Correct. So I think if you look at a lean diabetic patient, all right, you obviously, the best way of assessment of this is one, you look at the BMI of the patient and you do a waist circumference of the patient, right? Look at the duration of diabetes that the patient has got. Look at the A1C and what is the level of hypoglycemia. You may or may not do a C-peptide levels for these patients to actually get the, you know, what is happening to these patients. It's not a standard recommendations, but usually I would go more, I would sort of put sulfonylureas for lean diabetics on the back seat, probably go more with, you know, DPP-4 inhibitors, metformin and other agents, voglibose and others. If the patient does not respond adequately, you may give sulfonylureas, but with the caveat that it may not respond very well. You can give a GLP-1 if you are able to demonstrate a high amount of ectopic fat. So you can look at, you know, if the patient has got MASLD, then you can think of giving or SGLT2 inhibitors. But be clear about the fact that you cannot wait for long periods. If the patient is not getting to the goal, then you need to start insulin very early. When it comes to obese type 2, they're just clear. I mean, you don't have to, it's not a brainer that you really need to decide what you need to do. It's a question of where and how quickly do you start insulin in your patients who are lean patients. And I think it's very clear that if the patients don't respond adequately, then, and the patients' A1Cs are high persistently, then just put these patients on insulin.
Thank you very much, sir. I think we'll close the session. Thank you very much, sir.
Thank you so much. Thank you very much.
Next, I call upon Dr. Sanjay Reddy, sir. He has already been introduced and he is now the recipient of the award, CAK award. Dr. Sanjay Reddy, sir, will talk about mind and body medicine.
Good afternoon, everybody. Thank you, chairpersons, for the kind introduction. Dr. Vijay Kumar and the team, organizing team, for inviting me. So I was asked to talk about mind-body medicine. I'm not an expert on it. That's the first caveat. I don't know how many of you have heard the concept mind-body medicine. We all know. All our bodies are here. We don't know. I don't know if your mind is there to listen to me, but I'll make sincere efforts to get this mind and body medicine across to you in a structured format. What is exactly mind and body medicine? I would like to begin with Hippocrates saying, I would rather know the person who has the disease than know the disease the person has. We all know, we've been taught to listen to the patient. We all listen to Dr. Krishna's cases on diabetes. Apart from the conventional wisdom and apart from conventional therapies we do, we still fail to achieve targets. There are various diseases which we need to understand. The mind plays an important part. So how do we do this? And what is this mind-body medicine? Mind-body medicine focuses on the interaction from the brain, mind, body, and behavior, and on the powerful ways in which emotional, mental, social, spiritual, and behavioral factors can directly affect health. How many of you think that this is true? And do we practice anything to improve this part of it? I don't know. I've not been doing, nice to see somebody. We'll talk about it later, because I came to know of a lot of techniques which are there and whether these techniques can be used to improve outcomes in patients with different types of disease. And what is the background? It started somewhere around 2000 years ago when Hippocrates recognized that moral and spiritual aspects of life, belief in them helps healing. 16th and 17th century led to separation of human spiritual or emotional dimension from the physical body. They started separating it, like compartmentalization, like every disease and disorder has a compartment and everyone has a specialist. Nobody's thinking in a holistic way. So fixing or curing an illness became a matter of science, technology, driven by data, and that took precedence over not a place besides. It should have been placed besides the regular treatment in the part of the treatment algorithm after I heard about it of healing the soul. So these were the words. So science, we have the science which took over this, but the oldest inscriptions of mind and body medicine go back to Ayurveda and traditional Chinese medicine. Only two of these sciences really took all of this into consideration. Behavior, spirituality, the type of other problems you have with the disorder to do it. And 1964, they started doing certain experiments. George Solomon worked on rheumatoid arthritis and some people associated with depression, worked with their mind, and he found that people who were put into sessions saw that improvement in pain to 30 to 40%. 60 to 70, one of the landmark studies was blood pressure reduction with meditation. And 75, they thought that if you worked on your mind, good emotional and mental support improved immune system. Now, the problem with all these things require a longer time. We don't have patience for that. Given a drug, I want the results after a certain time. But when you don't find it, we give all the drugs, still you're not able to achieve the targets, and then you need to keep searching for other things. And what are these? And what are these techniques which are available? So if anybody knows about the placebo and placebo effect, this was one of the first things described. In World War II, lack of morphine, injured soldiers, there was no morphine, one of the physicians, Henry Beecher, gave saline. And 35% of the patients felt better without the morphine. That is the time when he coined the effect, placebo effect. And that is in discussion through ages. All medicines are, all trials, usually randomized controlled trials. For data, you need to compare it with a placebo. Placebo may itself have an effect, and that can be up to 35%. I'm not here to discuss and debate about the placebo effect, acknowledge the placebo effect. So, what is this mind and body medicine? What are the techniques which can you use to make sure the focus on this interconnectedness of mind and body, recognizing that thoughts, behavior can influence physical health, interconnectedness, relaxation response, stress reduction, improved well-being, diverse technique, integrated and conventional medicine. I don't know in India if you have a mind and body clinic. I Googled. I was surprised. Some of the best ones are in the US, like Solon Kettering has one. There's one in Johns Hopkins. They have separated, dedicated mind and body clinics, and their mind and body medicine certified courses for those who are interested. Now, what are the examples of these mind techniques which are there? Meditation, yoga, Tai Chi, guided imagery, biofeedback, and hypnosis. What I'm going to do in the next 4 slides is going to tell you what is these relaxation techniques which these mind and body therapists use. It's usually, these are practices whose primary stated goal is eliciting a psychophysiological state of relaxation or hypoarousal from an excited state in whatever that individual is, to make sure that that stress or that hypophysiological state. Suppose your muscle is under stress, so you relax the muscle, re-stressing. Something like this. One of the best prominent example is called the Benson's relaxation. It's one of the type of relaxation technique where you achieve a hypometabolic. Say if you're going into a calmful, all these wellness clinics are based on this mind and body medicine. So, other thing, our people are talking to it for ages. I don't know, for thousands of years. Meditation. There are 2 types of meditation. One is transcendental meditation. You just chant a mantra. The same thing you keep on chanting. That is one of the techniques. Or mindfulness meditation, in which practitioners simply observe or attend to
without judgment and thoughts, emotions, sensations, and perceptions. So I'm not an expert. I've never tried meditation. I thought I should try. And I know people who try meditation who find it effective in their well-being day in, day out. Yoga, as part of one of the therapies, it's also physical and it also has de-stressing things. Now, what is this? There's another technique called guided imagery. Is either by oneself or guided by a practitioner. What you do is, imagine that you have a infection, a chronic infection. You tell the patient, the cells are fighting it and they're fighting very well. It's an image of your disorder and you're fighting this disorder. And that way, immune system, these guided imagings are helpful, especially in improving immune systems. Hypnosis, we all see this as part of probably in a movie or used by psychiatrists or psychotherapists. So there are different types of hypnosis, especially if you take a patient in three types of, one is absorption or intense involvement of the central object. They put the concentration of the patient on a subject, on a central object, and he forgets his surroundings. Similarly, dissociation from the surrounding. This requires training. You need to be a hypnotist to try and do this. And these type of things are especially they work very well in anxiety, phobias, and so on and so forth. Biofeedback, this is also a technique in 60s. This is using technology. Suppose you have, you give a watch with his heart rate on that patient. The patient looks at the heart rate. When he's monitoring the heart rate, there are certain situations, people who have anxiety, who are type A personalities, many people who heart rate increases for various reasons. So you give them techniques by saying, look at your heart rate, tell them some technique or one of the techniques to get that feedback. The feedback is reduction in, they say take a deep breath, relax. So something like that. These are the things. This can also work for migraine. Biofeedback especially is works for chronic pain and especially in patients with blood pressure and increased patients with type A personalities and so on. Cognitive behavioral therapy, and we were all talking about how, Krishna was talking about how cognition, very important in elderly, as you get older. So the emphasis, the role of cognitive process in shaping affective experience, and argues that problematic emotions such as anger, depression, and anxiety result from irrational or faulty thinking. You're thinking that you're going to be doomed. Something is going to happen 3 days later. So all these people will have this. So for them, behavioral therapy helps. Behavioral therapy also is very effective in obesity, in patients with type 1 diabetes, and so on, because of so many other issues associated with them. Now, psychoeducational approaches. One of the best psychoeducational approaches which you can have is patient education. The more you educate the patient, the more empowering the patient feels about the disorder, the more aware he is about chronic disorders, and the more he knows that these are going to cause, and repeated psychoeducational approaches have a lot of effect on chronic disorders. So, mind and body interventions. So there is evidence that these interventions, mind and body, can be effective in treatment of coronary artery disease, especially cardiac rehabilitation, heart failure. So what I'm going to do is, give me a minute. So there is effect, just to tell you, sorry, the effect of placebo. There are PET scan studies, especially in Parkinsonism patients, that giving a placebo and looking at their dopaminergic response. This is a randomized study which was done to see PET scan placebo in a Parkinson patient versus a dopaminergic agonist. They found that there is, if you reinforce these strategies, there is an increased response to placebo, especially in patients with Parkinson's. Stress and wound healing, there's individual differences in wounding have long been recognized. I've suggested that negative mood or stress is associated with slow wound healing. So here giving them positive feedback that your wound is going to heal itself works on to improve wound healing. Surgical preparation. We all know, yesterday also there was a study which said, now a lot of people pray. And one of the important statements is there are more honest prayers in the ICU than in the temple or a church. More honest prayers are held there. So this prayer, somebody coming to the patient, talking positive about the disorder, telling him that he will go get well. We all thought this was something, some guy is coming and praying in front of them. Actually, it is encouraged and it helps people recover faster. There's data which says that these type of things will do well. Does it work? The question is, does this work? Do we have evidence of this? So I can't go through all the evidence, but I summarize it with a couple of slides later in terms telling you about 26 systematic studies. It works, especially standard breast cancer treatment with weekly support group. Support group, especially for various disorders, these support groups have helped people and they live better, their morbidity is lesser. And hostile attitude, being very increased, we all know increase cardiovascular risk. Is there evidence? So the best I could look for, there are many, I can't go, see now the problem with this is there is no control, there's no placebo control for these studies. How do you look at, so there are different techniques. Should we use one technique? This technique is enough to get this outcome from this disorder. So what are the things? There are 28 systemic reviews. There's close to 2.5 lakh patients who have been tried different techniques, relaxation technique, yoga, meditation, hypnosis, and so on and so on. The best evidence especially is for blood pressure, pain. Moderate evidence is available for other techniques. The limitations of trying to do studies like this is you can't compare one procedure with the other procedure. No study is there, we're comparing this procedure, relaxation is better, or can we do mindfulness or something, or yoga is better. You can't do this. There's a lack of data in it. But there is enough evidence to say that there is considerable evidence that array of mind-body therapies can be used as effective adjuvants to conventional medical treatment for a number of common clinical conditions where they can work. Cancer, blood pressure, asthma, coronary artery disease, obesity, pain, insomnia, diabetes, IBD, fibromyalgia, menopausal symptoms, perimenopausal, anxiety, depression, rheumatoid arthritis, and other autoimmune conditions. That means we should look for, apart from traditional medical management, probably look for all of these techniques, some of them which can be, act as adjuvant in helping heal the patients. So to conclude, mechanisms may exist by which brain and central nervous system influence immune, endocrine, and autonomic functioning, which is known to have an impact on health. Multi-component mind-body intervention that includes some combination of stress management, coping skills, cannot cope with this work. I've seen so many people coping with this work, cognitive behavioral interventions, relaxation therapy, maybe appropriate adjuvant treatments for coronary artery disease and certain pain-related disorders such as arthritis. Multimodal, multi-mind-body approaches should be combined and used as adjuvants for many chronic conditions. An array of mind-body therapies like imagery, biofeedback, hypnosis, relaxation, when employed pre-surgically, may improve recovery time and reduce pain following surgical procedures. So, hope this hypnotherapy, visual change, all of these guided image, they're all were new to me. I knew some of them, but thanks to Dr. Vijay Kumar, he helped me learn last 3 days. Spent a week trying to put in everything. I thought to introduce the topic and just to say that something else is available to all of you, I could put a brief presentation for all of you to understand. I have not had any real-time experience in trying to deal with these therapies. The natural healing force from each one of us is the greatest force in getting well. We've seen patients, you think his prognosis is very bad. You'd be surprised we have not offered everything, but he's doing well. So maybe, thank you for your mind, for your body being present here. I don't know if your mind was there. Thank you.
Thank you, sir. That was a very beautiful presentation on the link between the mind and body. The floor is open for discussion.
Yeah.
We have time for 2 questions.
Sir, it was very nice presentation, sir, and it is very new to me also. Sir, my only doubt is whether there are any guidelines like physical activity, like we say 150 minutes per week like that, whether there is any guidelines like this much time we should do the meditation, like minimum or maximum benefits? Like
I think we should evolve. There are guidelines. You can say how much of time you can do. Some people do it for long periods. There's no specific guideline, like say 30 minutes, 40 minutes. Try following this. When they see the benefit, they will increase the time, so on, in the same type of thing. I really don't know up to what time you have to do this. Hypnosis, I don't think you can do a time. Biofeedback, only relaxation. You are relaxed, you do it for some more time, that's it. Meditation, there's no time limit for that. I'm not. According to your age, yeah. You have, and it's not easy to meditate, can you? I'm not sure. I'm not sure, I've tried it, but I've miserably failed.
Good evening, sir. Thank you very much for bringing in this aspect in the patient's care. I have one addition and one deletion. And one addition is, I think, a good sleep is a must for all these as a background. And another one is, maybe the government pushing more of Ayush-based therapies. We have to keep our boundaries very clear, as WHO states them as complementary medicines. And I think preferably scientific person should guide the patients to take up all this, because as we are facing now with reversal of diabetes, a lot of fake things are also coming and we are facing real issues. I think we'll have to set clear boundaries between science and pseudoscience.
Yes, madam. That is why I just got the science and said, this is the basic evidence we have. The problem is we cannot compare which therapy is better. So that is where all of the social media is gung-ho over this wellness issue. So, because they are not accountable for anything. Here we're going to be accountable. I definitely understand Ayush is a different platform. Here they are only the different types of technique helping patients who are already receiving standard of care as an adjuvant. I made it very clear, it's an adjuvant therapy. So mind-body medicine exists, and this is what is there.
Definitely, because stress has become the important causative factors for most of the lifestyle disorders. We do need such adjuncts, but only thing is with proper guidance. Thank you, sir.
I think there's certified courses. I don't know if they're available in India.
Sir, thank you very much for your kind explanation about mind and body in yoga. I am doing yoga, and they are a lot of pleasurable things are there. Last month we presented yoga control heart failure. You mentioned about that. Doing yoga for 3 months, definitely it controls the heart failure in a reasonable way. So there is a lot of things. That is only thing, main aim is they control the parasympathetic nervous system, stimulate the parasympathetic nervous system. All stress reactions are controlled, everything be controlled, the disease also controlled.
Yes, sir. Thank you for your comment. Thank you, sir.
To be in short, a primary care physician or whoever the physician should have a very good interaction with the patient, with history. Then he will come to know that what type of the mind and body procedures will help the patient. That is more important. We don't spend time with the patient. We just write prescriptions for one thing. Therefore, we are unable to go into the total family history. The background may be his environmental one, or a social one, or a financial one, depressive one. Therefore, all these factors should be taken into consideration initially. Then you go for the alternative mind and medicine. Thank you.
Thank you, sir.
So with this, we conclude the present session. Moving on to the next session. We thank the delegates for your patient listening.
Thank you, Sanjay sir. Thank you, Chairperson. Now, as we move on to the next session, may I request Dr. J.C. Shekhar, Dr. Selvaraj sir, to take over the session, please.
Good afternoon, all of you. It's a great pleasure to be here with you, amongst you this afternoon and share an important session. And also, I thank Dr. Vijay Kumar sir and his team for conducting this beautiful conferences year after year. Novel topics, great speakers, great time. And not only that, his culinary taste is so different. He plans his menus with passion, and food is excellent here. So thanks to him. This is session 6. I invite Dr. Faraz Farishta for new strategies for detection and treatment of DKD.
So very good afternoon. It gives me immense pleasure to be here. I think, first of all, let me congratulate my senior and good friend, Dr. Vijay Kumar, for calling me here. Every week, what I do is, I'm out of Hyderabad speaking. The one thing which I am loving here is the audience. We see everything except the audience. We hardly are seeing audience nowadays. So I think 3 cheers to the entire audience, our entire colleagues who have come from morning and then listening and waiting for the real science. So today I'm going to speak on, I think in years, if we have nephrologists here, I don't know if we have nephrologists here, if I had to ask them a decade before that what are the treatment options available to treat diabetic nephropathy over a period of year, I think that is where science did not progress. There were ACE inhibitors, there was ARBs, there was nothing much. After a long gap, then came the SGLT2 inhibitors, and now we have the pillars of treatment. Now, I'm going to talk on one of the most important pillar of treatment. So why it is important to diagnose diabetic kidney disease in your patients in early stage? You will see it shortens the life expectancy by 16 years. So if somebody is having only diabetes, their life expectancy is reduced by 6 years. Only kidney disease is around 11 years. When they have it together, it is 16 years. So this speaks volumes that it is very important you diagnose it early. I know, how many of you here follow cricket? All? Oh, lovely. I think 2 years before I was speaking at Dr. Mohan sir conference, that time I could see very bare minimum hands, but I'm happy. If you have to pick a team, I know both of them, there's nothing much this year, both of them are not doing anything. They are trying to compete from below. One is trying to dominate the other. I think they are playing for each other. So, why do you think they are losing more matches? Cricket is a game where you need more and more dependency on the entire team. You need all-rounders. You don't need one player. You need multiple of them to perform so that you get the desired results. Similarly, when you talk about diagnosing a diabetic kidney disease, you just cannot be dependent only on one parameter, that is eGFR. I think, yes, we did a good job. We moved from creatinine to eGFR. At least I think all of us are doing that. We understand why it is very important. Next, now it is time that you also include the UACR, because you will see most of these KDIGO guidelines, all these guidelines say that you have to do both of them, the eGFR and the UACR. So it is very important that you do it in your diabetic kidney patients. So in our routine practice, yes, I think all of us, including me, and then now I would say with most of us using the EHRs, using the electronic records, the moment you put creatinine, the age, the gender, it automatically, your software calculates and tells you what is the EGFR of that patient. I think we all are getting it. Most of us, if you're using the platforms, you will see it will give you that. What I want to highlight here, you will see patient A, B, and C. Patient A, male, 68 years, creatinine 1.3. One glance, you will say, okay, this looks good. Yes, the risk of CKD is low. You see patient B, 1.4, just 0.1 milligram difference. You see the EGFR going down, and then risk of development goes into the moderate risk. If you see a female patient with even 1.3, here you will see the EGFR is on the lower side and the risk is very, very high. So that this tells you at same creatinine levels, male and females, because of the multiple body weight and other conditions, the EGFR differs. So it is very important that we move ahead out of the creatinine and look for the EGFR and the proteinurias as well. We all have understood and we all know that UACR is a very, very important parameter when you treat your diabetic patients, because it gives you the earliest indicator of endothelial dysfunction. So any patient who has a nephropathy, they are prone for developing cardiovascular disease, or they may already have one. So if you are diagnosing somebody with a nephropathy, it is mandatory that you screen for the underlying cardiovascular disease as well. Here you will see the all-cause mortality and the cardiovascular mortality keeps going up as the UACR also keeps going up. So yes, as I was saying, most of the guidelines now says you do both the EGFR and the UACR every 1 year. I think as a clinician, we know it is burden to the patients. We just can't keep on repeating the test all the time. So if the patient is come to you for the first time, do it. If he does not have any of these problems, then you can do it annually. Let me come to a theoretical case. So this is again a typical diabetic patient having diabetes for more than 13 years, duration of CKD of 5 years. Baseline EGFR is around mild to moderate dysfunction. Serum potassium is okay. UACR, here you will see a patient is on the moderate side of proteinurias and has history. So as I was saying, they may have a cardiovascular disease. This patient already has developed a peripheral arterial disease. So what happens if you have to risk stratify this patient, and if you just do the EGFR, you will see that this patient falls into G2A1, so which is on the green zone. So the growth zones, I think all of us know that the lights, green, yellow, and red. So green is the safest zone. So if you just calculate on the EGFR, you will see the patient is on the green zone. But if you add a UACR, you will see the patient has gone to the yellow zone. So this tells you very important that just not do the EGFR, but also do the UACR, so you can do the better risk stratifications of your patients. CKD and CVD progression in diabetes is driven by many factors. One, metabolic, yes, poor glycemic control. Hemodynamic, even an elevated blood pressure is a risk factor for diabetes, kidney disease and CVD, and inflammation and fibrosis. So as we are talking about omnious octet of DeFranco, where you say there are 8 pathophysiological mechanisms leading to diabetes, similarly, it's not just sugar, it's not just blood pressure, it's not just one parameter. So there are different parameters leading to the complications. MR overactivation is thought to be a major driver of end organ damage through inflammation and fibrosis. I think that is where this new molecule plays a major role, because it acts on the mineralocorticoid overaction. You will see it does the kidney damage, it does a vascular damage, it damages the heart as well. So this patient is again typically on glimepiride and metformin, is on a SGLT2 inhibitors, is on a ARB. So two pillars of treatment for your diabetic nephropathy. The patient is already on both of them. But what here we all have to understand that despite the RAS blockade and SGLT2 inhibition, patients with diabetes CKD are at risk of CKD progression. So you have reduced the risk. Definitely, when you give an ARBs and SGLT2, you have reduced the risk, but they are still at risk of further progression because of the inflammation and fibrosis where these two molecules do not act. So finerenone is a selective non-steroidal mineralocorticoid receptor antagonist. It blocks the mineralocorticoid receptor overactivation, slows the kidney and CV disease progression. I think if you will see, it acts at the hemodynamic factors, it acts at the inflammation, it helps to reduce the albuminuria as well. So what's the difference between a normal aldosterone antagonist and finerenone? You will see, as I told you, it is a selective. That is why I'm going back. It is selective. So that what happens when you give a selective drug, unlike your other drugs, which will overshoot and act on different other parameters and may lead to other side effects as well, here you are bound to be on the safer side. And definitely you will see the beneficial effects as well. There have been two major studies done with finerenone, the Fidelio DKD and the Figaro DKD. I know post-lunch sessions, your glycemic levels are very high. It becomes very difficult to absorb these. So I will not go deeper. I will see that all of you are awake so that my next colleague who is going to come can continue it from there. So these are the two studies basically which were done with finerenone. And Fidelity was the respective pooled analysis of them. So what is Fidelio? Just if I have to give you the one line, it was done to see the time to kidney failure sustained EGFR. So it was basically done to see the progression of the diabetic kidney disease. Figaro was done to see the cardiovascular death and non-fatal MI risk in these patients. So one was done for kidney, one was done for heart. And Fidelity is a pooled analysis of both of them. So it's very simple. The beauty of this is you will see across, right from mild to severe proteinurias, all of them were included in that. So it is your diabetic kidney patient when you treat, somebody comes with mild proteinurias, somebody comes with moderate, somebody can come with nephrotic rich proteinurias. So the beauty of these trials was it included everything. So it's almost like your clinical patients which come to you day in and day out. So the pooled analysis, the Fidelity, you will see the composite CV outcome. There was 14% relative risk reduction in the CV end outcome and 23% relative risk reduction in the kidney outcome. Finerenone reduces the UACR by 32% between baseline and month 4. I think all of you should just see here. Within 4 months, there is reduction in proteinurias. I think I spoke to a few of my nephrologist friends who've been using it more frequently. They said they saw the reduction within 6 to 8 weeks. But what the data says is, at 4 months, you see the reduction which is happening, and then you see over the period that is sustained, which is very important. So proteinuria reduced, but it continued. So there was no again rise in proteinurias which happened over a period of time. So finerenone improved the cardiovascular and heart failure outcomes versus the placebo in CKD and type 2 diabetes. 22% reduced risk of first hospitalization for heart failure, 32% reduced risk of new onset heart failure. So if you have a diabetic patient with CVD, this is one of the other drug of choice. Again, if I have to ask you, some of you may say that probably SGLT2 was added, so that might be the reason for reduction in proteinurias. So here you will see reduction in the UACR without baseline SGLT2 was 31% as an individual, and when it was added to the SGLT2, it was 37%. So even without SGLT2, it did help in reducing the proteinurias and preventing the further progression. This is a real world evidence in UACR when combined were given. So now what we have to understand, we were giving ARBs, we were giving SGLT2 inhibitors. Still, if the renal progression is happening, you will see when you give it combined, proportion of patients with more than 50% reduction in UACR, 96%. So when you are adding it as a third drug, definitely you are preventing the further progression. Coming to the adverse events, yes, hyperkalemia still was the problem, but you will see it was not a clinically significant problem. So coming back to our patient who was already on SGLT2 inhibitors and ARBs with proteinurias and reduced eGFR, this drug was started, and now you will see the pillars of treatment. So we are now talking about pillars of treatment of heart failure. We know there are 5 drugs. So pillars of treatment for diabetic kidney disease, you will see the RAS inhibition, the non-steroidal mRNA, and the SGLT2 inhibitors. All the 3 are now stratified or classified by all the guidelines. You will see the KDIGO guidelines, the European Society of Hypertension, they say these are, all the 3 should be used for patients with diabetic kidney disease. So how do you start it? The target dose is 20 milligrams. You start, if somebody is having a eGFR of less than 60, then you start with 10 milligrams and then escalate it to 20 milligrams after 4 to 6 weeks. If the eGFR is more than 60, you can straight away start with 20 milligrams. Most importantly, practically see that you do the potassium at the time of starting, because you should have a baseline of potassium when you are starting this treatment. So how do you start and adjust? You start with 10 milligrams if the eGFR is less than 60. Straight away go with 20 milligrams if the eGFR is more than 60. Monitor serum potassium at first month and then every 4 months interval. Adjust the dose. If serum potassium is less than 4.8, you can increase to 20 milligrams. Continue with 20 if potassium is less than 5.5. If potassium goes above 5.5, then stop the drug and restart when your potassium level goes below 5. So this is a very important clinical way. How do you start? How do you monitor the potassium? When you should stop? So here you will see in that same patient when it was started, the UACR reduction happened from 105 to 53. 50% UACR reduction was seen over and above the ARBs and the SGLT2 inhibitors. So to summarize in the end, diabetes patients we know have high risk of developing cardiovascular disease, high risk of developing chronic kidney disease. So it is important that you check for the UACR and the eGFR yearly once. Finerenone is recommended to reduce the risk of heart and kidney failure in diabetic patients with CV and kidney benefits irrespective of the glycemic benefit. So it directly...
To you? No, I'll come down and talk to you because I need to go. So we'll walk and talk. Thank you.
Thank you very much, madam, for a wonderful lecture. Thank you, sir, for a brilliant presentation. We really enjoyed. I thank the organizers for having made us to learn so much from today, and tomorrow also is there. We welcome you all for tomorrow morning presentation. Thank you very much, sir.
No problem, no problem. Are these contestant winners are here? Dr. Jayashree Krishnan I could see. Please come, madam. Dr. Deepa is here, Dr. Revati, Dr. Shamala. Maybe tomorrow if they are, otherwise they are unlucky to get this. Very good textbooks and everything we are giving. No? Nobody.